For this session on updates in neonatology, I invite chairpersons Dr. Hemant Sate and Dr. Deepthi Deshmukh. I also invite the first speaker for this session, Dr. Anita Haribalkrishna on HIE update.
Hello. Good morning everybody, and welcome to the opening session of the day 2 of Mahanecon 2023. The topic is HIE, hypoxia, means decreased supply of oxygen to the tissues, ischemia, inadequate blood supply to the organs, geoparalyzing the physiological function, and the encephalopathy. To tell you few facts, to emphasize what is the importance of this lecture, about 25% of the cases die in the first week of life, and amongst those who survive, about 15 to 20% are left with neurological deficits. And the neurological damage is directly proportional to the time of injury to the baby. Needless therefore, and the incidence in developed countries is about 1 to 8 per 1,000 live babies, and about hovering around 26 in the developed countries per 1,000 babies. Needless therefore to say to you that we have to enforce our activities in order to decrease the incidence of HI. And therefore to highlight and update you on this HIE management, may I invite Dr. Anita Haribalkrishna to the dais to unfold the mystery of HIE. Please, ma'am.
Yeah, a very good morning, everyone. And I'm first of all thankful to the organizing committee to invite me on behalf of KM Hospital Department of Neonatology. So without wasting time, so we will run through a quick update of HIE in newborns. So objective will be overview of HIE in neonates, pathophysiology, treatment options, evidences. So we all know that first 100 days in NICU is a window of opportunity for turning coffee beans into walnuts. So HIE is all known fact, a form of neonatal encephalopathy in term and late preterm infants with severe acidosis or need for resuscitation at birth, with abnormal neurobehavioral state characterized by seizures or abnormalities in consciousness, tone, posture, and reflexes, evidence of an acute perinatal or sentinel event, with characteristic neuroimaging findings and exclusion of other causes of neonatal encephalopathy. So coming to the epidemiology, it is seen in approximately 2 to 3 per 1,000 live births all over the world, with 26 per 1,000 live births in developing countries. 24% die in NICU. Remaining neonates may be diagnosed with cerebral palsy, visual and auditory problems, motor and behavioral damage, such as epilepsy, global developmental delay, and autism. So there are causes. We all know about the prenatal, perinatal, and postnatal factors which affect babies leading to HIE. So the areas affected in the brain differs in preterm and term infants. So preterm infants, basically pre-oligodendrocytes are affected leading to white matter injury, whereas in term infants, basal ganglia and thalamus are affected, causing perirolandic cortex and gray matter injury. Also there is parasagittal and border zone injury as well. So coming to the pathogenesis, I'm just going to a quick run. So there is a primary phase up to 60 minutes, followed by latent phase 6 hours, where there is oxidative metabolism, inflammation, and starting of the apoptotic cactate. There is secondary phase which lasts more than 48 hours, where there is depletion of the phosphate reserves, followed by tertiary phase, where there is late cell death and further damage of the brain. So we all know there is mitochondrial damage with the depletion of ATP, anaerobic glycolysis, and inhibition of sodium potassium pumps. There is further free radical production which further damages the mitochondria. There is nitric oxide synthase activation. There is further inflammatory response, which results in further phagocytic activity, leading to apoptosis. So coming to the current treatment options, we all know hypothermia is the worldwide standard of practice for treating any babies with moderate to severe HI. So it is the safest method which acts through increasing the cellular acetylation. There is suppression of the caspase and other apoptotic mechanisms, and it has become the standard treatment, and it started within first 6 hours of life with a temperature of 32 to 34 degrees Celsius, whole body hypothermia for 72 hours, followed by slow rewarming for up to 6 to 12 hours. So safety and tolerability of rewarming protocols is not proven yet in clinical studies. That is one concern. And also, the recurrence of de novo seizures on rewarming is also being reported. So coming to the studies, so we all know this first study that was done in 1998 by Gunn et al., selective head cooling in newborn infants after perinatal asphyxia. It was a safety study, and which concluded that mild selective head cooling combined with mild systemic hypothermia in term newborns after perinatal asphyxia is safe. So people accepted the fact that hypothermia is safe. Then comes the famous CoolCap trial by Gluckman et al. It was published in 2005 in Lancet, selective head cooling with mild systemic hypothermia after neonatal encephalopathy. It was a multicenter randomized trial. And they also found that head cooling is not protective in a mixed population of infants with neonatal encephalopathy. It could safely improve survival without severe neurodevelopmental disability in infants with less severe amplitude integrated EEG changes. Then now comes the NICHD trial by Sita Shankaran et al. That was published in 2005 in NEJM. So which concluded that whole body hypothermia reduces the risk of death or disability in infants with moderate or severe HIE. So we know the famous TOBY trial, by total body hypothermia for neonatal encephalopathy trial, which was done by Asopadi et al. And in their study they found that induction of moderate hypothermia for 72 hours in infants who had perinatal asphyxia did not significantly reduce the combined rate of death or severe disability. But the results show that it resulted in improved neurological outcomes in survivors. So that means that hypothermia still should be conducted. Now next trial RCT, that was a neo-neuro trial which was by Simbrunner et al. This study also looked at the effects of efficacy of whole body hypothermia, which showed that there is strong neuroprotective effect with the hypothermia, and it is effective in severe HIE groups. So another study, selective head cooling with mild hypothermia after neonatal HIE, a multicenter randomized trial that was conducted in China. It was published in 2010 in Journal of Pediatrics, which showed that 72 hours hypothermia may significantly decrease the combined outcome of severe disability and death, as well as severe disability. So Susan Jacobs has done a study, a randomized trial before her Cochrane review, which showed that whole body hypothermia is effective and appears to be safe when commenced within 6 hours of birth at hospital in term and near term newborns with HIE. So these are all the studies which we discussed just now. So what we can see that there is a decrease in the cerebral palsy among survivors of HIE in randomized trials of hypothermia. We can see in these boxes, TOBY trial, neo-neuro trial, and ZOO study, which showed definite significant reduction in the cerebral palsy in these survivors. So this is a further Cochrane review that was published in 2013 by Susan Jacobs for same cooling for newborns with HIE. There is evidence from the 11 randomized trials in this Cochrane review that therapeutic hypothermia is beneficial in term and late preterm newborns with HIE. Cooling reduces mortality without increasing major disability in survivors. So with that, all over the world, hypothermia started being used for treating babies with moderate to severe HIE. So further, TOBY group had further done in mid-childhood the long-term neurodevelopmental outcomes of these babies who were treated with hypothermia. And they found that moderate hypothermia after perinatal asphyxia resulted in improved neurocognitive outcomes in middle childhood. Similarly, Sita Shankaran et al., the NICHD group also did a mid-childhood neurodevelopmental evaluation, which showed that the rate of combined endpoint of death or an IQ score of less than 70 at 6 to 7 years of age was lower among children undergoing whole body hypothermia than those among usual care. But although the difference was not significant, there was a trend towards reduced cerebral palsy and reduced neurodevelopmental outcome in mid-childhood. So what about hypothermia initiating as early as possible, within 3 hours of life? That was done by Marianne Thorsen et al. And was published in Neonatology in 2013, which showed that therapeutic hypothermia is safe and significantly improves motor outcomes. Cooling should be initiated as soon as possible after birth in eligible infants. So, neurodevelopmental outcome in neonates with HI in secondary care centers. We discussed about tertiary care centers. What about in secondary care centers or primary centers, whether we can start hypothermia? This study was done by M. Batta et al., which showed that the relatively low prevalence of disability at 18-24 months suggests that use of hypothermia in level 2 nursery is feasible and possibly beneficial. So, we can even do hypothermia in secondary level centers from this study. This is a famous HELIX trial that was published in 2021 Lancet by Thayil et al., which was controversial in low and middle income countries. We all know about it. So this study showed that therapeutic hypothermia did not reduce the combined outcome of death or disability at 18 months after neonatal encephalopathy in low and middle income countries, but significantly increased the death allowance. So that was alarming, and people were confused whether to give hypothermia in low and middle income countries. Of course, majority of the study participants were from outborn patients, and also there were a lot of sepsis also being reported, and hypothermia was moderate. The babies who received hypothermia were also hypothermic. So all those were the factors that could have contributed to significant morbidities in these and mortality in these babies. That was a conclusion derived from further studies. So this is a study, thin study. There is a therapeutic hypothermia trial that was done in India itself by Acker et al., which was published in 2020 in archives, which showed that therapeutic hypothermia induced by phase-changing material. They have used phase-changing material, not servo control mode, and reduced brain injury detected on MRI in infants with moderate HI in an ICU in India. Similarly, Catherine et al. Has done another study which was published in Journal of Tropical Pediatrics in 2020, which showed that in term infants with HI, therapeutic hypothermia reduced mortality and neurological abnormalities and results in more normal survivors. So these are small studies, but RCTs from single center studies, but further studies are required with babies, inborn patients, and also those babies with being normothermic or not hypothermic at time of starting hypothermia to come at a conclusion whether we should stop in LMIC countries. So till that time, we should continue giving hypothermia. This is a systematic review and meta-analysis of randomized trials recently published in 2021 and +1, which showed that therapeutic hypothermia reduces the risk of death in neonates with moderate to severe HI. Both selective head cooling and whole body cooling are effective in reducing mortality in infants with this condition. So is there a need for hypothermia in mild HI? So so far we concerned about the moderate HI. So in mild HI, so the evidence, this is a famous prospective study which was conducted to just, without hypothermia, they just see what is the neurodevelopmental outcome at 18 to 22 months for babies with moderate to severe HI, and they found that there is in mild HI group, there can be 16% babies with neurodevelopmental morbidities. So yes, mild HI also warrants treatment. That is a conclusion derived. Following this, there is insufficient evidence on this. So there are a lot of studies coming up. There is a famous COMET trial, TIME study, COOL Prime study. They are still in the recruitment phase. When the results come, we'll come to know that whether mild hypothermia babies should be cooled or not. So now to late onset hypothermia for long duration. So whether we can give hypothermia for babies more than 6 hours later, up to 12 to 24 hours, and also for long duration, more than 72 hours. This is the effect of hypothermia done on the same by Laptuk et al., which was published in JAMA in 2017. You can see that definitely in the treatment group, hypothermic group, there is definitely better outcome, means morbidity, that is mortality and neurodevelopmental outcome was better in this group. And they concluded that among term infants with HI, the hypothermia initiated at 6 to 24 hours after birth, compared with non-cooling, resulted in a reduction in the death or disability. This is a famous study by Sita Shankar et al., looking for the effect of depth and duration of cooling in babies at 18 months, those with HI. It was a randomized trial, which found that among term newborns with HI, cooling for longer than 72 hours, cooling to lower than 33.5 degrees Celsius or both, did not reduce death or moderate to severe disability at 18 months of age. However, the trial may be underpowered, and an interaction was found between longer and deeper cooling. So that may be the reason why we are stopping the cooling at about 72 hours of age. This is a famous position statement and guidelines by many of our senior faculties have done from NNF for use of therapeutic hypothermia to treat neonatal HI in India. So we all know that what we can conclude is that hypothermia is likely to decrease death or severe disability and cerebral palsy at 18-24 months, even in LMIC, as compared to HIC. And the pooled estimate for mortality prior to discharge showed a significant benefit in favor of therapeutic hypothermia in HICs. Mortality before discharge, when analyzed for infants with moderate to severe HIE with core pH less than 7, showed no significant heterogeneity in studies from both LMIC and HIC. So definitely there is favorable evidence for therapeutic hypothermia. In units with hypothermia at admission and unclear evidence of severe intrapartum asphyxia, that is core pH when it is more than or equal to 7, or it is not available in LMICs, there is uncertainty of the benefit from therapeutic hypothermia. So all these tells that therapeutic hypothermia should be continued. So there is ongoing trials in late preterm infants by same NICHD group, whether it can be given in babies of 34 to 36 weeks. So the result is yet to be published. Now other drugs like melatonin, we all know that melatonin is an indolamine which has got anti-inflammatory and anti-apoptotic mechanisms. And there are studies for the use of these ongoing researched drugs, like whether it can help in neuroprotection in babies with HI. So they saw that the melatonin group had fewer seizures and less white matter abnormalities on MRI. At 6 months, the melatonin group had improved survival. So they concluded that early administration of melatonin to asphyxiated term neonates is feasible. Similarly, allopurinol, so it is an xanthine oxidase inhibitor. So there is a study by Candop et al. Which was published recently in 2017. And we can see that neonatal allopurinol treatment may lower the risk of death or severe disability in long term. Neonatal treatment with high dose allopurinol does not have negative side effects. So else it is also feasible. Similarly, for magnesium sulfate, so antenatal magnesium sulfate on effect on neurodevelopmental outcome, there is definitely decrease in cerebral palsy in mothers who have received antenatal magnesium sulfate. This also study shows that favors magnesium sulfate. You can see that from the forest plot. This is another study by Tagin et al. So erythropoietin, whether we can give erythropoietin for neuroprotection in HI. This is a study which was published in Pediatrics in 2020, which has shown that effective erythropoietin is also can be safely given in babies with moderate to severe HI. So this is a famous trial that was published in NEGM by Wu et al., trial of erythropoietin for HI in newborns. This study also shows that death or neurodevelopmental impairment was better, was reduced in babies who received erythropoietin along with hypothermia. So N-acetylcysteine is another drug, but animal studies are going on. Still further studies has to be done. Topiramate is another drug where safety study is being conducted, which shows that topiramate also is effective. This is a famous neonatal trial which was done by Filippi et al., which showed that it is feasible to use topiramate along with hypothermia for babies with HI, which will reduce the neurological impairment. This is a famous Toby-Sinon trial which was published recently in 2016 in Lancet by Azzopardi et al., the Toby group et al., which showed that definitely those with Sinon along with hypothermia, there is administration of Sinon is definitely safe. So further studies has to be done on the same topic. Then last one, finally, can stem cells cure hypoxic newborns? So a lot of animal studies are there which showed that yes, it is feasible. There is less neurological damage with using stem cells in animal models. So hence, neuroprotective effect of mild hypothermia combined with stem cell transplantation are superior to those of monotherapy. So finally, restricted fluid therapy in HI. So whether there is requirement of fluid restriction in babies with HI. This is a famous study that was done by Journal of, Taniga Sulan et al. In Journal of Perinatology that was published recently in 2018, which showed that restricted fluid intake did not reduce the composite outcome of neurodevelopmental disability and death, and was associated with a trend towards more hypoglycemia. So there is no need to restrict fluids. That was a study taken. So we have just completed our study. It's yet to be published. That was going on for past 6 years. So our study also showed that the primary outcome of mortality or severe neurodevelopmental disability at discharge was not different among the babies who had restricted fluid and normal fluid group. So key points from my talk is that neonates with HI present with characteristic physiological and biochemical findings. And presently, therapeutic hypothermia is accepted treatment modality for HI. Research is ongoing to determine the effect of hypothermia in mild HI. Clarification of definition of HI needs to be done, and further study for long-term outcomes is likely to improve the care of newborns with HI, and there is definitely the role of comprehensive follow-up. Thank you.
Thank you, Dr. Anita Haribalakrishna. To deliver the next talk on preterm neuroprotection, I invite Dr. K.P. Sangvi.
Hey, good morning, Solapur. Good morning, Chairperson. So I like to display shamelessly this hobby of mine where I click wildlife photographies. This time I'm using birds. Life makes more interesting than all the stress of the NICU. So this is a white-throated kingfisher, clicked I think in Solapur last time when I came. So basically neuroprotection has been defined as strategies capable of preventing neuronal cell death. Neuroprotective strategies are interventions used to help the developing brain to decrease neuronal cell death post-injury. So this is what neuroprotection is all about. And please remember that fetal brain grows 5 times in the last trimester and the surface area grows by 3 times. The child is out, there are key events which are supposed to occur before the child is born in the gray matter and the white matter, the growth of the gray matter and the white matter. But when the child is delivered from the safe presence of the intrauterine environment, which protects the child from all the external stimulants, this child is suddenly into the NICU, which is one of the most hostile environment, I should say. And there is an interruption of the normal brain development. This child whose brain was supposed to grow in the safe environment is now in a very harmful environment, and the interruption of this sensitive process compels a brain development to take a different trajectory. And the consequence of is that the neurodevelopmental impairment affects multiple domains. It's not only motor, but also cognitive and language. So all these less than 28 weekers infants or less than 32 weeks, they do have some telltale signs of neurological morbidity, most of them, 5 to 10% will have cerebral palsy, almost half of them will have some form of neurological handicaps, and even subtle neurological behavioral disturbances and intellectual disabilities. There are 4 types of brain injuries which we normally see. Intraventricular hemorrhage, all of us know. PVL, all of us know. There is a recently diffused white matter injury, which is also known as encephalopathy of prematurity, and it consists of primarily acute cell death, myelination failure, and disturbed connectivity and maturation of the CNS. The last is the dysmaturation, again a recent concept of neuronal and glial precursor cells. That means it's something akin to the new BPD, which the development is not in the right way. So as is the convention, to start with a case, and this is a G2 26-weeker severe PIH, reverse end diastolic flow, coming somewhere from 50 kilometers away, landed in our hospital, and I was called. I said, "Pehle beta metazone do, baad mein baat karenge." So first was beta metazone given. I didn't know much of the history, but I said, "First give beta metazone." And then when they told me the history, I requested to buy a few hours, told the obstetrician, "Give Maxelf." We gave Maxelf. This child was born, gave us quick. So I said, I was happy, baby is breathing. Delayed cord clamping karo. As we were doing it, we saw the baby had stopped breathing. I said, "Clamp, clamp, clamp." Move the baby under the warmer, intubated, IPP done with, of course, SpO2 monitoring. And then once we stabilized, moved the baby into the NICU. Birth weight was 440 grams. 1 dose of surfactant was given. We did targeted ventilation, volume targeted ventilation. NIV CPAP took about a month to do all these things. But at the end of it, no IVH, no sepsis, no ROP, no NEC. And as we were monitoring one day, if you can see on the left side, this baby took out her hand from in between the cling wrap and I remembered Bahubali. So I called this child Bahubali, the female version, but Bahubali. So this is a yellow-footed green pigeon, and premature infants post-delivery are subjected to sensory experiences that are inappropriate for their gestational age. So a child who was supposed to, I'm being repetitive because I want to stress this fact, that a child who was supposed to grow in the uterus is out and the brain is also growing out. So the NICU is a source of constant inappropriate sensory overload, lights, noise, painful, Dr. Sangvi shouting. As clinicians, we tend to concentrate more on physical and motor disorders as they are more noticeable. But preterm infants are also at greater risk for cognitive, behavioral, speech, language, autism, etc., etc. Sorry. So these are the 7 core measures propagated by Altimer and Phillips from California. They published it in 2013. But when I finish with this talk, please have an introspection and how much of this we are doing in our NIC. We talk about intact survival, but everyone talks about pharmacological survival. I am talking about non-pharmacological survival. Of course, I will talk about it provided I get some more time. But this is, I thought, probably the most important part of newborn brain neuroprotective care. So these are 7 core measures for the sensory protection, neuroprotection of the preterm infant. This framework should guide clinical practice in our NICU. We will have to undergo a cultural or a paradigm shift in our attitude and working in the NICU. How do we do it to effectively implement and adopt these neuroprotective measures? So the core is the healing environment. This addresses the 5 sensory organs of touch, light. There's so much of light in the NICU. Do we follow the day-night protocol? Do we allow natural light to come in? Do we dim the light in the night? Or the lights are full on? This hurts the eyes. When you dilate the child's pupil for ROP, have you ever thought how much light must be entering this child? I realized it when I got my pupils dilated for my cataract. And believe me, I had to call my daughter that please come and fetch me, I cannot drive, it's so bad. And we subject this child to that bright light. Sound, alarms are blaring, going away. Sisters are just doing their writing work, bang, 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 it goes on. And any NICU call, anyone, believe me, you will be hearing the sound of the alarms. The consultants coming and talking loudly, sometimes shouting. I'm guilty of that. But I remember when I was undergoing my training in the early 90s in neonatology in Australia, the nurse had the gumption of telling the director of NICU, David, please move back, you're speaking too loudly, my baby is getting disturbed. Idhar hota to pata nahi, where would have that nurse gone to the moon or somewhere else, I don't know. But that is the kind of care we need to take. Taste, we have to make this baby taste as soon as possible, colostrum, EBM, NNS. Smell, we have to instruct the mothers, of course our mothers may not do it, but not to use perfume when they come to meet their baby. Give them KMC, give them NNS, let them smell the mother's breast, milk, express breast milk. Touch, pain, touch, temperature. Temperature should be well maintained, thermoneural. Touch should be a soothing touch of the parent, just don't grab the baby to do a heel stick and hit it. And pain I will talk afterwards. So then comes to the first petal, that is the position and handling. Position should be midline with head and elevated and neck in slightly extended position, never flexed. Handling should be done very gently, especially the nurses when doing all these procedures, IV, all this. Sleep, both REM and NREM sleep are important. we should allow at least 60 minutes of a cycle, sleep cycle before someone disturbs the baby. Routine cares as far as possible, let them be cue based, do them when the baby is awake. Minimizing stress and pain. Now, analgesia in the NICU is the least used, it's the least used. We are doing a heel stick, try to give some soothing to the baby before we do it. Putting in an IV, of course, major procedure, we are using local anesthesia. But for the small things, heel sticks with the child undergoes 3-4 times a day, intravenous, handling, changing diapers, just lift the legs, change the road. Don't do it very gently. Protecting the skin, don't use any extra taping. Be careful, burns from the monitors. And the nurses have the habit of doing a heel stick, putting a cotton and then a tape micropore. So then ripping off that also is painful. And it also opens the door for the bacteria to enter. Optimizing nutrition, I don't have to talk a lot about it. All of us know, and I think there is a panel discussion on it. But your protein and lipid intake should be there. Try to give more and more of express breast milk. Start early TPN. There's no debate, no doubt about that. Partnering with the families. Now, this is a very important aspect. When a woman becomes pregnant, she starts dreaming about her child and she has a vision that this is what my child is going to be. She starts dreaming about everything what she's going to do. And suddenly there's an onslaught of prematurity, and she at the moment she does not know what is happening, whether it's a cesarean or normal delivery. The baby is rushed into the NICU, and finally when she is coming to see the child is having lines. She can see everything else but the child. Lines, tubes, monitors, blaring away, and she's scared. What is she seeing? And this is, ये तो नहीं चाहती थी मैं, ये कहाँ से आ गया? So there is first an emotional detachment. So we have to show empathy, compassion, sympathy, get her closer to her child, make her feel the child. If we cannot give KMC, at least first 4 days in extreme premature birth, we would not advise KMC and NNS. And minimal handling, suction, avoid suction if you can. And then let the mother touch the baby, feel the baby, hold her hands, and then as the days progress, start with KMC, NNS as the clinical condition allows. So make that contact of the mother with the child. Remember, you are the first point of contact for them. You are like that Pandit jo milan kara raha hai. So please do that with lot of compassion. Now I'll come to, I think I've got my message clear. Now I'll go on. What, 13 minutes? This is an Indian pond heron. You'll see everywhere, from Solapur to Kolhapur, everywhere. So now the pharmacological or the other neuroprotective strategies which you're going to do. Sorry, I've got only 6 minutes. So antenatal steroids, 3 drugs which are beyond any doubt now, redemption like Cleopatra, without any doubt. So antenatal steroids, of course, there are people doing only to that also now. But the studies have shown that with observational studies and meta-analysis have shown that antenatal steroids increase survival, no effects on neurodevelopment and behavioral outcomes at 5 years. I have taken that off just to shorten my time, but there is no difference between DEXA and beta. That debate has been resolved. Just go ahead, whatever you have. There is decreased neonatal death, RDS, IVH, mechanical ventilation and sepsis. Steroids, besides promoting the maturation of the respiratory system and stabilizing the hemodynamic system, also has a stabilizing effect on the geminal matrix vasculature and vasoconstriction effect on the fetal cerebral fluid flow, and they also decrease the permeability of the vasculature. MAC-SELF, Anita had already alluded to it, but just to, there are 5 randomized controlled trial called the MAGPIE, MAGNET, ACTO, MAC-SELF or BEAM trial, I think. All these 5 came to the conclusion that magnesium sulfate does not affect mortality. This is an IPD analysis, but it reduces cerebral palsy to 32%, 0.68. It also reduces death and cerebral palsy combined, and the number needed to treat is 46. Delayed cord clamping, when we clamp the cord, we decrease the preload going into the right atrium and we increase the systemic overload because the umbilical artery shuts down. The first one is because of the umbilical vein. And then there is opening of the pulmonary vasculature, so blood goes into that. So by immediate cord clamping, we are decreasing the preload to the right atrium. Delayed cord clamping helps to replenish this preload and helps in the smooth transition from a parallel to a serial circulation. So we are all gung-ho about it. 18 randomized controlled trials, about 3,000 infants. Delayed cord clamping was found to reduce hospital mortality, low EPCARs, increase hematocrit, decrease need for blood transfusion. But what unfortunately delayed cord clamping did not do was reduce the incidence of intraventricular hemorrhage or brain injury. Then Himalayan bulbul. So antenatal done, intrapartum done, now postnatal. Breast milk, breast milk, breast milk. We are fortunate to have breast milk to save our babies. I'll go very fast. Now the breast milk intake increases the volume of deep nuclear gray matter, increases IQ, increases math, increases language and motor function. So breast milk, as far as possible, express breast milk is the way to go. Caffeine, so 3 drugs which are beyond doubt. One was antenatal steroid, surfactant, and third is caffeine. It is neuroprotective and protects, improves hypoxia-induced white matter injury. It potentiates little complicated language. Sometimes even I don't understand what they are saying. Synaptic plasticity. Plasticity is the ability of the brain to mold from in the right direction. By modifying neural synapses, improves auditory processing and enhances cerebral cortical activity. The CAP trial and the follow-up showed that death or survival with cognitive deficit is decreased with deafness and blindness, nearly half the rate of cerebral palsy. And then erythropoietin, all these drugs are always there in all trials of erythropoietin. Just to cut a long story short, this was the peanut trial. They recruited 941 infants, less than 28 weeks, more than 24 weeks to less than 28 weeks, and they did not find anything. So the conclusion of peanut trials, as far as neuroprotection is concerned, peanut trial said that erythropoietin is peanuts. Sham ko acha lagta hai. Postnatal steroids, again, sometimes in life-threatening situation we have to use them. So if it is used in less than 8 days in high-risk infants for BPD, it increases risk of abnormal neurological examination and cerebral palsy on long-term follow-up. But if the same are used in more than 7 days, it increases the risk of ROP, but decreases risk of severe IVH and death, and increased risk and abnormal neurological examination. So the thing is that treating preterm infants at a low risk for BPD will increase risk of cerebral palsy, but treating preterm infants at high risk for BPD and in the postnatal steroids will decrease the risk of cerebral palsy. So to choose very correctly, prophylactic indomethacin, Laura meant when she published in 1994, all of us were gung-ho. Unfortunately, it was not available in India at that time. But she found that indomethacin reduces the rate of intraventricular hemorrhage and PDA. So we thought probably we'll have better neurological outcome. The same were repeated with ibuprofen and acetaminophen, paracetamol. And there was no difference in severe IVH or mortality except for indomethacin, which showed decreased IVH, but there was no long-term neurodevelopmental benefits. Most of the units have given up prophylactic indomethacin. And this is the forest plot from Cochrane. No improvement you can see anywhere in the whole line. Hypercapnia, hypocapnia. Please maintain your CO2 levels between 45 to 55. Anything more than 72 or less than 32 is independently associated with acute brain injury. Your mode of ventilation, preferred mode of ventilation should be volume targeted so that you can control the CO2 better. And this is associated with decreased odds of severe IVH. I am not very fond of high frequency, but early use may cause sudden CO2 washout, vasoconstriction and damage to the brain. So, to you, inotropes, again we chase the blood pressure and we use inotropes, but it is now true that it's not associated with decreased mortality, it is associated with increased mortality, IVH and brain injury. Improving blood pressure and perfusion does not increase cerebral blood flow, and there was no benefit found whether there is cardiovascular compromise or not. This is the last slide. To improve neurodevelopment and mortality. So, do not treat hypotension unless associated with clinical signs of increased capillary refill time, decreased urine output, elevated lactates, and you have echocardiography proof that you need volume or vasopressors, and rule out iatrogenic causes by doing a chest X-ray, rule out hyperinflation, rule out pneumothorax. क्या अटक गया? Okay, so in this baby, what we did correctly in Bahubali was antenatal steroids. We got a single dose, magnesium sulfate. We did delayed cord clamping, whatever was allowed. We gave caffeine. We gave mother's own milk. We used targeted ventilation. No postnatal steroids. No prophylaxis for IVH. No vasopressors. And this was the end result. This child was 440, 1.5 when she left us, smiling. And this is. I am conceited. We got in the Times of India, and it was actually fortunate for me to be, but one of the smallest surviving babies. And this is a great barbet, very colorful bird. Thank you for a patient hearing in many, many languages.
Thank you, Dr. K.P. Sangvi and Dr. Anita Hari Balakrishna. Thank you, Dr. Hemant Sate and Dr. Deepti Deshmukh. Please proceed for felicitation. To move forward, I request Dr. Amit Tagare and Dr. Sudhir Mure to chair the second part of this session. HIE is one condition where point-of-care ultrasound plays an important role. To enlighten us on POCUS, I invite Dr. Vikram Hirekeru.
So, good morning everyone. This is the title of my talk. I have some declaration. Hello. So, to begin with, to the novice, I would just like to mention a few slides how an image is formed. Ultrasound waves are beam inside the body. Part of the beam is reflected back to the transducer. The machine processes it and gives you an image. There are different forms of image. It is a B mode, that is a brightness mode that we use normally. So structures can be black in color, which are fluids. They are anechoic. Structures can be white in color. They are tough structures like diaphragm and the pleura, fat, bone and air. They are hyperechogenic. Structures can be in different shades of the gray depending on the organs, and they are called echogenic. What are the challenges that we face day to day in the ICU? We face patients of respiratory distress, sepsis, cardiac failure, and CNS depression. So let us see how POCUS is useful in this. So this is the operated case of esophageal atresia with tracheostomal fistula, comes back after surgery, has a pneumothorax, surgeon adjusts the ICD and gives back the patient. Are you happy with this respiration? Obviously, no. So we ask the surgeon to do something. He says, no, I cannot do anything. So I show him this. So this is the normal lung. See the echogenic pleura and see how it is moving. Can you appreciate the sliding sign that was shown yesterday? And one more important sign is the B lines. These are the vertical B lines. This is a normal lung. Now see on the right side. Can you see the pleural sliding? No. Can you see the B lines? No. These are the telltale signs of pneumothorax. To confirm, we can do a B mode, M mode that I will show you later. So now I try to convince the surgeon, but reluctantly he comes and he changes the tube from 16 to 20. And now see what is happening. Can you see the change now? There is pleural sliding and there are vertical B lines, and so we are happy. What about the patient? The baby is also happy. No distress now. Late preterm, diagnosed as TTN on the basis of this X-ray, but is not improving as expected in TTN. So we do a ultrasound. Now can you see the pleural line here? The pleural sign is absent. And you can see the hypoechoic structure, and you can see white echogenic structure that is appearing and disappearing. This is the air in the pleura. Air, I told you, is white in color. Same position on the right side. So this was congenital pneumonia. We treated with higher antibiotics and got away. This is another case, HMD, elsewhere. Diagnosed as HMD, surfactant was given but did not improve. And this was the X-ray. So they transferred it to us. Now can you tell me anything? What is this? On the basis of previous slides that I showed you, no pleural sliding, no B lines. This was a pneumothorax. I confirmed with the M mode, which shows horizontal lines like layers of atmosphere stacked one over the other. This is a stratosphere sign. This is the same patient at another zone of the lung. You can see the black structure. This is fluid. And can you see these lines? They are appearing and disappearing. They are air in the bronchus, air in the airways that are coming in and going out with each phase of respiration. This is a sonologic air bronchogram that is similar to the radiologic air bronchogram that we are used to see. But here the lines are very close together, not distant, they are close together. This is because of the volume loss of the lung. This is collapse probably because of the effusion. We did a diagnostic tap using the ultrasound, and we found that this was a very thin, this is a gelatinous fluid. We contacted our senior surgeon, Dr. Vijay Patil. He said that this is probably a lung cyst which has ruptured. Another case of diaphragmatic hernia, clear cut, taken for surgery out of inquisitiveness. I was not knowing how diaphragmatic hernia is seen on ultrasound. I had seen only one case before. Can you make out anything? Yes. This was reported as pneumonia on CT scan. Patient was operated, this was left like that. CT scan was done 1 month later, still reported as pneumonia. I contacted the obstetricians, he said yes, they had reported it as normal and it probably later disappeared. So I forgot to tell you. That's what she said. So message, chest can be insonated as a misconception because air is an enemy of ultrasound. Lung ultrasound is better than chest X-ray to identify pneumothorax. Lung ultrasound is better than CT to identify cystic lesions. Ultrasound can be used for guided thoracentesis. So our next problem, sepsis. So this was patient. You can see an almost flash refill. Lethargic 150, but BP is 60 by 28. You see the difference in the pulse pressure. Can you make out the IVC? It is fully collapsing. The anterior and posterior walls of the IVC are touching each other. How is the heart? Heart is working more. It is hyperkinetic because it is not facing any resistance. The diastolic BP is 28. So it is not facing any resistance. This is the interventricular septum. Can you identify this interventricular septum? It is touching the posterior wall of the left ventricle, almost touching. This is called the kissing sign in echocardiographic parlance. This is a tricuspid regurgitation and the pressure is 36.8. And this is a 3.1 mm PDA. All this is fitting into a warm shock in the newborn. Now I did the ACA, anterocerebral artery Doppler, and you can see the velocities. This is the systolic velocity, this is the diastolic velocity. There is a large difference in that. Resistive index is 0.86. I will talk about resistive index later on. the patient has lost its autoregulation in this case, because when the resistive index is more than 0.74 plus minus 0.08, that means that the diastolic BP is falling, the autoregulation is lost. When the autoregulation is present, the diastolic BP rises up, the difference between systolic and diastolic falls, and the resistive index falls. So key messages: in sepsis, we can know the volume status, we can know the cardiac contractility, we know the state of pulmonary vasculature because it constricts and gives rise to increased pulmonary artery systolic pressure. We can know about neurological status, whether the patient is autoregulating or not, and we can select vasoactive drugs. We use noradrenaline and normal fluids in this case, as against the dopamine, that is the usual trend. Now shock. Any diagnosis? All four chambers are connecting. All four chambers of the heart, ventricles and atria are in communication with each other. This is a complete AV canal defect. A diagnosis that can be made within a minute in a standard apical four-chamber view. This is a truncus because the right ventricle and left ventricle are in communication with a single large vessel. So this was a truncus. A patient with shock is completely white in color. Diagnosis here, the left ventricle is very small. This is a hypoplastic left heart. This patient I was facing at around 12:30 or 1 a.m. at night. I had seen this patient after birth. Relatives came on day 3 or day 4. 5-6 people came. I was alone, but I saw the patient. I showed them this, and they said, okay, this was conveniently, ye peet mein tha, tab se aisa tha. So I was saved. If it had been normal or I could not have answered them, then I had it at 11 a.m., at 1 a.m. at night. So it was a savior for me. This is a normal view. You can see the arch here. This is the arch of aorta with the 3 vessels, 1, 2 and 3. 1, this is the common carotid, left common carotid, this is the innominate, left common carotid, left subclavian. You know, appreciate this? You will appreciate better on this. Can you see the arch now? Completely well-formed arch. Can you see the arch here? You might appreciate it better here. So it is constricted here. So this was a coarctation of aorta. 3 cases of PDA at approximately similar day of life, 1, 2 and 3, with 3.8 mm, 3 mm and 2 mm PDAs. Which one of them is the most hemodynamically significant? Obviously, since we are seeing only the size, we would say that the 3.8 mm will be the most significant. Now let us go a little bit in detail and see the Dopplers. So here you can see velocity 240, usually is less than 200. If it is constricted, it will give more velocity. So here velocity is more. This is the systolic, this is the diastolic. Difference is very small. Now see this next one. Velocity 160. A low velocity, less velocity. Difference between systolic and diastolic is more. So this is a closing type of PDA. This is a pulsatile PDA. And now see this one. There is no diastolic flow here, which means that there is a steal phenomena where blood is going is taken away from the PDA, from the cerebral circulation, is going into the pulmonary circulation. So now what will you say, which is the most hemodynamic significant? It is exactly the opposite. I will be more worried about this 2 mm PDA rather than this 3.8 mm PDA. I would not even hesitate to extubate this patient if this child is on ventilator. This is another case, 5-week-old with wheeze, tachycardia and a gallop. Can you tell me the diagnosis here? If I tell you the diagnosis, you will never forget in life. This is Pompey's disease. See the hypertrophic left ventricle. So key messages, ultrasound gives us a quick diagnosis in circulatory failure. Gross congenital anomalies can be easily diagnosed. We don't want to diagnose complete anomalous venous drainage. We don't want to diagnose that. They are a little bit difficult to diagnose, but these could be diagnosed. We can make out which is the hemodynamic significant PDA. It helps in decisive management and will tell you about the prognosis. Neurologically depressed newborn. These are the normal views. You can see the sagittal view. This is the lateral ventricle. Actually, this is cavum septum pellucidum, but lateral ventricle will also be similarly. This is the normal choroid plexus. This is the cerebellum. These are the normal sulci-gyri pattern. This is the sagittal view. This is a coronal view. See the comma-shaped ventricles and good differentiation between gray matter, white matter. This is the Sylvian fissure, the Y-shaped Sylvian fissure. Now, can you make out something here? The choroid plexus is very big here, and this is an intraventricular hemorrhage. Large ventricles, including the third ventricle. Normally, third ventricle is not seen or is just slit-like. So, this was a hydrocephalus. This here sulci-gyri pattern is not easily seen. The lateral ventricles are not seen at all. And this is a cystic lesion in a 3-week-old child, periventricular. This is periventricular leukomalacia. This is a case of cerebral edema, and this is showing a resistive index of 0.47. Normally, 0.75 or 74 plus minus 0.08. So, this has happened because the diastolic pressure has increased. This child is auto-regulating in spite of such picture. Because resistive index is systolic minus diastolic divided by systolic. As against in another case where it is 0.84, you can see the diastolic has fallen down, and so the resistive index has increased. So, a rising resistive index is a bad sign because you know that the patient is not auto-regulating. Ventricles with exudates inside, this was a meningitis with ventriculitis. So, key messages: cause of CNS depression can be made out, stage of HIE whether auto-regulating or not, disease complications can be made out, and monitoring in patients with hydrocephalus when to subject this patient for shunt. That also can be done, but that is out of purview here. So, to analyze, this is an old modality. Ultrasound came to Solapur in 1983 when it was first used in obstetrics. Today, it is not well used in pediatrics. So, 40 years have passed. Focused ultrasound has wide scope in neonatology. Its role begins where the clinical examination ends. It gives a pediatrician quick insight into the case. It increases comfort level in the emergency room and helps us in this era to face the relatives boldly. Ultrasound is a friend, will never let you down at any moment of time, provided you have patience and perseverance. But the final word I would say, ultrasound should not be a substitute, but a supplement to and complement good physical examination. Thanks very much for patiently listening.
We have 5 minutes. Any questions from the audience?
Thank you, Dr. Vikram Hirekarur. For the next update on neonatal shock, I invite Dr. Sachin Shah.
So good morning, everyone. Thank you, organizers, for inviting me today. So I will talk about shock in about 25 minutes. I thought it was 25 minutes. I have taken 5 minutes less. No, it was because in the brochure, the invitation said 25 minutes. That's fine. I'll try and finish it fast. So after a long night, long dinner, late night, I hope I make sense when I'm talking. If not, you can please stop me. So I will talk about the standard practices that we follow. And believe me, since this is a huge talk, I will be basically restricting myself to term infants. Little bit addressing little bit controversies about diagnosis, treatment, and then we will go integrate everything into a case-based scenario. So what do you mean by shock, right? Is it hypotension, impaired end organ perfusion based on lab parameters or echo-based? In fact, we use all these parameters to define shock. There is not a single parameter with which you can identify shock. So the common parameters that we use, conventionally, the clinical examination, which is the most important, which includes heart rate, capillary fill time, blood pressure, lactic acidosis, central venous saturation, some few words on that, and obviously AV oxygen difference. and then echocardiography that Vikram was talking about. Now NIRS and rest other parameters are purely experimental, and I do not have much experience with that, so I will not talk about that. So this is the most important slide today, and because we have to look at shock from a physiological perspective. So we all know that shock is not synonymous with hypotension. So when you diagnose shock when the baby is hypotensive, that's very, very late. So we know this algorithm, like blood pressure depends on the cardiac output and systemic vascular resistance. So you could have a high systemic vascular resistance, low cardiac output, and your blood pressure will be maintained. And look at these parameters which would be affecting your cardiac output, the heart rate, stroke volume. So this is very, very important because you need to know what is wrong physiologically with the baby and where do I need to make a change, whether I need to change the preload, contractility or afterload. And only then accordingly you can titrate your medications. And for that, apart from clinical examination, in addition to clinical examination, like bedside echocardiography is very, very important. But we need to understand physiologically what is wrong. So one is physiological understanding of the disease process. So now if you look at this particular diagram, it's very simple to understand. On the vertical axis you have cardiac output. So if your cardiac output is good and the blood pressure is good, you are in a normal situation, right? But if your blood pressure is normal but cardiac output is low, what is that? Compensated shock, right? If both your blood pressure and cardiac output are low, pretty bad, right? Pretty late, decompensated shock, right? And if you have a hyperdynamic circulation, then you will have a high cardiac output with a low blood pressure, sometimes called as a vasodilatory shock. Nowadays we don't use the terms of cold and warm shock. We call it vasoconstricted or vasodilated shock. So, but then again another controversy, what is hypotension? Do we know what is hypotension? Really no, because then what is it? Statistically low blood pressure where less than 1% of all the babies are, where like more than 99% if they have a normal blood pressure, we said that blood pressure is normal. So again, if you look at the definition of hypotension, it is derived from babies who are well, those who are not in shock. So all those normograms that we have are not much of a use in a sick baby, but still we follow them because there is nothing else that we can use in our practice. What is unsafe BP? It's a very vague term, blood pressure which can, if you don't address that blood pressure, there would be end organ dysfunction over a period of time. So all these are very vague definitions. So what usually clinicians use is a operational or a target BP. We try to keep it above the gestational age, and that is a very simple way of looking at things, oversimplification of definition, right? And mind you, that definition was coined in 1992, or this operational threshold was determined in 1992. How do we measure blood pressure? Forget about definition. Do we know how to measure blood pressure? Either non-invasive or invasive. A lot of controversies in that. If you are doing a non-invasive blood pressure measurement in ELBW babies, we have to struggle to get a correct size cuff. Multiple readings are needed. You are supposed to take an average of 3, and then it can be quite disturbing to the baby. Invasive blood pressure, obviously technically challenging, zeroing, you need nurses, again cost increases, and plus it can lead to vascular complications. So a lot of challenges in measuring blood pressure in a baby. So we did our study, we published our study where we looked at comparison between invasive and non-invasive blood pressure. And what we found that the risk of bias was very high, as I talked about. The risk of bias was low if you look at mean blood pressure as compared to systolic and diastolic. So if you have to take a single reading and compare, then mean blood pressure is better. And the risk of bias was also low in normotensive babies. So if you had a hypotensive baby, then the bias was high. So what we concluded that if we have a hemodynamically stable baby, non-invasive blood pressure, yes, you can use for monitoring and identification. But the moment you start needing, like the baby starts needing like vasoactive agents, it's better to go for a invasive blood pressure monitoring. So after these controversies, then how do we choose therapy? We choose therapy depending on clinical findings, right? Blood pressure, yes or no, and echocardiography. And sometimes we use all 3 parameters, right? We usually will not choose a therapy based only on a single parameter. And what are the reasons why we use vasoactive drugs? To improve blood pressure, right? To improve end organ perfusion and to improve cardiac output, isn't it? There is always, these are the reasons, because these are the physiological endpoints that we are targeting and we are trying to chase them. And then what do we monitor while we are chasing that? All the parameters that I talked about, clinical plus echocardiography. Now in echo, Vikram talked about it, like you get a good idea, like I will show you a couple of slides, but what we need to monitor is like, what is the left ventricular output and what is happening to the right ventricular status. So you monitor the cardiac output, you calculate the ejection fraction with all its limitations, you can calculate the cardiac index, you can also calculate the systemic vascular resistance index. And then once we know the physiology, then what are the conditions where we use vasoactive agents, common conditions, like apart from the duct-dependent lesions that Vikram talked about, the common conditions where we use vasoactive agents are basically septic shock, commonest in term baby, septic shock and PPHN. Now PPN is a primarily, like we would use vasoactive agents because all of them would be like in shock at some stage. So then what are the drugs that we have in our armamentarium and what is their mechanism of action? This is a very simple slide. You all know that. I will not go into the details. But mind you, like when you are, again, you need to know what receptors a particular drug is acting and what do you expect the drug to do, right? So this is very a simple slide. So let me go through the recommendations for management of septic shock in term babies which have been given by American College of Critical Care Medicine, and they are pretty simple and easy to follow. They were given in 2017, and what they advocate that if a baby comes in shock and you have addressed the basic things, ABC, sugar and calcium, then you should give a fluid bolus of 10 ml per kg. You can give maximum up to 40. One thing to remember now, everybody is moving away from fluids. So you have to be conservative. One bolus is okay. Before you give the second bolus, you have to ask yourself the question, is the baby hypovolemic? Do I need to give fluid boluses? And how can that question be answered? By calling Vikram? No, by doing an echocardiography, yes. So basically, so after every intervention, if you are not getting a desired result, it is better, especially if you are giving fluids, you should look at the IVC and look at the volume status before you jump up the gun. So if the baby doesn't respond to say 30 to 40 ml per kg of normal saline or crystalloids, then you would start on vasoactive agents, and dopamine is the drug of choice. You can start at 10 microgram. If the baby doesn't respond, then the second drug would be adrenaline. And after that, it goes into the category called as catecholamine resistant shock. And that's really a difficult baby to tackle because it's not only a single modality. You will need a lot of multimodal monitoring to manage such babies. It's not just adding vasoactive agents. You will have to apply all the physiological principles that I talked about. So on echo, like just briefly, what do you look at? Briefly, like if you are doing a quick echo in a baby who has come in shock, you look at the IVC, distensibility, you look at the cardiac contractility, and just looking at the heart, you get a good idea like how the heart is contracting. You calculate the ejection fraction and calculate the cardiac index, very good. And you will also assess, if you have a PPHN, you will assess for like the tricuspid regurgitation, how is the shunting across the duct, whether there is bidirectional shunting across the duct, ASD, how is the septum, whether the septum is deviated to the left side. So this is what you would look for, right? Well-filled IVC, go to the M mode, calculate the maximum minimum diameter, and look at the variation in the IVC. Now this is an aortic outflow tract. You put your probe, do the velocity time integrals, and from that you can calculate cardiac index by simple formulas which are available. You can do it like just using a pen and paper, right? So what I am talking about in neonatal shock is basically it's an individualized and personalized critical care. So it's not a standard like protocol based critical care. You will have to individualize the management. Up to a certain extent, protocol based management is okay, but once the baby starts getting really sick and things are not responding the way they should be, you have to tailor your treatment according to the needs of the baby. So this was a very nice algorithm which was published by the European neonatologists, those who are interested in echocardiography. And this is very easy, it looks very complicated. Basically, again, it is based on echocardiographic findings. But if you look at this particular algorithm, it is purely based on physiology. So if you know your physiological reasons, you can just go through these steps. Little bit about lactate and central venous saturation. See, when the heart is pumping blood in shock, there is a demand and supply mismatch. So the blood comes from the heart, goes to the tissues will extract. And if the tissues are extracting more than the heart can supply, the blood which comes back will have less oxygen, right? And this we would be measuring in the SVC. So you'll have a low central venous saturation. Now sometimes it's difficult to measure in newborns. It's okay if you have an internal jugular vein. But if you have an umbilical venous catheter which is also well placed above the diaphragm, then it will give you a fairly good idea as to how is the circulation in the lower part of the body, not at the upper part of the body. Now if the demand is very high, if the tissues, because the tissues would be having a lot of demand, and if the supply is inadequate, the mixed venous saturation or the central venous saturation will be low. Right? The normal value is about 65 to 70. So anything less than 55 is really worrying. What about lactates? Do you routinely monitor lactates? Yeah, all the blood gases routinely give you lactate. A single value, yes, it is useful to some extent. It just tells you like what is happening to the end organ perfusion. But if you have lactates which are like rising, or like, it's always better to monitor the trend of lactate, because if the lactates are coming down, then you're sure that at least your tissue perfusion is getting better. Another important thing to remember is that if you are using very high doses of catecholamines, then your lactates can paradoxically go high. So don't let that be the only factor to decide. It could be one of the other factors to assess. So you should have a holistic approach to shock. So now that we know the physiology, we know the pathology. So broadly, like, how can the shock be classified? One is obviously septic shock that I talked about, and the algorithm is pretty clear as to how to manage that. Second is PPHN. I will talk very briefly about PPHN. Heart disease. So when I mean by heart disease, it's a duct-dependent lesion, and it's good that we do an echo. Most of the duct-dependent lesions can be easily picked up by a neonatologist. And obviously then you can call a cardiologist to confirm what you are showing. And what we routinely do, if you are not sure, we take videos and send it to the cardiologist, which makes it easy because they are not going to come in the middle of the night to do an echo. In PPHN, like we know, pulmonary vasodilators are the mainstay of therapy, but circulatory support is needed. And there are two drugs which, in my opinion, like when we manage shock in PPHN, make a huge difference. And one is milrinone, right? And we all know that milrinone is a ionodilator, so it improves the cardiac contractility, and it causes like a little bit of systemic as well as pulmonary vasodilatation. So it is a wonderful drug. So if you document myocardial dysfunction on an echocardiography in a refractory PPHN, then milrinone is the second drug of choice, right? And it has to be given as a bolus, important thing to remember, otherwise it will take almost 4 or 6 hours for the peak levels to be achieved. So if you want rapid increase in levels, I have 5 minutes, isn't it? Yeah. So if you want rapid levels to be achieved, then you should give it as a bolus and then run it as an infusion. Another lovely drug is vasopressin, which acts directly on the V1, V2 receptors. And the beauty is it increases systemic vascular resistance and decreases the pulmonary vascular resistance, and very short half-life. And in fact, we recently published our experience with use of vasopressin in refractory shock in PPHN. Refractory, and we defined refractory shock or hypotension as a baby who was needing dopamine of more than 10, adrenaline of 0.3, NORAD of 0.1, and the blood pressure was persistently staying lesser than the gestational age for 15 minutes or more. And obviously this baby was on nitric, high frequency, and the whole works. And what we found that once we started vasopressin, we monitored the vasopressin, like the vasoactive infusion score. The need of other vasoactive agents decreased, and also our oxygen index decreased. So there was improvement in oxygenation and the need for circulatory support also decreased. So vasopressin is a useful drug when you have refractory shock. Either it could be it is most useful like if you have refractory shock secondary to pupation, but people have tried it in severe sepsis also. So now whatever I have talked about, how do we integrate? Let's go through a case, right? And we will make it interactive. Very simple. So 3 weeks old baby comes to the ER, heart rate 180, respiratory rate 60, lethargic, fever for 2 days, poor feeding, birth weight was 3 kg, currently 2.8, lethargic, heart rate is 180, peripheral pulses are feeble, cold, capillary fill time is 4 seconds, NIBP 40 by 25, mean 32, respiratory distress, saturation 98% on HFNC 6 liters, FiO2 50%. What do we do? Okay. But yeah, this is probably what are you thinking? Septic shock, vasoconstricted, decompensated, right? Simple. So I agree, you have given fluid boluses. What drug would you start? You will address the ABCs. Will you intubate this baby? Obviously, like having severe respiratory distress. But you will first start vasoactive agents, and that's what we did. You can start dopamine or adrenaline. Look at the you should know the pharmacokinetics. Dopamine is slightly slower acting because it will get converted, right? Well, adrenaline will act fast, like within minutes. So, okay, important thing to remember, vasoactive agents can be started via peripheral IV, especially in resource limited settings. Now, when you have NIBP, you can cycle the NIBP every 5 to 15 minutes, especially if the baby is very sick, cycle it every 5 minutes. And then once the baby stabilizes, you can cycle it every 15 minutes. And if you are using peripheral vasoactive drugs for a short duration, dilute them and then use it. And then later on, like once you get a proper PIC line or a central line, then you can change to a normal concentration. So obviously this baby is ventilated, intubated, ventilated on dopamine 20, adrenaline of 0.2 microgram per kg per minute, heart rate is 180, saturation 95%, invasive blood pressure 55 by 35, mean 41, pulses are still feeble, peripheral pulses, cold, CRT 4 seconds, central venous saturation is 55%, lactate 5, hemoglobin 11. Happy, not happy? Who are unhappy? Only few people are unhappy. Okay, fair enough. Okay. So unresolved shock. Yeah. So what do we do? Do nothing. Fluids. See, the options that I have putting doesn't mean they are right. I am just randomly putting options. So you can give fluids, you can give increase adrenaline, add some other drug, add milrinone. Echo, yes, so echo guided therapy. So echo is most important at this stage because things are obviously not going as per plan. So it will help you in fine tuning. So I give you the echo findings. IVC is normal, ejection fraction is 45%, cardiac index is 3 liters per minute, which is low normal. Systemic vascular resistance is 2000, which is high. So he has got low cardiac output, myocardial dysfunction, probably because of sepsis, and obviously the systemic vascular resistance is high. So what do you do? So, what do you want to improve the cardiac output? Yes, you want to improve the cardiac output, contractility, you want to improve the stroke volume, right? So then you can add milrinone. Do you want to reduce the systemic vascular resistance? Yeah, but milrinone will do both. It will reduce your system, it will decrease the systemic vascular resistance also. केलं ना? नहीं जाते, हाँ झालं. Okay, so milrinone, there are proponents of dobutamine also, which I usually don't use, but dobutamine is also a useful drug, but mind you, here the baby had a heart rate of 180, and one of the downsides of using dobutamine is it will rapidly increase the heart rate. So when you have a baby who is having like tachycardia, it is not a good drug to be used. Okay, 6 hours later, baby is on adrenaline 0.3, dopamine 20. I have only 2-3 minutes I will take. Milrinone 0.66, heart rate is 150, pulses are still the feeble, cold extremities, CRT 4. Blood pressure now is normalized. In fact, slightly on the higher side, mean is 46. What information do you want? You want labs? Echo. So ABG is 7.15 pH, 34, PCO2, PO2 56, 13, base deficit -10, CVP not available, central venous saturation 50, lactate 6.4. Echo again, poor cardiac contractility and high SVRI. ECMO? No. Can you still play around? Yes, so obviously like still unresolved shock, he's still vasoconstricted, right? Because the systemic vascular, do you want to vasodilate him a little bit? Could it be a side effect of the drugs that we are using? It is possible, yes, it is possible. So if you want to reduce SVR, improve cardiac output, one of the ways is he is on very high doses of adrenaline. You could reduce adrenaline. I'm just giving food for thought. There is no right or wrong answer, right? This is based on physiology. You'll have to think. You can add a vasodilator. Right now the heart rate is normal. You can add dobutamine to improve cardiac contractility and cause vasodilatation. You can increase milrinone. He is at 0.66. So you have various options, right? But you think what you want to do and then reassess after some time. So vasodilators, usually people would be using sodium nitroprusside. In a low dose, it acts rapidly. Don't increase it to doses more than 4 microgram per kg per minute, right? Because it can lead to cyanide toxicity. So some nursing issues are important. Do not mix inotropes. Connect the distal inotrope closest to the, like the most important inotrope has to be closest to the baby. Keep new syringes loaded when the pumps give alarms of nearly empty. Use pumps with battery backup. Do not flush the inotrope lumen. Do not use inotrope lumen for sampling. Ancillary care is equally important. So pay attention to your thermoregulation, sugar, calcium, and hemoglobin thresholds for transfusion. But regardless of resource limitations, certain monitoring tools are very, very important, without which advanced shock cannot be managed. And that includes IBP, echocardiography, lactates, and central venous saturation. So type of shock and the reason for using vasoactive agent needs to be identified. Remember that one size does not fit all. We have to use an individualized pathophysiology-based approach. So thank you.
Thank you, Dr. Sachin Shah. Coming to our sixth quiz, our quiz master for this quiz is Dr. Vidyanand Patil.
I invite you for Pedicriticon on 1st, 2nd, 3rd of December to Pune. So those who have not registered, please register fast.
Good morning, everyone. At the outset, I would like to thank the organizing committee members of Mahanecon Solapur for inviting me here to speak to you about human milk banking. It's just an eye-opener session for those of you who are not that well-versed with human milk banking. So this is the outline of today's talk. We are just going to go through a little in depth so you can clear out a few doubts. What do we mean by human milk banking, the global and the Indian scenario? Why do you think there's a need for human milk banking? How it works? What is the composition of PDHM, which is pasteurized donor human milk? The scope of a milk bank, what are CLMCs, and transitioning to a CLMC. So let's begin. A human milk bank is essentially a service that collects, screens, processes, and dispenses, but by the use of a medical prescription, pasteurized donor human milk, which is given in by mothers who have it in excess and who are not biologically related to the recipient infant. Let's begin by addressing how the global setup was. Initially, breast milk banking first started in Vienna way back in the 1900s. And India, everyone knows that human milk bank started first with Sion Hospital in 1989. During the course of 2005 to 2015, we had about 22 milk banks, and currently India stands at somewhere between 100 to 110 milk banks. However, unfortunately, all of these are not functioning in its entirety. This is something that I think we should all know if we are looking at human milk banking. Brazil's setup is the champion setup. They have their own milk banks, which they also call as houses of lactation. There are more than 224 milk banks, and they have more than 214 collection points in the country. So their bars, their malls, their hotels, their restaurants, their firehouses, every single place works as a collection point. Every single place has a deep freezer, which is meant for mothers to leave their excess milk, and it is collected by every single of their government people, right from ambulance workers to firemen to each and every single delivery guy. It's that simple and it's that efficient. So why should we choose MOM or PDHM over formula? I didn't want to put everything on multiple slides, so that's just a small gist for you there. Decreasing rates of neck, late onset sepsis, decreasing rates of ROP, definitely better weight gain, but if you're using pasteurized donor human milk, please don't forget to fortify it. Fewer rehospitalizations and improved neurodevelopmental outcomes. All of these justify the need of a human milk bank. As per the WHO recommendations, we all know that all low birth weight babies should get access to mother's own milk first. If not mother's own milk, then definitely donor human milk. And if that is not possible, then the last option is preterm infant formula. So this is how the human milk bank works. This is a small screenshot that I have taken from the Sion Hospital setup, and we'll see it in detail over the next few slides. So your healthy donor mother either approaches the milk bank or she is identified as a mother who's producing in excess by the lactation counselors and consultants at the hospital. She expresses her breast milk either at home or at the hospital. It can be refrigerated in her own house or frozen at home. It's transported to the milk bank, of course, in a cold chain. And then there are quite a few processes that occur at the milk bank itself. So there's the thawing and pooling of donor milk that occurs. So multiple mothers' milk is taken together, it is thawed at the same time, and it is pooled in one big sample. There's a pre-pasteurization culture. This is an optional step for many milk banks because they try to save on the milk. There's the holder pasteurization, which heats the milk to a temperature of 62.5 degrees and holds it there for half an hour, and after which the milk is plunged into an ice bath where it is kept till it reaches a temperature of 10 degrees. Then there's a post-pasteurization culture. Once your post-pasteurization cultures are available, that is when the dispensing of the donor milk comes in the picture. This is only when the cultures are sterile. So any growth in the post-pasteurization culture is not acceptable. And this is on prescription only. So this is just an additional piece of information to give out here. I work a lot with mothers who choose to deliver through the modes of surrogacy. And most of the time we find that most medical professionals tell these mothers that milk will be available from a milk bank for the baby that they have through surrogacy. So please stop telling this advice. Milk banks, as it is, find it very difficult to have that much milk for their own babies in their own NICUs. So giving out milk to healthy term infants who are at home is a very big step, and we have not reached there yet. So please don't loosely give out this advice. Donor human milk goes to babies only who are in hospital setups, in NICUs, PQs, and so on and so forth, but not to healthy babies who are at home. So again, to simplify, this is how it goes, and we'll be speaking about donors and the donor milk a little in depth in the next few slides. So what's in, what's not? This is a very interesting slide. You can find the difference between mother's fresh milk and frozen pasteurized donor human milk, and of course the relation with formula, just so all of us know. One of the interesting things here is, for us, or for those of us who are breast milk friendly, some bit of breast milk is always better than no breast milk at all. So if you're using donor mother's milk and you do have 1 or 2 ml of mother's own milk coming in, give it off at the same time. Don't wait to pool all of the mother's own milk together and give it in one feed. So if you have a baby who's on about 8 ml of OGT feed, who's gotten 6 ml of donor milk, and who has 2 ml of mother's own milk, give it off together. It helps. That fresh mother's milk will help the lipases of the breast milk to do their job well. Okay? So look at how it works, and this is definitely an option that most of us can look at. So donor screening, what do? We ensure that all mothers are screened before donating. If they are not, then the hospital where you work, the management can come up with a drive where the blood checks can also be done before the milk is taken in. So they are checked for HIV, HTLV 1 and 2, hepatitis B and C, syphilis, and this lab work may be repeated every 6 months. Now again, this differs from most milk banks to milk banks. Most setups will not accept donor milk from a mother beyond 6 months of her baby's age. But there are milk banks who will accept mother's milk even from a mother whose baby's age is close to 1 year. So if that is the case, then you may want her lab work to be repeated every 6 months. In general, most donor mothers should of course be in good health. They should be free of all infection, should not be smoking and drinking, should be willing to undergo a blood test, and should not be on any regularly medicational or herbal supplementation use, and preferably should have a baby less than a year old. Exclusion criteria is same as the American Association for Blood Banks. So it's a little simplified there. You don't have to think a lot. Illegal drugs are not allowed, ensuring that they are otherwise free of most infections or all infections. No smoking or tobacco. Of course, the alcohol remains to a bare minimum. And organ or tissue transplant, blood transfusion, tattoos or body piercings in the last 12 months are not allowed. Informed consent form is very, very crucial, and now there are in fact guidelines which tell you that it's an informed consent for the mother who is donating her milk, so she knows that she is donating it voluntarily, no one is going to pay her any remuneration for it, and the informed consent form also reflects that it is going for a needy cause. There is nothing attached to it otherwise. So who are the recipients of donor milk? Since we've been seeing it since yesterday, any preemie infant, basically below a weight of 1.5 kgs, because of the risk of infections and NEC, any gastrointestinal anomalies, whether the mother is in a situation where she can't be possible, or she is not in a situation where she can breastfeed or express milk, someone who's had a lot of complications throughout the course of pregnancy and the process of delivery, weaning from parenteral nutrition, metabolic disorders, and just as a bridge till the mother is able to get in her milk supply. So these would all be the recipients of donor milk. So where does a CLMC come into this? So as per the last or the most recent guidelines that have come in, we are not supposed to call human milk banks anymore, because banks essentially make people think of money. So now human milk banks are known as comprehensive lactation management centers. So essentially a milk bank would be associated with a NICU, would be associated with a lactation support center, where a mother is ensured very good service in order to be able to successfully breastfeed her newborn. So the current CLMCs would also support not just breastfeeding counseling, but also kangaroo care, family-centered care, infection detection and treatment. Currently, we have about 108 CLMCs and LMUs established in India. So this is from Dr. Sushma Anangia, and this is how it is expected that a CLMC would actually work. So CLMCs would be with medical colleges with big NICUs in district hospitals. Lactation management centers would be a step down, and lactation support units would be another step down. So the functions of the milk bank or the CLMCs here would involve lactation counseling and breastfeeding initiation. So doing the golden hour post-feeding, doing the skin-to-skin contact post-birth, all of this would be in the picture. Stimulation and expression through using either electric breast pumps, personal use breast pumps, or a manual technique. Collection of the donor human milk, storage of the donor human milk, so the ideal temperature is minus 20 degrees, processing of the donor human milk, and finally the dispensing of the donor human milk post sterile cultures with prescription. When we speak about bringing anything new in the system, there's always a cost attached to it. So this is the equipment and cost of setting up. What I've given here is what we had done when we built the human milk bank at Sayadri Hospital. but you are always allowed to do it on a smaller scale. It need not be something very lavish. You have to think of the recurring costs of bottles, bacteriological testing, blood testing, and also always remember that this is not a revenue generating mechanism, okay? You need an administrative staff to run the milk bank like you do for any other setup that you have. So a director, a milk bank officer, a lactation management nurse, a milk bank technician or an attendant, a receptionist, and a microbiologist. These people can have dual roles. They need not be separated and used just for the milk bank. Something that I need to put out there, in all the milk banking that has occurred since the 1900s, there have been no published reports of infectious diseases being caused by properly pasteurized human donor milk. So any one of you who's thinking of that, you can take it out of your head. As long as the pasteurization was done correctly, as long as the cultures were sterile, then you can be completely comfortable with it. So just to summarize, human milk banks and going ahead to be known as CLMCs will be functioning as multi-purpose units, which essentially will ensure that all mother-baby dyads can have access to mother's own milk, can have access to pasteurized donor milk, can thereby either breastfeed or breast milk feed, thereby reducing the need of breast milk alternatives to bare minimum. Thank you.
Thank you, Dr. Amrita Desai, Dr. Sachin Shah, Dr. Vikram Hirikarur. Thank you, Chairpersons Dr. Amit Tagare and Dr. Sudhir Mure for presiding over this session. Thank you, Quizmaster Dr. Vidyanand Patil. Please proceed for felicitation.
I thank all the faculties for very power-packed presentations with clear message. Thank you.
There is one announcement.
The room checkout time is 12. So those who have not done it can be kept in cloakroom or inform the reception counter.
Before proceeding for the oration ceremony, there is one more announcement. For the delegates who have not received the certificates, can today collect it from the registration counter.
Ladies and gentlemen, we now proceed to the most prestigious part of Mahanecon festival, Dr. Simin Irani oration.
Good morning, everybody. For the next very prestigious oration, I request Dr. Ashish Dongde, Secretary NNF, and Dr. Rishikesh Thakre, President NNF, to be on the dais, please.
A very good morning to you all. It is indeed a pleasure and privilege to have you today for the prestigious Professor Dr. Simin Irani oration, which is conducted during the annual conference of the Maharashtra State Chapter of National Neonatology Forum. The oration was started in 2015, and we are indeed fortunate and privileged to have Madam Irani with us today in the audience. To many in the audience, she has been a teacher of teachers, an academician, a researcher, a mentor and guide, and a living legend today in neonatology. We thank you, Madam, once again for your presence. And to deliver the oration, we have Dr. Sandeep Kadam, consultant neonatologist from Pune. And I invite our honorary secretary, Dr. Ashish Dongde, to introduce the speaker for today's oration.
Hello, good morning everyone. So it is indeed my privilege and honor to read the citation for Dr. Sandeep Kadam. So after completing his MD Pediatrics from BJ Government Medical College, Pune, and he did his DM in Neonatology from LT MMCH College, Mumbai. He further honed his knowledge and skills through rigorous fellowship training programs in neonatology in Australia. With his unwavering commitment to the profession, he has accumulated a wealth of experience spanning over 2 decades. And he is currently serving as a neonatal consultant at KEM Hospital, Ratna Hospital, and MGM Hospital, and Hope and Health Clinic in Pune. So with your passion for improving lives of newborn and unyielding commitment to their well-being, you have emerged as a beacon of hope for countless families, transforming the landscape of neonatal care in Pune and Western Maharashtra. Your contributions to the field of neonatology extend beyond the confines of clinical practice. You have trained, you have guided, you have mentored students of DNB neonatology program, fellowship programs, and your involvement in academic programs such as preterm educational package by WHO, non-invasive and invasive ventilation, high-risk newborn follow-up have been extensive, both as a contributor and as a lead trainer. Your valuable contributions to the clinical practice guidelines of NNF have made a significant impact. Through numerous publications and presentations at various scientific forums and conferences, you have passionately shared knowledge and illuminated the field of neonatology. You have served as a president of Maharashtra State Chapter NNF, and it was just because of your untiring efforts during the COVID-19 epidemic that led to innovative use of online teaching and training programs, which earned Maharashtra State Chapter the Best State Award of the Year. However, your true measure of success lies in the lives you have touched, the infants who have thrived under your care, and the families who have found solace and strength in your guidance. Beyond your exceptional medical skills, you are also blessed with the qualities of compassion, empathy, and unwavering support of your young patients and their families. You always strive and establish nurturing environment where families feel heard, supported, and well informed throughout their medical journey. Driven by genuine compassion to make a difference, you go above and beyond to ensure that each and every baby under your care receives personalized attention and the highest standard of medical care. With your relentless pursuit of excellence and unwavering dedication to the well-being of newborns, you have had unmatched support of your family, including your father, Sri Sharat Kadam, your mother, Srimati Swati, and your wife, Dr. Archana Kadam, and your children, Ajinkya and Siddhi. So with immense pride, the Maharashtra State Chapter of National Neonatology Forum bestows this prestigious Professor Simin Irani oration to Dr. Sandeep Kadam. Sir. So now I invite Sir to join us on the stage. So please, I welcome you to join the stage.
At the outset, I would like to thank the Maharashtra State NNF, Dr. Rishikesh Thakre, President, and Dr. Ashish Dhongde, Secretary, for your kind words. And this morning, I'm here to share my experience, my journey over the last 2 decades of what I learned in neonatology. We have with us Professor Dr. Simin Irani, Madam. We all know Madam. She is teacher of teachers, a clinician par excellence. Madam, we learned so much from you, and we still learn from you, your discipline, your meticulousness, and your warm-hearted nature. You are ahead of time. You have done research at the GS Medical College, and your research on room air resuscitation is still being quoted. your leadership qualities that you have shown over the decades, over the last 5 decades. And above all, what we learned from you is your care for babies in the community. You still go from all the way from Mumbai to Nandurbar to mentor the SNCUs there, and that is an inspiration to all of us sitting in this auditorium. And most important, madam, what you have shown us is NICUs can't work without nurses, and your passion for nursing education stands tall. So with these, madam, I bow and salute you, madam. You are ahead of time. Today we are talking of healthcare leaders, but madam, you showed us these qualities over the last 5 decades about your humble nature, your vision, your mentorship qualities. You have demonstrated integrity, and most important, madam, you have collaborated research with so many NICUs across the country and abroad, and you are one of the founder members of the National Neonatology Forum. So madam, you are truly an inspiration to one and all. I would like to thank my teacher, and this is a newborn baby. Over the last so many years, so many things that we have done, right, wrong, fair, unfair, just, unjust, mistakes, knowingly, unknowingly, and these babies have tolerated so many of our things without saying even ah. We learn from the mistakes that we have done so that we don't repeat our mistakes. So this baby is truly a teacher for me. I would like to start my journey saying that our life has 4 wheels, as quoted by Gopal Das Gaur. We have our personal life, we have a family, we have work life and profession, and then we think about social contribution. But what I'm going to discuss today is going to be a discussion on the work life and profession, and then I'll take you to the 3 wheels that we are talking about. I think we all sitting in this auditorium are focused about the 3rd wheel, and we constantly ignore the 3 other wheels because we realize that it is career and profession that is more important. And then we forget to realize that this car just doesn't go forward, and it is going in the same radius without going any forward dimensions. So I think this is where we are as pediatricians, neonatologists, and we need to have that as an outset to think about what we need to do. What I learned in the first few years as a student, and still I learn, are some of the pearls in clinical medicine, and which I think are very important for all of us sitting in this auditorium. To start with, a newborn physiology is much different than a pediatric physiology. A child is not a miniature adult, and a neonate is not a miniature child. So physiology of a newborn is different, and transitional changes plays a huge role in understanding neonatal disorders, and therefore our approach is going to be much different than what a pediatrician would think in managing a baby in PICU and an adult treating an adult in an ICU. Just as Sachin told us just about few minutes ago, as a shock we would manage physiology-based approach rather than having a dogmatic approach of starting DOPA, DOBUT, vasopressin, adrenaline, so on and so forth. So our physiology has to be clear, and we need to understand so as to treat these babies who are admitted in the NICU. My take on newborn assessment is very simple. It is less invasive and non-invasive. Professor Meherwan Singh said, you can see a lot by observing, and that's very important when it comes to looking at a baby who is sick. So it is just observation and inspection that gives us a lot of information, and if you don't understand, you ask the nurse. Why? Because the nurse is a custodian of a baby who is with the baby for so many hours in the shift, and still if you are not clear, then ask the mother. Don't hurry into touching the baby or auscultating and inspecting, because you can make a lot of your inferences just by looking at the baby, and these are some of the simple, powerful tools when it comes to assessing a baby in NICU. Some tips for all of us sitting in this auditorium as far as clinical medicine is concerned. We often are so busy that we don't have time to take history, And I would like to just emphasize that history taking is very, very important, and these missed opportunities can give us a lot of information. So let's make most of it. Now, I'm just quoting few examples. Suppose I see a full-term baby with respiratory distress, and you have done everything under the sun and you don't find a cause. And you have examined this baby has tachypnea, distress, labile oxygenation. The baby is just not saturating by giving 100% oxygen. Look for pulmonary hypertension. The echo has been done. It shows severe PPHN. And then you ask the mother, has she taken any NSAIDs? NSAIDs given to a mother just before delivery can cause premature closure of ductus, and therefore this baby has presented with pulmonary hypertension. Or sometimes the mother may have some viral infections and the baby presents with viral pneumonias and respiratory distress. A term baby with prolonged jaundice beyond 3 weeks coming to you, and this baby has still unconjugated hyperbilirubinemia, and you do a urine culture, you find Klebsiella, and then you see, oh, I must do ultrasound and I see that there is hydroureter hydronephrosis. But a simple tool to see what was the urine stream. Is it going 2 feet? Is it reaching the feet? And if the urine stream is poor, it tells me that this baby probably has a PU valves with obstructive uropathy with reflux. And this baby has UTI which presented as unconjugated hyperbilirubinemia. A floppy baby with hypotonia, ask for history of fetal movement, ask for history of polyhydramnios, and you get a lot of information about neuromuscular disease, that this was a floppy baby because of hypotonia and polyhydramnios. Failure to thrive, hyponatremia, alkalosis, ask for history of polyhydramnios, and this is a case of Barter's syndrome that you have picked up just on history. I had a baby who was a preterm, 30 weeks, 1.1 kilo, presented with shock on day 3. And we did everything under the sun. We did echo, sepsis workup, head ultrasound, point of care, and everything. But just we couldn't get the etiology. And then I just asked, what was the urine output of this baby? And the nurse tells me, sir, the baby is passing urine quite frequently. So I said, wow, how many times? 10, 12 times. So I said, quantify the urine. And the urine output was 5 ml per kilo per hour, going up to 7 ml per kilo per hour. Now, which is this shock where there is polyuria? Then we came to a history, then we got a diagnosis that this was the diabetes insipidus, where there was severe polyuria, dehydration and shock. So what I'm trying to emphasize is that this is a baby, these babies have to be taken in, and you need to ask for history and you get a diagnosis. We all know what a normal examination looks, a normal term baby looks like. We all know how preterms look, they're pink. The extremities are warm, the central part is warm, CRT is less than 2 seconds, the breathing is less than 40 breaths per minute, they are tolerating oral feed. But for you and me sitting in this room, if a baby comes to you, I think the toughest challenge that we face is to label that this newborn baby is normal. I am sure you agree with me that to label that this baby is normal, it takes a lot of strength. And we are still not 100% certain that this full-term baby is normal or this preterm baby is normal. So I think for all of us sitting, it's still a learning curve, and we cannot say with certainty that this baby has normal examination. Some clinical experiences that I have learned over the years and tips for practice as far as all of us sitting in this auditorium is concerned. If you see a baby who is centrally warm and peripherally cold, and the cold to peripheral temperature difference is more than 3 degrees or 3.5 degrees Celsius, look for shock. You don't need a point of care to diagnose this, and you can diagnose shock just by feeling the baby centrally and peripherally, and I think this is a very good tool that you can pick up shock quite early. If you see a baby with fever and the baby is excessively pink, what is my diagnosis? This is environmental fever. If I see a baby with fever and there is excessive weight loss, what is my diagnosis? This is a dehydration fever. If I see a baby with fever but the extremities are cold, they are mottled, the cold to peripheral temperature is significantly high, what is my diagnosis? This is infection. If I see a baby with shock and I don't palpate the femoral artery pulses, what am I looking at? This is coarctation of aorta or a aortic thrombosis or interrupted aortic arch syndrome. A preterm baby who is not looking well, there is a full fontanelle, and I look at asymmetrical popliteal angle. What is my diagnosis? This is IVH. So I think these are some of the clinical tools and clinical signs which I have learned over the years and which can definitely help improve my judgment and analysis of babies. A term baby with extensor posture, what is my diagnosis? This is a clear-cut case of neonatal encephalopathy. So a normal full-term baby has flexed posture. So if you see a baby with extensor posture in a term baby, it is neonatal encephalopathy. You don't need anything else to diagnose this condition. Cause may be HIE, cause may be intracranial bleed, cause may be meningitis, sepsis, metabolic encephalopathy, so on and so forth. If I see a baby who is off-colored, there is temperature instability, there is tachycardia, bradycardia, heart rate characteristic changes, sugar instability, baby has tachypnea, distress, just not looking well, look for sepsis. If I see a baby with minimal tachypnea or tachypnea without distress, there is saturations which are low, there is baby is blue, collapses on day 3, look for a duct-dependent cardiac disease. This is maybe a congenital heart defect. A baby who looks pale but has normal hemoglobin, look for IVH, fungal sepsis, metabolic disorders, or sometimes duct-dependent cardiac disease like a coarctation of aorta. If I see a baby who has tachypnea with no retractions, so minimal retractions but tachypnea, look for metabolic acidosis, look for inborn errors of metabolism, or sometimes a congenital heart disease. If I see a baby who is IUGR, SGA, has hepatosplenomegaly, rashes, microcephaly, cataracts or corneal opacities, look for torch infections. And last but not the least, if I see a baby with shock which is not responding to inotropes, look for coarctation or a duct-dependent left-sided obstructive lesion, maybe IVH, maybe adrenal hemorrhage, or maybe a severe acidosis. And if you have acidosis, no matter how many vasopressors you are giving, these vasopressors will not act unless the pH improves above 7.25. So one of the differential diagnoses of a catecholamine resistant shock is persistent metabolic acidosis, because there is downregulation of these receptors that we are talking of when you are giving vasopressor drugs. So today's talk that I was thinking of is less is more. And what do I mean by less is more? Basically, you're talking of doing some interventions which may be less and they may have more benefits. So some pearls for practice is the Pareto principle of 80-20, wherein if I do 20% of interventions, it might bring about 80% of change in my practice. And I think all of us sitting in this auditorium will agree that if I do less, or if I do interventions which have got maximal benefits, they are going to be beneficial in the community. And what are these interventions that we are talking of? Basic interventions like warmth, kangaroo care, breastfeeding, skin care, hygiene, cord care. All these are doable, all these are feasible, all these don't take a lot of cost. And if you do these interventions, you are going to get maximal benefits, and these benefits are what we are looking at in improving newborn health, not only in state of Maharashtra, but across India. So when I'm talking of less, I'm talking of less hypothermia, less oxygen, less intubation, less antibiotics, less TPN, and less investigations. And what do I achieve? I achieve less mortality, less infections, less hospital stay, less BPD, and less ROP. So coming to the first intervention we are talking of, it is antenatal steroids. We all know it's intervention which is beneficial in 24 to 34 weeks of babies, and dexamethasone is a preferred steroid. But avoid antenatal steroids in late preterms. Don't give it routinely. There is no evidence. Don't give it in early term, and don't give it just because it is an elective cesarean section. So avoid antenatal steroids in these group of babies where less is more. Avoid repeated course of antenatal steroid. Doesn't do any good, because it has been shown that if you give repeated steroids, there is significantly reduction in the birth weight, and also there is reduction in head circumference. So basically what we are trying to say is that one course is good enough, and if you have a mother who has not delivered, we you could give another rescue dose, but more than that is definitely not indicated. When we are talking of hypothermia, why are we talking that we want less hypothermia? Because hypothermia is associated with 5 times higher mortality in the first week of life. Every 1 degree reduction in the temperature increases the risk of mortality by 80%. So if I just prevent hypothermia in community, I am going to make a lot of impact in reducing neonatal mortality. And how do I do it? I can keep the ambient temperature above 25. I can use plastic bags or plastic wraps in babies who are less than 30 weeks of gestation. But most important for you and me, it is early skin to skin contact. You could use thermal mattresses, and all these interventions definitely would help reduce hypothermia, but mind well, prevent hyperthermia. So we need to have euthermia, and that is very important. Sorry. Coming to oxygen, we know that oxygen is one of the most abundantly used or probably more misused drug in the NICU. It is a double-edged sword. Too much or too little, both are equally bad. And we need to understand what is the right use, what is the right dose, and what is the right titration of oxygen that I would use in NICU, which has good optimal outcomes. For this, I would use an oxygen blender, because we know that blended oxygen I know how much oxygen am I giving the baby. It is a standard of care as far as delivery room resuscitation is concerned, and according to NRP 2020, we need to keep that between 21 to 30% in babies less than 35 weeks, and more than 35 weeks I would start resuscitating with room air resuscitation. We all know that both hypoxia and hyperoxia are bad, they are detrimental. Why? Because hyperoxia is associated with ROP, hyperoxia is associated with BPD. Hypoxia is associated with increased mortality and increased incidence of necrotizing enterocolitis. So as of today that we understand, the saturation between 90 to 94 is acceptable, and when you are talking of resuscitating a term baby, one would start with room air resuscitation, and in a preterm baby, one would start with less than 30% of oxygen and avoid excess oxygen. So when it comes to oxygen and take-home message, oxygen, which was once considered as a panacea, the perception has changed with time. Unrestricted liberal use of oxygen basically contributed to the epidemic of ROP. Restricted oxygen sometimes can be associated with NEC and mortality because of hypoxia, and we as clinicians need to find a middle path and make the best use of oxygen to titrate your saturations between 90 and 94. When you go to resuscitating a preterm baby, we are talking of delivery room CPAP and less intubation. So here what I am saying is that the message is less intubation, more delivery room CPAP. Now why delivery room CPAP? Because you are going to help the lung to get recruited, and there will be prevention of atelectasis. When you do delivery room CPAP, basically you are going to reduce the need for mechanical ventilation by 25%, and the need for surfactant is reduced to close to 30%. And so whenever you are looking at less than 30 weeks of gestation, it is less intubation and more delivery room CPAP that we should be doing. When it comes to baby who is shifted or transferred from labor room or OT into the NICU, we should be doing more non-invasive ventilation and less invasive ventilation. Why? Because early CPAP has been shown to reduce the need for mechanical ventilation by 50%, and the need for surfactant has reduced to close to 40%. There is small but significant reduction in the incidence of BPD and mortality when it comes to NIV versus invasive mechanical ventilation, and the number needed to treat to prevent one case of BPD is 25, though significant, because the morbidity associated with BPD is significantly high. So today we know that less invasive ventilation is better than invasive ventilation. CPAP versus NIV, it is less CPAP and more NIV. Why? Because when you are talking of nasal ventilation versus CPAP, as an initiating mode of RDS, there is reduction in the incidence of treatment failure by 40%. Need for mechanical ventilation decreases by 40% for RDS. NIPPV is superior to nasal CPAP. Why? Because you are giving PIP and PEEP as against only CPAP, and it also has been shown that there is reduction in the extubation failure by 30%, and the number needed to treat is 8. So basically NNT to prevent one extubation failure is 17 with non-invasive positive pressure ventilation as compared to CPAP. So we should be using more of non-invasive ventilation as compared to nasal CPAP. Coming to surfactant, less intubation and giving surfactant versus more mist and LISA. What am I saying? Whenever we are giving surfactant, today we are talking of giving surfactant in a preterm baby when the FiO2 requirement is more than 30%. So if I have to give surfactant, might as well give using a lesser invasive technique wherein I continue CPAP or NIPPV and I put a catheter in the larynx into the vocal, near the vocal cords and give small aliquots of surfactant. And basically when you look at this lesser invasive modalities of giving surfactant, there is reduction in the incidence of bronchopulmonary dysplasia and or mortality. And the number needed to benefit is 9. The need for intubation also within 72 hours significantly reduced. So it tells me that if I give LISA or MIST, the benefits are far more as compared to intubation and giving surfactant. So we are talking of less CLD, and how do I do it? We should be gentle in our ventilation. We should use more NIPPV, more delivery room CPAP, use LISA, more caffeine, and optimal nutrition with more mother's milk, and most important, less infection. I think these all interventions together would definitely help reduction in the incidence of chronic lung disease in our NICU. Less fluids versus liberal fluids. What are we looking at? When you restrict fluids in a baby who is sick with RDS, you are allowing some weight loss about 1 to 2% daily, but avoid preventing too much of dehydration. There is benefit in terms of reduction in the incidence of PDA and necrotizing enterocolitis. So basically, restricted fluid is the way to go forward when you are managing a baby who is preterm and sick in the first week of life, and allow the baby to lose some weight physiologically. Less infections, and how do I do it? We need to have asepsis protocol, hand hygiene. We need to have our bundles where you are looking at CLABSI, VAP bundle, nutrition bundle, IV care bundle, mother's milk, less invasive approach, more kangaroo care, and aggressive feeding. We are all aware sitting in this auditorium about antibiotics, their resistance pattern, and the menace of the multi-drug resistant and pan-drug resistant bugs that we are looking at. Now this was a simple study from Canadian VLBW network where they looked at prolonged initial antibiotics for more than 3 days in the first week of life, and they looked at the outcomes, and they found there was an increase in the risk odds of mortality and as well as morbidities such as CLD, PDA, ROP, and severe neurological injury. Now this simple study tells us that over antibiotics more than 48 hours in the first week of life was associated with increase in the risk of CLD. It was 31% as compared to 14%. So what are we looking at? We should not use prophylactic antibiotics at all. Whenever you are looking at starting antibiotics, we are very quick to start, but if you see a baby with probable infection, stop early. Believe in your cultures. If the cultures are negative at the end of 48 to 72 hours, I think we should stop antibiotics. Culture-proven infections, 10 days are enough, and we need to adhere and we need to respect strict pharmacy policies and have your infection control nurse and the microbiologist on board. Coming to laboratory investigations, we all know today if a baby comes to us, there is a big file of investigations and we find very little of clinical notes. Parents also send us a lot of reports on WhatsApp. Please see the report and tell us what to do. So we are all driven by labs and investigations. Providing the best care doesn't equate to more tests. They basically are associated with higher blood loss and higher cost. And moreover, they create a lot of confusion. Suppose a baby is well and CRP is 100, what am I going to do? Oh, shall I start meropenem? Shall I do an echo to see if there are coronaries which are dilated and MISC? Am I looking at HLH? All these are going to create more confusion, and the cost of care and the treatment is going to be even more difficult. Look at your non-invasive modalities of testing, such as transcutaneous bilirubin instead of doing invasive bilirubin levels. You could look at oxygen saturations. You could look at other ways by which you could reduce the laboratory cost. There is also a good idea in all of us that we should do once a week hemogram, once a week electrolytes, bi-weekly creatinine, so on and so forth. So that's something called as a routine lab. I think it is not the best way. I think every baby is different, and we all need to think before we order any test. Why? Because basically we need to achieve less hospital stay. And why less hospital stay? Because it is beneficial for families. It reduces their cost for travel, it reduces the cost for visiting. We don't even think of the leaves and the holidays that they have to take from work to sit in front of you and outside the NICU because the baby is admitted in the NICU. Also, there is less time off work, and most important, the cost of care comes down. So the bills are less. So I spoke about less is more, but sometimes more is also less. And what are we looking at? More is less. We need to have more normal temperature. We need more mother's milk. We need more asepsis. We need more kangaroo care, and we have shown that there is enough evidence that every hour that you do more KMC, the morbidity and the mortalities are going to decrease and the babies grow better if you give KMC more than 6 hours a day. And last but not the least, involve the mother, involve the family in the care of newborn babies, and that's family participatory care, which is wherein more is less. So basically what we are looking at is the science and the art of neonatology. Art of neonatology is power of observation. We are all now in the last, yesterday as well as today, we learnt about science and technology and how technology has revolutionized neonatal medicine. We are constantly getting newer technologies, point of care in laboratories, point of care in investigations, and that basically has made a lot of aggressive change in neonatal care. What is important here is, it is a transformation of this knowledge into practice, which is wisdom. And that is the art of medicine. So basically, integration of art and science is a must for holistic care for all of us sitting in this auditorium. What did I do beyond clinical care? Well, I was lucky to be involved and associated with the government of India for advocacy roles, where we were involved in designing the packages for newborn care health in economically backward sections. And this was Ayushman Bharat, where we had 3 or 4 meetings, and I was lucky to be a part of this group where we designed packages. And if you have babies who are below the poverty line, the government of India has made subsidized rates, and they have offered packages for all the hospitals which are taking Ayushman Bharat, which is a very, very good initiative taken by the government of India. And I think we all need to be aware of these packages, which is being the advocacy by government of India. And I would like to thank Dr. Ashok Devrari and Dr. Praveen Kumar for inviting me for this group. I was also a part of the COVID task force in the government of Maharashtra during COVID times. I take this opportunity to basically thank my parents, my mother and my father, who basically taught me through a lot of difficult times. It was a very tough time for the family to raise me. Basically, there were issues whether I should go for surgery or ortho after my MBBS. 2 of my friends told me that MD Pediatrics is a good branch for you. And you know why? Because Pediatrics is a super specialty branch. The day you pass MD Pediatrics, you sit with table and chair and you will start seeing OPD and you will make a lot of money. These friends were Dr. R.D. Patil from Nashik and Dr. D.B. More from Dhule. So, I got a locum post, and this locum post was from BJ Medical College. I was posted to KEM Hospital, Pune. So I decided I was getting ortho, I will do ortho because it was a paid branch, I would have earned much more money. But they said, no, ortho involves a lot of investments. It is a very expensive branch. You may not be able to afford all those. So I went to pediatrics and I met my guru, my mentor, my teacher, my role model, my inspiration, Professor Dr. Anand Pandit. I worked for 6 months as a locum pediatric resident, and I was still not sure whether I was going to do pediatrics. But then sir used to come and he used to take rounds every day, and I was like a just past intern. I used to do blood collections, collect labs, and I used to see sir. He used to just listen to the history, take rounds, and come to a logical clinical diagnosis. And that was turning point in my life that I took up pediatrics. And I owe a lot to my teacher, Professor Dr. Anand Pandit. The twist in the tale happened that I was first. And there was, in those days, there was residency and PG student. Unfortunately, the open merit seat came in BJ Medical College and Sassoon Hospital. So I had to take my residency at Sassoon. But I told Fadke madam that I want to go to KM, which was not possible. So my guide and my teacher, Dr. Sudha Chaudhary, grabbed me from Sassoon to KM. So I was working in KM and Sassoon was paying my salary. So a lot of credit happens to the team at KM, Dr. Sudha Chaudhary and Dr. Anand Pandit. And the person next to Dr. Anand Pandit is late Professor Dr. Jayant Devdar. He was an astute clinician. Unfortunately, we lost sir quite early. And he was a teacher par excellence, ahead of time. He would use internet, collect the references, and he would teach every day in the rounds. And he was very good in spotters. He would see a baby and say, this is quacked. This is intracranial bleed, so on and so forth. And you could see our staff, Dr. Umesh Vaidya, who still looks as young as today. We have Dr. Mishra, we have Dr. Otiv, and most important, we have two of our trusted people through which the department ran. That was Premlata, just standing on the right-hand side, and there's Anjali, who is standing in the last row. So these are two people through which the Department of Pediatrics actually ran. So I'm grateful to the team at KEM. They have been a lot of support from the Department of Pediatrics, and I express my heartfelt gratitude to the department. I came to Bombay and coming to Bombay from Pune was very difficult to get adapted because Bombay was faster than Pune. I met some of the legends, and the legends that I met, we all know Irani madam. Definitely she helped us. She used to take Rishikesh, Sanjay Ahir and me from Pune, Nashik, Aurangabad, various parts of remote interior Maharashtra to do the NALS workshop. We used to call neonatal advanced life support workshops. And madam used to teach us the clinical tools of how to keep the baby warm, how to hold the baby, how to start, and how to teach all the doctors, residents, nurses, and we learned a lot from those workshops. I'm sure Rishikesh would agree that we had a wonderful time. We in fact even went to Belgaum by road to do the NSSK training, and that was something which remains in our heart. So thank you, madam. At Sion, we had Professor Armida Fernandez, who was my guide and teacher. She taught us about empathy. She taught us about palliative care. She taught us about less invasion and more optimal outcomes. Dr. Monkar was just opposite. She was very aggressive in terms of treating the babies. She would never waste an opportunity to intubate and ventilate and do everything possible under the sun that life is not lost. She would say one statement, never play God, do everything that you can to save that life. And Madam Monkar really taught us everything in the rounds, and she made a different human being out of us. We had Dr. Rekha Udani and Dr. Ruchi Nanavati from KEM Hospital, and every Thursday, 2 to 5 was a time when we would interact, and Madam Udani and Madam Nanavati would definitely teach us a different aspect of neonatology. When it was teaching, training, they were very meticulous, they were researchers, and they were quite strict in terms of doing the presentation. Suppose we had not done, it would be difficult to face them. So we used to remain awake and do the needful and present it at 2 p.m. on Thursday. I made good friends in Sion. One of the best friends that I have made is Rishikesh, who is sitting just here across. He was my neighbor who would take a lot of care. He would help me do a lot many things, and I'm grateful to Rishikesh, Sheila, and Arjit and Shankar. Basically, they were there to, it was like an extended family, because I was alone in Mumbai and all my family was in Pune, so it was quite tough to getting adjusted in Mumbai. I would fail in my duty if I had not met Professor Dr. Sanjay Patole. Well, Patole sir is somebody who is always willing to help, and I was fortunate to have got his mentorship, to have learnt a lot from Dr. Sanjay Patole, who is Professor Daga's student. And well, Patole sir truly inspired me to ask questions and do simple clinical relevant research. I was never good in, never understood ABC of statistics and never understood how to write a paper. And he would teach me, you have to sit and try to answer simple questions where you don't know the answers. And with Dr. Patole's guidance, we were able to do some research. Amit, I think we did first trial on bubble CPAP versus ventilator CPAP, and this was a randomized controlled study in KEM. Then we looked at RAMS versus Hudson. The first few years we did a lot of work on CPAP. Then we also published this on surfactant. Infections were very common, and we did one randomized controlled trial of routine use of antibiotics, which was prophylactic versus no antibiotics, and this was published in Journal of Hospital Infections. We also looked at emerging hospital resistance in Pune, which was published recently. And these were some of the studies which we published in Journal of Tropical Pediatrics, where we looked at time to full feeds in VLBW babies. Then came the Diamond Jubilee call for retinopathy of prematurity and premature baby package. This was initiative by the Public Health Foundation of India, where KEM Hospital and HB Desai got funding, and this was from the Queen Elizabeth Trust. We did some work on retinopathy of prematurity, wherein we were involved. A part of our grant was basically to look at SNCU training of all the nurses and all the medical officers across Maharashtra state. And this was over 3 years that we did this study. Basically, it was more of service than research, and it was very, very interesting, interactive, and I learnt a lot, and I'm sure I tried my best to impart some education to the SNCUs across Maharashtra. We also went to Nagpur, we went to Daga Hospital, and we went to Dharavi, which is near Melghat, to look at the logistics and the functioning of SNCUs. And it was satisfying that I learned for the first time that it is not, neonatology is not NICU in the four walls of the NICU, but you have to go beyond the four walls. You have to reach the community, you have to learn a lot, and I really learned a lot of neonatology when I visited the SNCUs in these places. We have two countries in our own country, one is India and second is Bharat. And I was very happy as a young enthusiast. I was happy sitting in KEM and managing India, but Bharat is different than India. We also published a lot of work in ROP. Then came KMC. My thesis was on kangaroo care, where Professor Armida Fernandez told me to look at feasibility of KMC in Mumbai. And I asked Rishikesh, I am doing DM and what is the thesis that I am getting? It is so simple. Do you think it will get passed? That was my first question. And he said, no, Madam Fernandez is a visionary person. And if she has given you something, it is worth doing and you should do it with a lot of zeal and sincerity. And that paper got published in the Indian Journal of Pediatrics. And then we looked at doing early kangaroo care and its effect on time to full feeds, which was a prospective cohort study which was published with Deha Pandya's thesis. Then we also looked at feeding and probiotic supplementation with Dr. Patole. And my better half, Archana, is a developmental pediatrician, and we published these two papers about general movement assessment in preterms and outcome at 1 year. This was recently published in Journal of Pediatrics X. And a video-based screening in COVID-19, where she looked at autistic children videos, and we also looked at definitive diagnosis after some time, and this was quite well taken in the Science Direct Research in Autism Spectrum Disorder. I was happy to be contributing to some chapters in some of the textbooks. Basically, it helped me review the literature and improve my style of writing, and I learned a lot during these contributions. With my friend Srinivas Murki and Rishikesh and Dr. Devrari sir, we contributed some chapters in workbook on CPAP and neonatal ventilation book. So this was again something which we keep on learning, relearning about non-invasive ventilation. I was accidental president of the Maharashtra State NNF, and it was thanks to Dr. Umesh Vaidya. I think I would say he's a very good, great friend who pushed me into this, but I learned a lot in this state leadership experience. Thank you, sir, for pushing me into it. we had 2 conferences and we had some online activities in the Maharashtra State NNF activity, and I was fortunate to have with us Dr. Sunil Gawane, who is a young dynamic neonatologist from Aurangabad, and believe me, Sunil today is a much changed Sunil than what we started with, and he is so sincere, he is trustworthy, he must be shouting behind my back. Or rather cursing me, but I am grateful to Sunil, I am grateful to Ashish Dongde, who was treasurer with us during the state NNF leadership, and most important, grateful to all my team members, Sanjay, there was guidance from Dr. Kabra sir, guidance from Dr. L.S. Deshmukh sir, Rishikesh, so they are all, it was a teamwork, Dr. Vaidya sir, Dr. Tushar, so all of them contributed a lot. Shilpa was there, quite active in the state NNF activities. So basically grateful to all of you for your contribution during the 2 years of tenure. I learnt a lot about accidental leadership that I got in the Maharashtra state NNF activities. I am grateful to Dr. Ashok Devrari and I am grateful to Professor Praveen Kumar sir. The reason basically is that, well, we met these 2 legends because of Irani madam, and both Rishikesh and me got associated with 2 teachers who were into academics, into teaching. Basically teaching training was something which we learned from these 2 legends. We did a lot of workshops initially on CPAP, then mechanical ventilation. We used to go across the country for 4 days, and we used to teach a lot of nurses, residents, practitioners, doctors. I don't know how much they got benefited, but in the process we definitely got benefited. And we made some good friends in having Ashish Mehta sir, Srinivas Murki, Naveen Jain, Rishikesh obviously was there, Suman. So basically we made a lot of close acquaintances and close friends, and these relations remain very tall and healthy in today's time. Basically, thanks to all the like-minded people who came together, and the idea was to teach and train non-invasive and invasive ventilation. Being associated with the SNCUs, I was very happy, and I'm still a part of teaching, training the SNCUs across the state of Maharashtra. There are 38 SNCUs, so we used to visit Satara, Karad, Pandharpur, and we keep on doing those 6 monthly mentoring visits where we try to teach and train the nurses, the medical officers and the pediatricians. But the scenario is different. There's one sister and there are 15 babies. Now how our mortality and morbidity is going to decrease? So we are talking of this Bharat where there is disproportionate nurse to baby ratio, and that is the bottleneck as far as outcomes are concerned in the government sector. So basically here comes the role of involving the mothers and involving the parents in the care of babies. So this is basically what we are talking of mentoring. We go there, but I don't know how much of help we are for them, because the infrastructure and the personal difficulties are too far, and I don't know how much we can contribute to those difficulties. I have made a lot of friends. Basically, when you look at clinical medicine, when you look at profession, you need to have good friends who are there for you. At work front, well, you have many colleagues, but when it comes to friends, I have had 2 excellent CRs. There's Vikram Dabde and Bhushan Dev, and there's Vikram Ghaute. So they used to take care of me. They did trouble me initially, but then probably the trouble was more for good than bad, and they disciplined me into becoming a better human being. I have Tushar, Dr. Vaidya, Sanjay, Rishikesh, who are there. Then also Rishikesh along with Abasai Patankar and Sunil Shet, who are unfortunately not here this morning. We have had Amit Nigde, who is here, but basically all these people are there to support us in difficulties and also guide you and groom you. So basically sitting in this room, all of us should have good healthy friendships and friends. 2 people who have made a difference in my life is Sudhakar, who is there with me since my undergraduate days, the one on the extreme right, and there is Dr. More, who guided me to take into pediatrics, and I jumped into pediatrics because of him. He is at Dhule. So all these friends make a lot of impact in your life they touch you, they help you become what you are, and I'm always grateful to all my friends. Thank you very much for your support. What is the future of neonatology in Maharashtra and India? Well, this is the future. You see a lot of your students here, now they are your colleagues, and then soon you realize that you want them to be better than you. So I look forward to seeing all these superstars taking up the baton of neonatology, not only in Maharashtra but India and abroad, that you people have to carry on this good work. Believe me, if your ideologies are clear about do no harm to babies and do good to community and your patients, I think you are going to be successful. Nothing works without team, and I'm grateful to my team at KEM Hospital, that is Dr. Umesh Vaidya, Tushar, and all the nursing staff, all the resident doctors, all the colleagues, all the maushis, and the team at KEM and team at MGM is something which you look forward to. We have with us this young dynamic doctor who was our student, Dr. Deha Pandya, who now is my colleague, and we work together at MGM Hospital. So it was wonderful having Deha with us, and he is one who has very clear ideas that, sir, we should get this baby, do well, don't worry about anything other than that. So, and that's what I like about him. He's very, very sincere, honest. So I look forward to working with Deha in the years to come. I have been lucky to have two beautiful children, Ajinkya and Siddhi. Well, Ajinkya is very quiet and Siddhi is very naughty, but both of them have tolerated my absence, my not being at home, and I am grateful to them, because when I am not there, mother is there, and they have been single-handedly raised by Archana, and I was just about there and not there. So Siddhi and Ajinkya, I think they have got more mother than the father, and they have really loving children and kept us happy as always. I would fail in my duty today if I don't say a few words about Archana. Well, Archana, as we all know, she took a back seat. She was topper in BJ Medical College. She was more clever, more intelligent, more able, but she sacrificed her career for me. She took a branch which nobody would like to take. That's branch with disability, developmental pediatrics. And in 20 years ago, she was wondering whether I would get any patients. And today, 80% of phone calls come to me for her appointment. And today, whatever I am, it's only because of Archana and my parents' blessings. Archana stood with me. She, in the difficult times where we had nothing in front, she was the greatest support that I have had. And I always am grateful to Archana. When we finished our MBBS and MD, we are all the time thinking, I need to have house, I need to have the best car, I need to have name, fame, money, people need to recognize me. Well, as you become old, as you cross 50, then you realize that the true measure of success is not all these. Because my friend sitting here told me, if you have Vikram Dabde, that if you have 5 cars with BMW, Audi, you can only drive 1 car at a time. You can't drive 2 cars at one time. So the true measure of success is basically how happy you are. And I think that is the most important message that I would like to convey over here, that we need to be happy. So success is not the key to happiness, but happiness is the key to success. So if you love what you are doing, you will be successful. I think that's the basic bottom line that we all should remember. And if you look at evidence, if you have happiness on x-axis and life on y-axis, then success is exponentially proportional to the degree of happiness. So this is as simple as that. So from today, I want all of you to be happy and success is yours. So what is the next for newborn babies? Basically, the next generation should focus on emphasis on basic newborn care, because our Bharat still needs basic newborn care and newborn nursing empowerment. Follow-up is essential because we need to save babies, but save babies with good outcome. They need to have intact survival. We can't produce children with disability. We can't produce children with CP, microcephaly, epilepsy. So all these follow-up services are essential. We need to have our involvement of the family in the newborn care. So that's very important, especially because if you have family participatory care, if you have mothers who are involved in the NICUs and the SNCUs, your outcomes are going to be different. And quality improvement at all steps. I think this is what is important for the babies and for all of us sitting in this room to focus on and to concentrate. So some pearls for practice. Our approach should be towards prevention, early diagnosis and prompt management. I think we are all excellent in this. We are exceptionally intelligent and exceptionally able and capable of doing these preventive and early diagnostic tools. I think we need to remember that technology should not be allowed to dehumanize neonatology. And to me, this is very important. Don't allow your echo machine to diagnose sepsis for you. You should be able to diagnose sepsis just on your clinical judgment and acumen. You should not allow technology to tell you that this is sepsis and this is not sepsis. The day it happens, all of us will be out and the AI people and the machine learning people will come in the NICUs. And very important, all of us are pediatricians who are good at heart. So we need to treat our babies not only with our brain, but more so with our heart. I think if we do this, then probably the error for margin is very less. We would do very little mistakes in our day-to-day practice. So coming back to these four wheels, we need to look towards our health, in our family, also have our work-life balance, and most important, contribute to society. If your four wheels are moving forward in equal or more or less they are moving together, then our life will keep on moving and we won't be stagnant at one point. To end, if something is good, then more must be better is what we always believe. But this may not always be true. Why? Because do less and gain more. Thank you very much. And I would like to thank Nishant and Sanju for their inputs in making slides. Thank you very much.
Thank you, Sandeep. May I invite Professor Simeni Rani on the dais to felicitate Sandeep. And I also invite the Mahanecon team, Dr. Atul Kulkarni, Dr. Vikram Dabde, Dr. Sunil Vaidya, Dr. Dayanand Nagate, to please come on to the dais. Dr. Sandeep Kulkarni. Dr. Vikram, our scientific chair.
I request Dr. Archana Kadam, please come on the stage.
Just announce the next.
नेक्स्ट क्या देख लो तुम्हारा ओरेशन का काम हाँ पहले से ही टाइम टेबल प्रमाणे है ना अभी क्या है
Adequate nutrition during health and sickness is essential to ensure optimal growth and long-term development in a newborn. To moderate the panel discussion on optimization of nutrition in NICU, I invite Dr. Umesh Vaidya. I invite the panelists, Dr. Dattatray Kulkarni, Dr. Ashutosh Yajurvedi, Dr. Piyush Shah, and Dr. Deepika Tiwari.
So good afternoon everyone, and after this wonderful and inspirational oration, we now come back to the conference, the panel discussion on nutrition. Now, just to set the ball rolling, it is in this century only that people started talking of postnatal growth failure and achieving optimal growth. And this decade only we start talking of aggressive nutrition. And we want to do what the placenta did, to make our babies grow just like they grew in the womb. And this is what we mean by optimal growth. Babies should grow, is initial postnatal weight loss, and the baby is growing at 16 gram per kilo per day. This is what we expect them to grow. And this was the standard practice around 14 years ago. And most of us followed this practice. We use human milk, we used to grade them reasonably well, we used to fortify milk, start early TPN. But in spite of doing this, you can see this particular baby that I am showing, where all the standard treatments were given as per the protocol, but this baby still you can see has fallen off the centiles and has fallen from the 30th to the 3rd percentile. This is a baby with no TPN, very few feeds, and you can see on day 26 the baby going right down, and we see so much of EUGR in our babies. So this panel today is to optimize bedside nutrition in the NICU, and we have 4 very young neonatologists to answer this panel. This is Dr. Piyush Shah. He didn't have a beard before. He's got a beard in this photograph. Then we have Dr. Dattatray Kulkarni. We have Dr. Deepika Tiwari. And another person who has grown a beard later on, he is Ashutosh Yajurvedi. So we have these 4 young panelists and they're going to help us to decipher this panel and see how we can make babies grow better. A small request to the panelists, we have to finish in 45 minutes. Keep your answers brief and tell us mainly what you do and give clear messages at the end of the question. So we go to round 1, and when we designed this panel and we sent the question, there was no discussion, so all the panelists have been very free and liberal. So Piyush, a question to you, that what happens if baby doesn't grow? Baby is sick, RDS, shock. This baby doesn't grow in the NICU, kya farak padta? Baby can always catch up later. We always know that once you treat the morbidities, babies will grow. So why are you worried about growth in an ICU?
Thank you, sir. So in past 2 decades, probably we all have changed our thinking when it comes to saving lives, because it was not only about saving lives, but now we are talking about intact survival. At the same time, we've started moving to more smaller gestation as well. I think many of us are comfortable definitely above 28, but some of us have started going least to 25 and some claim up to 24 also. But we forget to understand that the last few weeks of life, that is usually the end of the 2nd trimester and the part of the 3rd trimester, that major accretion of nutrition will happen to the growing fetus. Now, the day the baby is born, the fetus is born and now a baby, he is already in a catabolic state, because Joe nutrients the baby was supposed to get from the mother is suddenly cut off. So yes, you may try mimicking the intrauterine growth. Unless we are really aggressive to meet that requirement, that will not happen. So if we worry, we have to worry the right way, otherwise we better don't start treating them. For the growing fetus, the requirement is nearly 110 to 130 kilocalories as energy per day. Now let's imagine it's a 1 kg baby born. If we've just given dextrose to this child, even if you put 10% dextrose and you started at 100 ml per kg per day, you're probably going to end up giving only 40 calories to that child, making which he's going to be in deficit, and that deficiency is going to kill some of the protein of his body, because for every protein accretion of 1 gram, he requires 30 grams of non-protein calories. But if this is not done, the reversal is also happening, making which, if the nutrients of his requirement as protein, lipids and energy is not met, he's going to start going on a deficit side. And that's not only going to affect his linear growth, but importantly, it's going to affect his brain growth, because brain tissue is also going to get lost. Thus, if the nutrients are not rightly met, probably they are going to have poorer neurodevelopmental outcome at 2 years, which would be more of motor. But now we are seeing psychomotor, psychosocial skills also being affected if the right nutrients are not being caught in the early life. Thus, I think so nutrients in the early life would be very, very important and crucial.
I think people only spoke of nutrition growth, nutrition growth, nutrition growth. It is now that people say nutrition neurocognition. And there are many studies now to show that even the first week nutrition affects your IQ as early as 18 months. So we are really looking at something very serious, and I think because of the impact of nutrition on neurocognition, I think this aggressive nutrition has come into being.
Yes, sir.
So, Dr. Kulkarni, I wanted to ask you that we are talking of more growth. So can you tell me what is the minimum, what is the desirable, and what is the ideal? Do you have any benchmark? We are talking of, say, babies 1500 grams and below, because these are the babies who have nutritional issues. So can you give some figures?
So whenever there is a very low birth weight baby, this is a baby at the stage of rapid growth. So what will be the ideal growth will be it mimicking the fetal growth. That is definitely above 20 gram per kg per day. So till 36 week, the baby intrauterine life grows at 20 to 30 gram per kg per day. So that will be the ideal growth. And what we say desirable means, suppose at birth baby AGA, and at discharge or term corrected gestation, the baby is following same centile. So that is a desirable. So that would be something between 15 to 20 gram per kg per day. And so bare minimum means the baby should not crossing major centile or losing at least 1 Z-score at growth, at discharge or at term corrected. That will be minimum 10 to 15 gram.
Yeah.
So the numbers are 10 to 15, that is a minimal to prevent postnatal growth failure. Desirable will be 15 to 20, and more than 20, that will be an ideal scenario.
Absolutely. People always believe that mimicking intrauterine growth is not possible. And we also are always told that you can never grow at intrauterine rates once you are born. But now that's not the case. Our babies grow well. They can grow even at 30 grams a day if you do the right things. So perfectly right, minimum 10, desirable 20, ideal maybe 30. Okay? So Deepika, we want 40 now, we want 50. More the merrier. Now we know that brain will grow better. So why not give them 40, 50 grams in a day? Because we want babies to grow even faster.
As a neonatologist, we might feel, or sometimes we may feel that it is good actually baby is growing very fast, like a fast catch-up growth during once he has started gaining weight. We have a better value to tell to the parents also that baby has past weight was this much, now present weight is this much. But exactly research studies have shown that faster catch-up growth is associated with metabolic syndrome, overweight. There are many abnormalities in the lipid profile and associated with the adult onset cardiovascular disorders also. So this optimal growth should be achieved, should be the target, because it's a kind of a double-edged sword also. So we have to balance the growth adequately so that we should have a potential neurodevelopmental outcome and to avoid this late onset metabolic complications also.
Exactly. Thank you. So what has happened is even in the Pune low birth weight study, they showed that babies who grow very fast had insulin resistant at 4 years. So because we don't check it early, we don't know. But if you make them grow fast, you're going to have hypertension early, you're going to have insulin resistance and obesity in their later life. So what Dr. Kulkarni said is fine, 20 to 30 grams a day, but be careful of not pushing growth too much. So it is not very safe to make babies grow faster. Now, growth charts. So Ashutosh, can you tell us that which growth charts to be used in NICU babies in the first few months? Things keep on changing. So what do you use?
Yes, sir. Actually, a right measure is required for measurement of the growth. If we don't have anything, then we don't know whether baby is growing well or not. So there are different types of growth charts. They are gender specific as well as they are for preterm as well as term babies. For term, we follow WHO growth charts. For preterm babies, there are infant and feto-infant charts. The charts, they follow the trajectory, the intrauterine growth trajectory, how baby should baby should grow. There are some longitudinal growth charts. They usually show the dip which is seen at initial week of the life and later the growth in the baby.
So what are you using?
Fenton.
Okay, so Fenton's chart is what most people use. Yes. And people now have moved on to intergrowth. So I think this is something that is a more recent, and I think we should now graduate from Fenton to intergrowth. Okay, yes. And of course later on, as you rightly said, we move on to WHO charts and we take the 40 weeks as the corrected age for the preterm babies. Okay, so thank you. So now we go to the second round. How to achieve optimal growth. We saw the importance of growth, how to monitor growth. Now how to achieve that we will see. And we talk a lot of parental nutrition in very low birth weight babies. But Piyush, you tell me that is it feasible in our units? Now Dr. Kadam said it's India and Bharat. So what do you do? There are so many SNCUs with small babies, there are so many smaller units, products are not available. So it's not feasible. Is there any weight cutoff that you use to start PN? Like we use 1500 grams in KEM. So what do you use and what do you recommend for other units to use? And any suggestions for the smaller units? Should they go for parental nutrition at all or they should just manage on enteral nutrition? So what do you think about this recommendation?
Thank you, sir. So for the weight cutoff...
First tell us what you do.
Yeah. So primarily, sir, in our unit, any baby whom we cannot feed completely, say around 120 ml to 140 ml per kg per day by 5th day of life, probably we would start them on some parental nutrition, especially if the baby is born less than 28 weeks, definitely. 30 to 32 weeks, there would be a gray zone, but 28 to 30 weeks, again, if you're not able to achieve by 5th to 7th day.
Any weight criteria?
So less than 1000 definite, 1000 to 1500, I would say 1250 and below definitely, and above 1250 if you're able to go aggressively on the
So what do you suggest for these other units?
Yes, sir.
So the government of Maharashtra asks you about SNCUs.
So for the smaller units, now that one of the studies which has been supported by Dr. Sushma Nangia's group from the north, where they went aggressive enterally for less than 32 weeks, less than 1500 and above 1000 grams, they did find that if they went from day one, as per the age appropriate fluid, they did not see an increased incidence of NEC, which is the biggest fear when it comes to smaller ones. And definitely if in your unit, the feasibility of TPN is an issue, one may consider being aggressive feeder. But even in smaller units, if TPN is taken as sacred as blood product and all possibilities of infections have been controlled, while may not mixing, but if you have enough number of syringe pumps in your unit where you can dedicate one syringe for protein, one syringe for lipids, and one syringe for dextrose, and through a Y connector with a dedicated peripheral line, even the smaller units in the early life can be doing TPN in their unit. Yes, laminar flow would be best if it's available to prepare, but even if you treat it as a blood product and do all asepsis possible, one may consider doing, but aggressive feeding starting early as possible so that the need of TPN is on the minuscule would be the takeaway for the smaller units.
Yeah. If you take the national recommendation, any unit that deals with babies 1500 grams and below and who keeps surgical babies should have the facility for TPN. That's the national recommendation. And if you can ventilate, you can certainly give TPN, correct? So I think those who are not doing it can adapt it and slowly develop it, of course without complications. Okay, but I think our cutoff is 1500. People can decide what cutoffs they would like to choose, but certainly below 1 kilo. Right? Okay, so this confusion about amino acids and lipids. So Dr. Dattatreya, some people say 1 gram, some say 1.5, some say 3 grams. So what should one do? Should we be aggressive or conservative with TPN? And what do you do when you start TPN for your babies?
So before understanding the TPN protocols, we have to understand something. What do we mean by conservative and what do we mean by aggressive? So aggressive by word itself, it's little misnomer. So what we mean by aggressive is optimum. So optimum nutrition providing in initial first week has definite evidence. So providing that is also quantitative effect. Suppose first week protein is provided, 1 gram extra protein provided, it has effect on mental developmental index at 18 months.
So what do you suggest? What should we do?
So we have to go.
What is the minimum again and what's the maximum what you think you should do?
So we should start with amino acid 1.5 gram and lipid 1 gram on day 1 itself. And we can progress to full TPN. That means by 4 gram of amino acid.
Over how many days?
3 gram of, by 3 to 4 days. Okay. I would reach full TPN.
Okay. So not less than 1 gram per kilo is the answer. Not less than 1 gram per kilo, not more than 3 to 4 gram per kilo.
Yes.
And better to start in the middle. So we start at 2.5, you start at 1.5, but certainly not below 1. Right?
Yes.
Right. So now coming to starting enteral feeds, and first, Deepika, I would like yes or no for these things, that you want to start enteral feeds, but these are the situations. Baby is ventilated, you can still start enteral feeds, yes or no?
Yes, sir, we'll start ventilation.
Hemodynamic instability needing inotropes?
There are no definitive answers.
Yes or no, ma'am? Baby is not in shock, he's just on inotropes.
I'll start, then I will start.
Abnormal Dopplers, reversal of end diastolic flow, yes or no?
Normal diastolic flow, then depend upon the condition of the baby, abdominal conditions generally, we can start early, but for the hiking of the feet we have to be vigilant.
But you will start or not start?
I will start, but
okay.
I'll be vigilant.
Baby is not past stool on day 1.
If generalized abdominal conditions are okay, then definitely I'll start.
1.5 ml green aspirate.
Only isolated green aspirate is not associated with NEC.
You'll still start?
I'll still start.
Umbilical lines in situ, USC and UVC.
If it is umbilical venous line, then there is a no fear. But in umbilical arterial line, if it is a lower or upper, if it is in between somewhere, neither it is lower, neither it is upper, not in the appropriate situation, then I would be worried for the chances of arterial ischemia. So then I would like to remove umbilical arterial line, then we'll start. But if it is either well appropriate position in upper or in the lower, I will still start.
Okay, the answer is yes, 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 and yes. Okay, so these are not contraindications for not starting feeds. You can start feeding these babies unless the baby is in absolute shock, pulseless, you're doing volume resuscitations, you may withhold. But most of these situations, even if your UAC is well in C2, in the right place, you can still feed these babies. Maybe you can be cautious as you said, but you can start enteral feeds in all these babies. So my next question to Ashutosh is this baby, we want to start minimal enteral nutrition, but typical problem, mother is in another hospital, EBM is not available, but we want to start MEN. Common question that is asked, and I will quote one panelist who was with me from Fortis. So somebody from the audience asked this question. So he said, what did you do? So he said, I use mother's milk or stolen milk. So we all fainted. I said, stolen milk? He said, we take some other milk and chupchap hum de dete hain. So unfortunately, you should not do that. So Ashutosh, what do you think you should do? Formula or commercial human milk? What is your thought on it? Do you use it? Should one use it if mother's milk is not there? And also in the same, you asked me, what is this oropharyngeal colostrum and do you practice it? Is it easy to practice or difficult?
We are not practicing it at this moment, but we can try. Papers have suggested that this oropharyngeal colostrum won't cause apnea or any mucosal damage. Basically, this oropharynx is continuously getting exposed to this immunoactive factors in the intrauterine life through amniotic fluid. Whenever this amniotic fluid after birth gets replaced with breast milk, that breast milk also has immunoprotective factors.
Okay,
and
so it should be done, right? Not that difficult
not
at all?
Difficult.
Few drops you need,
yes,
right? Okay.
That should not cause any problem.
Yeah, Shilpa, you do it in Dinanath? Yeah. Okay, and what about this formula or commercial human milk?
No,
you have an
actually,
option.
In Solapur, we don't have milk bank, so we have to rely on formula only.
Okay.
If mother is not
Have any of the panelists used commercial human milk for gut priming? Do you use it? Dr. Dattatra, do you use it?
So there is no human milk banking at where I am working. So donor milk is not feasible.
Okay, Deepika?
We use donor human milk, sir, next to the
Have donor
MR.
milk.
Yes.
Okay, but suppose you have none of these, you have only formula, can you still do it? Or you should not? Okay, you can still do it. Okay, so if you have nothing, even if do not stop MEN, even if there is formula, you can give it. Okay, third round, how to optimize enteral feeding. So Piyush, tell us how to grade up feeds and what do you normally do? We are talking of babies who are around below 1500. And should there be a different strategy for birth weight below 1 kg, abnormal Dopplers, SG and precious baby? Do you have any different strategy or we follow the same?
So for most VLBWs, we would be starting gut priming. If possible, we would be going for full enteral feeds also, but if the child, we are starting gut priming within the first few hours of life, and thereafter, on a conservative side, we would increase 20 ml per kg per day, but if the baby looks stable, we have gone aggressively to up to 40 ml per kg per day as well, aggressively, so that we are off lines by day 4, day 5. Some of the VLBWs who are on the higher side, we've completely gone on enteral feed from day 1 itself. So the same strategies for the high risk infants as well. For the extreme low birth weights, on day 1, the minimal enteral feed has to be 10 to 20 ml per kg per day, and thereafter we conservatively step up 10 to 20 ml per kg per day, provided EBM is available or PDHM. Sometimes, yes, as pointed out, both of them are not possible, and we have gone aggressively with formula also for first 72 hours, where we continue with minimal enteral feed and then we grade up. For abnormal Dopplers, unless there's a vast discrepancy in centiles, we have not given much importance to those abnormal Dopplers, and we've started feeding on day 1 and went up on 10 to 20 ml per kg per day. Otherwise, for the first few days, we would have left them on minimal enteral feed of 10 to 20 ml per kg per day for first 3 days and then gone up. For SGAs, there's no other specific strategy that we use, and we use the same. And so what's precious baby?
Precious baby. Gynecologist called you, it's a
Every baby is precious, so no specific strategy for them.
Absolutely right, but we still use this word. It's not the right word to use anyway, but people still use that term all the time. Okay. So essentially what you said is there is no need to grossly deviate from the policy.
Yes, sir.
Maybe you are more careful in your monitoring.
Yes, sir.
But don't change the basic policy.
Yes, sir.
Okay, you'll be more careful and aggressive in your monitoring. So this is the standardized feeding regimen which most of us follow, and you can see 20 to 30 ml per kg per day grading up. Okay. So now Deepika, what is this feed intolerance? And you'll be surprised that you will not find any evidence-based medical literature on this. And this is something that affects us on an everyday basis. So just tell us again, what do? You green or yellow aspirate, abdominal distension, visible bowel loop, or increase in abdominal girth. What is actually feed intolerance? When is the batsman clearly out?
Actually for feed...
And what your unit, what do you practice?
Feed intolerance generally, whatever the previous studies have mentioned, any time or any condition, abdominal condition, in which we need to withhold the feed at least for the 24 hours, they have mentioned as an intolerance. Isolated aspirates, green residual volume or yellow residual volume, they are not associated with the incidence of NEC, which we fear really. So otherwise, if it is a frank bile, like very dark green color, then it has association with like intestinal obstruction or some other surgical condition. So gaseous this abdominal distension also, distension is because whether baby is on non-invasive ventilation support or something. If it is an NIV support, then it is very actually non-specific thing to look for this abdominal distension. But baby is suppose on the room air or on the ventilation mode, then distension may be the significant or may be the another cause for the abdominal pathology. Visible bowel loops, it depends upon prematurity also, like in very low birth weight, extremely low birth weight baby, sometimes in the normal situation because of a very small muscle mass or very thin subcutaneous fat, we do appear as a visible bowel loop. But if bowel movements are good, baby is passing stools, then it is not to be considered as an abdominal pathology. And regular monitoring of abdominal girth is also not to be considered during giving feed. So generally, if baby has multiple signs rather than the single, like it has a significant aspirate, abdominal distension, bowel sounds are very sluggish, not pass stools for the long, or stool frequency has decreased from the previous one, and abdominal girth has significantly increased, means more than 3 centimeters.
So this Simon Toffel has declared the batsman out. So what is absolute feed intolerance, where there is no dispute? So all these are sort of yes and no situations. Where do you say this is no, you have to just give the baby nil by mouth? So one thing you said, dark green, dark yellow.
Yes, sir.
Accepted. Third,
yes,
tense abdominal distension.
Yes.
And third,
and
a baby who is vomiting.
Yes.
So these are clear signs
and
where there is...
Other things are hemorrhagic aspirates also. If there is a baby having brown aspirates,
correct.
Then this
so
is
large hemorrhagic aspirates, dark green, bilious, vomiting, tense distension. Okay, these are clear-cut signs. All others are slightly low. So what with this pre-feed aspiration, Dr. Kulkarni, do you do pre-feed aspiration recommended for all babies?
Before, like baby initially on minimal enteral nutrition, so trophic feed, there is no need to do pre-feed aspiration. So once the baby is reaching 5 ml feed secondarily, or at least 5 ml per kg, and there is a background condition like abnormal Doppler, definite hemodynamic instability or asphyxia in background, then only it is recommended. Otherwise, no routine.
Fine. So stable babies tolerating feeds, not much distension, not greatly at risk, you would not. Some high risk babies you may.
Yes.
Right?
3 days back there was SR systemic review meta-analysis published on 30 June.
Yeah.
So they said that no routine checking of gastric residual volume, and also either discard or what to do with that also there was.
Our unit also was doing it for many years till we had to really teach our nurses repeatedly not to aspirate. So in spite of the order, do not aspirate, they used to mention how much the aspirate was because they were used to doing it for years. So I think stable babies tolerating feeds you don't need to. High risk babies you may. Okay, fine. So Ashutosh, this fortification, again, all babies below 1500, what is your policy? How to choose the right fortifier? And again, we have a human milk based fortifier now. So what is your view on that? Should we use it, or are there any babies in which it is recommended?
All babies less than 1.5 kg, we usually start with fortification because these babies are born prematurely and few last months of the intrauterine life, maximum accretion of the nutrients occur. Plus the nutrient requirement is very high. So we need to fortify them. For fortification, HMF sachets are there, and human milk-based fortifiers are currently little costly and prohibitive in my setup. So bovine only we use.
Okay, so we have choices now, and increase in protein, calcium, phosphorus and iron, and we have choices, but you can see the human milk based is very costly.
Yes.
At the same time, there are babies who do not tolerate the bovine fortifier at all. They keep on vomiting with it. If the parent can afford, we have used it, and one other advantage is you can start it early.
Yes, sir.
So you can even start at 30 ml per kg, you can start adding it. So
Yes,
in people who can afford, people not tolerating bovine human milk fortifier, I think there is still an option of using the human milk based fortifier. So fourth round now, that is the second last round. Simple question to Piyush. Give a simple answer. Which supplement to be prescribed to a term baby at discharge? We see multivitamins, calcium, enzymes, and we see what not. I mean, the maternity prescription is a whole lot of things. So what is really needed to a term baby at discharge? Tell us what IAP says, and if there is any other deviation in any other society. So WHO IAP, what is term baby at discharge?
Both WHO and IAP, other than vitamin D, 400 international units per day. That's the only recommendation for every term.
Calcium?
Baby. Not needed.
Multivitamin drops?
Not needed.
Not needed. Okay, so only vitamin D. Again, global recommendation, and I don't know, people are aware, 2022, IAP has released the comprehensive nutrition module with clear guidelines on supplementation of preterm, low birth weights and term babies. So we should refer to that. So Dr. Dattatreya, for a preterm at discharge?
We have to continue fortification if
Okay.
the baby is on mother milk.
Okay.
Fortification we have to continue till the baby reaches 3 kg or till 40 week. And if the baby is at birth was AGA and at discharge it is SGA, then we have to continue another till 52 week fortification. And if the baby is not on mother milk and fortification, if on preterm formula, then vitamin D supplementation needed till 1 year.
Okay, exclusively breastfed?
If the baby is exclusively...
After you stop fortifier, what will you start?
only vitamin D. Vitamin D and iron till 1 year.
Okay, so what has essentially happened is fortification after discharge can be done, very tedious to do it. We generally do it till 2 kilos. But when the baby is on a fortifier, no other supplement should be given because fortifier contains vitamin D, iron, calcium, phosphorus. So do not add additional things when the baby is on fortifier. Once you stop the fortifier, then you can start with your calcium, phosphorus, multivitamin and vitamin D. Okay, but I think we will go to the IAP module and those things will be relatively clear. So this is the module and I think it will be rolled out across the country and will be held in Solapur as well. So this contains all those guidelines. So again, MCT oil. We are asking the role of MCT oil both in NICU and also in follow-up prescriptions. We see 5 drops 3 times a day in the prescriptions of pediatricians. What is your take on this?
Sir, actually really none of the consensus guidelines recommend use of MCT oil either in the NICU for catch-up growth or in the later follow-up also. So because studies have shown that use of these MCT oil might lead to associated with the overweight and later on metabolic syndrome. So generally if the baby has a cholestatic feature or suspected to have fat malabsorption, in these selective babies we can use MCT oil for better weight gain, otherwise it is not recommended.
Okay, so evidence very, very poor. It's monocomponent fortification, both in NICU and follow-up. It has virtually no role. In fact, it's very risky to give it on an outpatient basis because of lipid aspiration. So it's not safe to give MCT oil and it has to come out of all the prescriptions. So now we ask Ashutosh, this complementary food in preterm babies as per actual age, corrected age or on mother's request?
Again, this is also something gray, not conclusive evidences are...
That's why we have asked you, that's why we have...
Actually, this is very difficult. It depends upon the maturation of the child. If child is ready and oromotor, these things for semi-solid food, it is child is ready, then when we can start.
But parents tell you, na, देखता रहता है, हम खाते तो हमारी तरफ देखता रहता है. This mention that, isn't it?
Yes, sir.
And mothers usually will push you. So what is the bare minimum below you which you cannot?
Less than 4 months we avoid. Corrected 4 months. Below that we don't start it, but it is better to start at 6 months because recently...
No, again confusion is corrected or chronological.
corrected age.
Corrected age 4
Correct,
months.
4 months.
Is the earliest, and any weight, approximate weight, because people we are
5 kg they say.
Yeah, correct. So again, as he rightly said, little bit of confusion. Every baby is different, but sometimes that 800 grammer at corrected age 4 months may be just 3.8, and you don't know the baby looks so small to eat dal rice. So the recommendation guidelines are very loose, but people say not before corrected age of 4 months, and usually baby should be around 5 kilos. So that's a rough guideline, but again, oromotor reflexes, baby's partial neck support, all that will definitely count in this. Okay.
Individualized.
Okay, so now we are going to play KBC, and believe me, so next few questions panelists are not aware. So we are going to have a proper hot seat. Audience can participate provided the participant asks you your help. But the participant on the stage, you are not aware of this question. This is suspense. You can ask your friend on the dais before answering, and you have around 1 minute to ponder on that. So who is on the hot seat first? Is Dr. Dattatreya Kulkarni. You are on the hot seat. Okay. ये पहला सवाल आपके लिए. 1.2 kg baby on full feeds at 150 ml per kg per day. He's growing at 8 grams a day. आप क्या करेंगे? Increase feed volume, switch to formula, add supplemental parenteral nutrition, or add MCT oil. You think? बहुत समय है आपके पास और सारी हेल्पलाइंस आपकी खुली है.
Start supplemental parental nutrition.
Okay.
Fortification.
आपके पास हेल्पलाइन अभी भी है. अगर श्योर नहीं है तो आप पूछ सकते हो, ऑडियंस से पूछ सकते हो.
Sir, increased feed volume. I can go till 200.
कौन सा लॉक कर दूं? A, B, C या D?
Sir, ये.
A. बिल्कुल सही जवाब. Okay, next on the hot seat is Dr. Ashutosh. Standard bovine HMF provides which additional nutrients? Iron, protein, calcium, phosphorus, or all of the above?
All of the above, but iron content is low.
A, B, C या D?
D.
अपनी किसी न्यूट्रिशनिस्ट को फोन करना चाहते हैं पूछने के लिए? आंसर इज डी.
Yes.
Absolutely correct. It's iron, calcium, phosphorus, proteins, all of the above. Dr. Piyush, which of the following supplements are needed for low birth weight babies till 1 year of age as per IIP Comprehensive Nutrition Module 2022? DHA, multivitamin and calcium, iron and vitamin D, calcium, zinc and vitamin D.
So answer is B, iron and vitamin D.
Everyone agrees? Karu lock? Okay. Check सबको बाद में मिलेंगे. And last is Dr. Deepika, your question. ये tricky question है. Which of the following two statements regarding low birth weight babies are false? Two of these statements are false. HMF can be continued after discharge. Vaccines begin on achieving 2.5 kg only. KMC should be continued after discharge. And fourth is direct breastfeeding to be started after 2.5 kg only.
B and D, sir.
Sure?
Sure.
पक्का? Lock कर दूं?
Yes, sir.
Okay. Absolutely correct. So we start both breastfeeding vaccinations at around 2 kilos. You can start the process of breastfeeding. So you don't have to wait for 2.5. We have questions for the audience. Okay, so the audience अभी तैयार हो जाइए. अभी आपकी बारी. How to sustain good growth post discharge and reduce EUGR? Continue fortification till needed. Prevent anemia. Growth monitoring. All of them. All of the above. D. बिल्कुल सही है. Next is a very difficult question. Which of the following statements regarding Mahanecon 2023 are correct? Excellent organization, a good scientific program, fantastic banquet and dinner, and all of the above.
We are very much thankful for appreciating us.
The next question is a more difficult question. I am sure we'll see whether you can answer. who should be our next Prime Minister in 2024. यहाँ किसी के पास कोई विकल्प नहीं है. Thank you very much.
Thank you, Dr. Umesh Vaidya, Dr. Dattatray Kulkarni, Dr. Ashutosh Yajurvedi, Dr. Piyush Shah, and Dr. Deepika Tiwari. Please proceed for felicitation. To continue the session, I invite chairpersons Dr. M.S. Kumbare, Dr. Dilip Kade on stage. I invite Dr. Sagar Lal to update us on neonatal transfusion practice.
Before the next session, there is one announcement.
So, good morning everyone. So, it was an excellent Mahanecon that we are attending. I am Dr. Nikhil Pathak from Aurangabad, and I would like to invite you all for International Conference of Tropical Disease and National Conference of Infectious Disease at Aurangabad. It is held on 8th, 9th and 10th. On 8th we have workshops, and 9th and 10th we have a very good academic session where we will be covering everything for pediatric infections, vaccines, and what we see in our day-to-day practice. So I would like you all to register for the conference, and I would like to invite you all for Aurangabad for a very good academic feast. Thank you very much.
Before coming to the next session, we just want to announce the winners for the quiz which we have declared so far. The winners are Dr. Giri, Dr. Sukanya, Dr. Sunil Sahil Mehta, Dr. N.D. Birazdar, Dr. Snehal Rathod, Dr. Shreya Patil, Dr. Jyoti Maske Patil, Dr. Deepika Mashalkar, Dr. Nachiket Inamdar, and Dr. Gargi. All the winners are supposed to take their prizes from the scientific committee counter.
Good afternoon. I will first like to thank Mahanecon organizing team for giving me a chance to speak on this topic. Now, the topic is transfusion practices in the newborn. Should we just rampantly use PCV, platelet, plasma? So I will throw light on that. First, what is the rationale for the transfusion? When to transfuse the child? Why we want to transfuse the child? Because it prevent and reverse the tissue hypoxia from reduced oxygen carrying capacity. Obviously, in the anemia, there is going to be low hemoglobin, low oxygen carrying capacity that can be prevented by giving the packed cell or red blood cell transfusion. And we should give the transfusion, which is optimum transfusion practice should be used to avoid unnecessary transfusion to the baby. Actually, we should withhold the transfusion only to the children who needed you give it, which is truly benefited to these babies. Now, anemia for prematurity affect majority of the preterm infant. And why there is anemia? There are two reasons. First is a delayed erythropoiesis in the preterm and the term baby. It's called as a physiological anemia. And second is the iatrogenic causes. Like if you do early cord clamping, there are lots of evidence which is supported that if you delay the cord clamping, it prevents the anemia. Secondly, phlebotomy, lots of blood sampling in the neonatal intensive care unit, and these are called as a diagnostic exsanguination. So if you are giving too much sampling, everyday sampling, obviously this preterm baby is going to land up into the anemia, and almost 80% of the extremely low birth weight baby needed supply RBC transfusion in the neonatal stay. Now, what is the risk associated with RBC transfusion? These are basically transfusion-associated infection, immune-mediated transfusion reaction, most important is a graft versus host disease, and toxic effect of anticoagulants and the preservatives. What we are worried about the transfusion reaction, it may be because of some hemolytic transfusion reaction. Secondly, transfusion associated acute lung injury. This is very important that it is immune mediated disease and child, the baby can deteriorate because of this trally. Secondly, transfusion associated circulatory overload, the child or baby, preterm baby can land up into the CCF. And fourth is the sepsis. Now, what is the evidence? Now, restrictive versus liberal blood transfusion in a very low birth rate evident. What Cochrane shows that, or is concluded that, when you are using a low versus high hemoglobin threshold for giving the blood transfusion, it says that it does not find any significant difference. So, multiple and randomized control trial has shown that whether you are using the high or whether you are using the low threshold for giving the transfusion, it does not affect your long-term outcome. Now, this is very important side which is recently published in a Neo Review in 2023, and this gives us a correct idea that when the baby is 0 to 7 days, neonate with clinical instability, that is the child, the babies who are sick. What is mean by neonatal instability? The babies who are on mechanical ventilation, the babies who has got circulatory failure, he is on the CPAP, he is on the non-invasive ventilation requiring 40% of oxygen, acute sepsis, necrotizing enterocolitis, the baby who is requiring the repeatedly apnea and undergoing the major surgery. So these are given that these are the indicating these are the sick babies. And for this sick baby, you keep a threshold of 11 gram per deciliter, and the children who are stable, the babies who are stable in 0 to 7 days, it should be 10. So just remember the magic number is 11, and if the level is less than 7, then definitely the baby is going to need the transfusion irrespective of whether baby is sick or not sick. Now again there is the guideline which is published in the British committee about should a restrictive threshold for the RBC transfusion, packed red blood cell transfusion, should we use a liberal use or should we use a restricted use? And restrictive threshold of a packed red cell transfusion approach is strongly recommended, and this is again an NF guideline 2020, and it shows that in the first 24 hours the level should be 12, whether the baby is ventilated, whether the baby is on CPAP, you should keep the level as a 12, and later on it should keep up to 7 days the level as a 10. Now, in the babies who are a term baby, what should be the hemoglobin level? If the child has got a severe pulmonary disease, it should be 12, severe cardiac disease 12, if the child has got a moderate level, it should be 10, and any babies who has got a severe anemia, when the baby is sick or non-sick, the level should be less than 7, indicate that we should give a transfusion to such babies. Now, what are the strategies to reduce the blood transfusion? Very important, delayed cord clamping. Already it has been mentioned and it has been accepted that if you delay the cord clamping more than 1 minute, 1 to 3 minutes, definitely it improves the repeated requirement of a blood transfusion and it prevents the anemia also. Iron supplementation should be started in a term baby of 4 months and in the preterm baby at a 2 week, obviously when they are in a good amount of the or full feed. 2 to 4 milligram per kg of iron should be started and maximum 15 milligram iron should be given, and you should limit the blood loss by a phlebotomy. Now, choosing the blood group, that we all know when you are giving a blood transfusion to the babies, you need to cross match with the mother, because there are some certain antibodies which are present in the mother which can get transplacentally transferred to the baby, and if you do not cross match with the mother, it can cause a reaction in the baby. Obviously, we should use ABO compatible blood to the babies, and especially the blood sample should be a newborn's ABO and RH system. Very important when you do exchange transfusion. For the RH disease, generally we use O negative PCV, which is mixed with the AB plasma. It can be done at the blood bank level, or you can do it manually also, and you check the hematocrit of the sample, and the hematocrit should be at least 45 to 55 to give the blood used for the exchange transfusion. Now again, the guidelines, should we use a less volume 10 to 15 ml per kg, or should we use a large volume 20 ml per kg? Again, this is NNF guideline, they shows that 10 to 15 ml per kg and you should use it over 2 to 4 hours. This is again a weak recommendation, there is no low quality evidence, but this is in the practice. So rate of transfusion, how long we should give? 10 ml per kg per hour. In absence of cardiac failure, if it is a 2 ml per kg per hour, if the child has got, or if the baby has got a cardiac failure. And when you give a baby of a 10 ml per kg of a blood of the PCV, it increases your hemoglobin level by the 3 gram per deciliter. Now the special technique, especially in the extremely low birth weight and VLBW babies, you can give as low as 5 to 10 ml per kg, and generally in the blood bank, they are using a small bag instead of giving the whole big bag. So these are called as a satellite plat, and that will prevent unnecessary loss of blood. Should we give a blood less than 7 days, or should we use a blood more than 7 days? Now guidelines say ki, this is again a Cochrane review and again NNF guideline. If the old blood, if the fresh blood less than 7 days is obviously you can use it, but you should not reject it also. So oldest first approach. If it is available, you can use a blood pack cell more than 7 days also. What Cochrane review shows that fresh RBC does not result in the low risk of the DICs. So there is no benefit or there is no advantage or disadvantage of giving the blood more than 7 days. But definitely if you use a fresh blood, it has got a high level of a 2,3 DPG, and that increases your oxygen delivery and also reduce the risk of a hyperkalemia, which is commonly seen if the blood used more than 7 days. Again, a multiple donor exposure in small and the sick neonate can be prevented by reserving a bag of a fresh RBCs up to 7 days. So you can take one bag and repeatedly you can make a small alicot and then you can give it up to the 7 days. Gamma radiation, this is very important, and I think when you are handling in the babies, especially a small preterm or extremely low birth weight babies, you should do a gamma radiation if it is available. What is the basic mechanism of gamma radiation is that it inactivates the donor T lymphocytes, and this T cell is responsible for majority of our graft versus host disease which is seen. Especially it should be used in the immunosuppressed babies, very small babies, and when you are giving a large volume of a blood transfusion and also during an intrauterine transfusion. And when the donor is related. So what is the mechanism? It stops the proliferation of a foreign T lymphocyte in the extremely low birth weight baby. Now this, it is done in the blood bank. You keep the blood in the cobalt chamber and you keep it like 5 to 10 minutes and give a dose of a 25 to 50 gyri, and that will give the gamma radiation. What is when you irradiate this blood, the RBC lifespan comes to 28 days, but the potassium level is increases by giving the gamma radiation. And when you give a gamma radiation, this blood should be used in 4 hours to avoid the risk of hyperkalemia. Obviously, because of the radiation, the potassium is going to come out to the RBC and cause hyperkalemia, especially in a baby less than 1 kg. So irradiated RBC is generally recommended for all the babies when you are going to take care of a baby less than 1.2 kg, and you can use it. It may be preferable for any transfusion till the 4 months of the age. So if it is you are using, if you are at tertiary care level, definitely you use the irradiated plasma. Now what is evidence for this? It is again an NNF guideline that should irradiated RBC component, where no irradiated RBC component should be used in a transfusion is neonate. Again the guideline show is that you should use the irradiated product even though there is a high level of increasing the level of potassium in this if you use for a long time. Now this is again very important thing about the development of NEC. So when you are withholding the enteral feed, or should we continue the enteral feed in the preterm babies where you are giving the packed red blood cell transfusion? Again, for this it is a weak recommendation. Moderate quality evidence has shown that withholding the enteral feeding in the preterm undergoing the neonatal RBC transfusion, it reduces the risk of a neck as compared to the continued enteral feeding during the RBC transfusion. Various study has shown there is no so much of evidence. These are all standardized randomized control trial, but this is again what is the recommendation. Enteral feedings should be withheld in a preterm infant while giving the packed red blood cell transfusion. 3 hours before and until the end of the transfusion, it should be advisable. Leukocyte depleted, again if you are using the babies, giving extremely low birth weight baby, you should use a leukodepleted filter because it reduces the leukocyte count into 5 into 10 raised to 6. Leukocyte reduction, if it is not done, it causes a non-hemolytic febrile transfusion reaction, HLA isoimmunization, transmission of leukotropic viruses, transmission of a graft versus host disease, and transfusion related acute lung injury. This can be prevented by using the leukocyte depleted filter, which is available in the market. Next question, should a leukocyte reduction and CMV seronegative donor or no leukocyte reduction and CMV seronegative donor can be used for a transmission of a blood product in the neonate? Again, the study has been demonstrated that leukocyte reduction with the use of a CMV negative blood, if you use it, leukocyte reduction plus CMV negative, definitely it reduces the transmission risk up to the 0%. Because it is all known that CMV is going to cause a short-term as well as a long-term effect in the babies. So if you are taking care of a 800 gram, 600 gram, the baby is going to be in ICU for 2 to 3 months. Such baby, if you give a repeated transfusion, definitely they may get a CMV related complication like hepatitis or all other complication with CMV. So to prevent this, you should ideally use a CMV negative, leukocyte depleted and gamma radiated blood. So the recommendation is a provision of CMV safe blood for the transfusion in the preterm neonate using the CMV seronegative donor or leuko reduction, and combination of both is highly recommended. Platelet transfusion, a few slides on platelet and the FFP transfusion. Now platelet concentrate, it can be a random donor platelet and it can be isolated by apheresis, is called as a single donor platelet. Sometimes it is not readily available to get a single donor platelet because you need a apheresis machine, but definitely it is better to use a SDP rather than RDP. The platelet concentrate required to be stored at minus 22 to minus 24 degrees centigrade. And again, if you irradiate the platelet, that will be good. Now, when you are giving the platelet transfusion, it should be used very fast. You cannot give platelet transfusion over 1 hour because this platelet will get inactivated. So it should be given as early as possible, and 1 unit of a platelet per 10 kg body weight. If you give a 5 ml per kg per dose of the platelet, it will increase your platelet count by 20,000 to 60,000 per cubic millimeter. And the dose can be given maximum as a 10 to 20 ml per kg, and this is not a platelet or not a blood group specific. You can use any blood group platelet. What is the guideline? When to give a platelet? 25,000 and 30,000 and less. Even if the baby is asymptomatic, you give the platelet. 30,000 to 50,000 if the baby is considered a transfusion if the baby is sick. Sick in sense, bleeding newborn, newborn less than 1 kg, previous bleeding disorder, newborn with a coagulopathy, requiring surgery, exchange transfusion, in that case 30 to 50,000 you give, less than 30,000 you give it, and more than 50 to 90,000 only if the baby is actively bleeding. These are again the guideline by NNF, you can use it. Few words about a random donor platelet. Again, RDP, it can be prepared from the platelet-rich plasma. So when you hold blood, it spin, you get a platelet-rich plasma along with a red blood cell. And you do it in a fast spin or hard spin, definitely you get to separate the plasma and you separate the platelet. Single donor platelet, again by the apheresis machine. When you put the whole blood in the apheresis machine, the platelet gets separated and the RBCs and the plasma get returned back to the patients. So you can use a single donor platelet, and the procedure is take 4 to 6 times and yield 4 to 6 units of a platelet from one cycle. Single donor platelet contain a platelet count of 3 into 10 raised to 11, while RDP contain a platelet about 0.5 into 10 raised to 10 per unit. Now what is evidence? I already discussed that when the platelet is less than 25,000, you should use a prophylactic platelet, especially in the preterm babies, not in the term babies. Now what is the recommendation? High platelet count threshold more than 30,000 and low platelet count less than 30,000 in a babies who has got a neonatal albumin thrombocytopenia. You know that neonatal albumin thrombocytopenia is the antibody get transferred from the placenta to the baby, and there is a breakdown of a platelet in the baby, and this baby are very high chance of getting a spontaneous bleeding, especially in the brain or in the joint. So this baby, you need a platelet should be kept at the higher level. Ideally, they should need IVIG. Along with IVIG, the platelet count is less than 30,000. You should use the platelet transfusion. And again, if you use a single donor platelet, it will be better. There are just few more slides. Now FFP. Now FFP, we all know it contains high level of albumin, factor 2, factor 7, factor 9, and factor 10 and factor 11. And FFP should be stored for 2 to 36 months, less than 30 degrees centigrade. Cryo is also separated from the FFP by thawing the FFP at 2 to 4 degrees centigrade. Cryoprecipitate can be used for 1 year if you keep it at minus 18 degrees centigrade. So what is the difference between the cryo and the FFP? Now FFP, indication of FFP is a DIC, vitamin K deficiency because it contains a good amount of vitamin K dependent factor, inherited deficiency of coagulation factor, and rare indication is the afibrinogenemia, von Willebrand factor deficiency, congenital antithrombin 3, protein C, protein S deficiency, and exchange transfusion. You should not use FFP as a volume expander or giving the albumin. One bag of albumin, one bag of FFP contain almost 5 gram of albumin. So if you use FFP, it will give 2.5 gram of the albumin or 2.5% of albumin to the baby. It will increase your protein. If the baby is edematous, you should not use a plasma as a volume expander or a protein replacement. You should use ideally albumin to the children, to these babies. Now cryoprecipitate is derived from the plasma only, but it contains majority of a factor 8, von Willebrand factor, fibrinogen, and varying amount of factor 13. Major indication of giving the cryo is a factor 8 deficiency, factor 13 deficiency, afibrinogenemia, dysfibrinogenemia, and von Willebrand disease. So whenever your fibrinogen level is less, in that condition you use a cryo. Now FFP should be either group AB or compatible blood group. Volume of FFP should be 10 to 20 ml per kg, and the volume of cryo in a dose is 5 to 5 ml per kg. Now should FFP or no FFP use prophylaxisally in the preterm baby? There is no role of a prophylactic FFP transfusion in the baby. The evidence shows that there is no significant difference even if you give prophylactic and non-prophylactic or therapeutic, but strong recommendation not to use a prophylactic FFP transfusion. Now should we use FFP transfusion prophylactically in a baby receiving therapeutic hypothermia? Again, there is no evidence. Even if the coagulation factor is abnormal in a babies with HIE getting a therapeutic hypothermia, evidence show there is no role of a prophylactic FFP transfusion in such children. Now, should FFP or no FFP use in the babies with a deranged coagulation profile who are undergoing surgery? Definitely, if the baby is going to undergo surgery, you need to correct that coagulation factor. This is a very strong recommendation. So, deranged coagulation factor, you should give them a FFP. Now, should cryo use or should we FFP use in the DIC? Very important in the child with a DIC, if it is associated with a hypofibrinogenemia or fibrinogenemia, the cryo come into the picture. Otherwise, FFP is good enough for the DIC if there is a bleeding child, or cryo, only indication of cryo is a persistent hypofibrinogenemia. Now, should a coagulation screening or no coagulation screening used in the neonatal routinely? So, all the babies who are stable, even if they are sepsis, should we do a PT INR and PTTK of all the babies? The recommendation is that routine coagulation profile screening for a neonate admitted in an NICU is not recommended. Again, there is a cost involved, there is no benefit has been shown in the study. So, this is a strong recommendation. Don't do coagulation profile of all the babies unless the babies show the evidence of bleeding. So, this chart will give you the dose, RBC 10 to 15 ml per kg, you will increase the hemoglobin of 2 to 3 gram per deciliter, FFP 10 to 15 ml per kg, just 1 minute. FFP in a dose of 10 to 15 ml per kg, 15 to 20% rise in the factor level, platelet 5 to 10 ml per kg, that will increase your platelet count to 50,000. So, in a summary, the liberal and restricted use, you divide or give a restricted blood transfusion. Threshold for giving the transfusion, keep a number of 10 to 12, 12 in the sick baby, 10 in the non-sick babies. Volume transfusion 10 to 15 ml per kg of a packed red blood cell transfusion. Gamma radiation, leukocyte depletion, CMV negative, especially in the babies less than 32 week, extremely preterm less than 1 kg, or ideally it should be in all the babies. Platelet transfusion 10 to 20 ml per kg will increase the platelet count to 20 to 60,000. FFP is a good source of a factor 2, factor 7, factor 9, 10 and 11. FFP should not be used as a volume expansion, should not be used as a replacement of the albumin, or it is and the cryoprecipitate is usually indicated if there is a documented hypofibrinogenemia. First will be a FFP transfusion. Thank you.
Thank you, Dr. Sagar Lad.
Thank you.
Now it's time for our last quiz. Quiz master is Dr. Poonam Mastood. Thank you, Dr. Mastood. I now request Dr. Amit Tagare to deliver his talk on neonatal hypoglycemia.
Good afternoon, everyone. I am very thankful to organizing committee of Mahanecon Solapur for inviting me, giving me opportunity to meet my friends and talk to you all. It's very intimidating talking about hypoglycemia in pre-lunch session. I don't want to threaten you, but we'll just see. This is about neonates. So there are certain things that happen in NICU which are very important, but they are so we feel they are so minor that we just neglect them, and hypoglycemia is one of them. From time to time, it has been proven that in Indian NICUs, sugar monitoring is not that very well taken. So today we'll just see about hypoglycemia from most of the things that we know, a few things we may not know. Now the major problem is always definition. When do we call it hypoglycemia? Just a week back I had been at one pediatric meeting, and then there was also a lot of discussion about how to define hypoglycemia. There are multiple trials, multiple guidelines ranging from sugar of 20 rather than 25, from sugar of 20 to sugar of 60, 70. But in practice, if we take, the NNF says less than 40 is hypoglycemia. Most of the places say it is 45 to 50. So it is safer to have it at 45. It is more about safety of the neonate and the legalities associated with hypoglycemia. So it is better to take it somewhere around 45 as the level that we want to keep. If our patient has persistent hypoglycemia, that we'll see later on, we take the level of 60. If our patient is on TPN, we should take the level as 60. So for a routine, 45, and for TPN and persistent hypoglycemia, 60. Persistent. So what is persistent hypoglycemia? A baby is with me, I am trying to manage his sugars and is not responding. So if this happens for more than 72 hours, practically we take it as persistent hypoglycemia. NNF says more than 7 days. In simple terms, the hypoglycemia that doesn't respond for simple glucose administration. Nursing staff calls, sir sugar 22 है, हाँ ठीक है त्याचं fluid थोडं वाढव. We are doing all those things on phone and mostly they get managed. But when it doesn't happen, when you have to be on the floor, then it is persistent. Who are the babies where we have to check the hypoglycemia risk? Technically, any patient gets admitted in NICU, we should check sugar in first few days. It's very simple thing to do, a bit painful, but still. Any baby who is large for gestation or small for gestation, any baby who is preterm, infants of diabetic mother, perinatal depression because the demands are high, and we don't want to risk the brain once again with hypoglycemia. Infections, once again the demand is very high, and on a history background, a previous sibling who had hypoglycemia. These are the babies who have some component of hyperinsulinemia and other things that can cause hypoglycemia. Why are we worried? Now this is India, or rather anywhere. Whenever we are doing something, the first question should be why. Now check the sugar, why? Brain is in this era supposed to be the most important organ of our body. And glucose is the chief energy for brain. And this is more true for a neonate than for an adult. Now what can happen? Today morning we saw Kishore sir talking about neuroprotection. We are all worried about a neonatal outcome, and that is intact outcome means brain should be intact. The more about intact goes in favor of brain. Now what can happen with hypoglycemia? It can cause cortical lesions, it can cause white matter injuries, basal ganglia and thalamic injuries, and it can cause infarcts. How do they present? Unfortunately, most of the neonatal diseases present same way. We all know something odd. When I was doing my MD, it was said that neonatology is subject of 10 diseases. Over these 2 decades, it has increased and increasing. So it is not that simple. But one of those 10 diseases, 2 decades back, hypoglycemia was there. It is that significant. And it presents like lethargy, irritability, abnormal crying. It presents like feeding difficulty, and that feeding difficulty itself causes once again hypoglycemia. So they land up in a cycle. I just have a baby in my NICU. Primary mother could not feed well, so all those things, and then sugar went to 18. And then everybody, the mother म्हणली काय सर ते पितच नव्हतं 2 दिवस. So that cycle happens. Jitteriness, seizures, hypotonia, and lastly any neonatal disease presents with grunting, tachypnea, apnea and cyanotic spells. Now why we are worried about hypoglycemia is more about the long-term problems, and these are microcephaly, tone abnormalities, visual impairment, mental retardation and seizure disorders. Very old paper, but still true for India. Neonatal hypoglycemic brain injury, a common cause of infantile onset remote symptomatic epilepsy. So that indicates about our ignorance on sugar monitoring. So because we don't monitor sugar, the hypoglycemia goes undocumented, and then they land up with convulsions later on. And when we do imaging, and then we find imaging and EEG, and then we find that probably the reason was hypoglycemia. 114 babies were of hypoglycemia were monitored. 25% had epilepsy and 40% had psychomotor retardation. This is also once again a very old paper. So overall what we see is it definitely matters when a patient has hypoglycemia. Now symptomatic or asymptomatic, that's a different thing altogether, but we should try and avoid it, document it, and if it is documented then correct it. So it's a serious condition with significant long-term problems, so we need to manage it aggressively. Now when to define? The major problem is asymptomatic hypoglycemia. There is no evidence of long-term abnormal outcome in asymptomatic babies with BSL between 32 to 45. So staged approach is suggested. So what we do, if sugar is somewhere 36, 38, full-term baby, feed him and check post-feed sugars. Most important thing, check the sugar after 60 minutes, because most of the times we just forget it. Asymptomatic hypoglycemia with less than 32 or repeatedly the sugar is less than 45. My patient's sugar was 36, patient was fed, sugar was once again 34. Now here we need to intervene. Asymptomatic hypoglycemia, sugar of 28, baby is fine, intervene. Feeding milk provides fat which promotes ketogenesis and reduces the glucose uptake by cells. This causes longer effect of milk on preventing hypoglycemia. That's why we prefer enteral supplementation, because it is just not sugar. It's a live fluid. Dextrose water, there is old time tradition of giving dextrose water to the babies or sugar water to the babies. It can work absolutely like IV dextrose bolus. It can stimulate the insulin, and that insulin will remain high for quite some time, and it will exacerbate hypoglycemia. Symptomatic hypoglycemia, whatever is the level, treat it. It requires immediate intervention. IV glucose is initiated and effect is assessed every 30 minutes till the sugar becomes normal. Once the target sugar of more than 45 is achieved, then we can go to hour and then 2 hourly. Either we can increase the energy intake or we can mobilize the sugar. Now 10% dextrose, 2 ml per kilo bolus or 5 ml per kilo bolus, and that is always to be followed by IV dextrose line. We usually start with 4 to 6 milligram per kilo per minute. Now, whenever we talk about glucose, we always talk in terms of GIR. We don't talk like 8 ml, 10 ml, 12 ml. It is about how much sugar the baby is receiving. So, the GIR. So, GIR should be 4 to 6. Check sugar after 30 minutes. If hypoglycemia persists, increase the GIR. Either by increasing fluid volume till that is allowed range, or later you can increase it by concentration. GIR of 15 or as per NNF 12, that indicates investigation. That is something different. So, we need to go for stress samples. So, if the GIR has reached more than 12 and hypoglycemia persists longer, then we send the first line investigations and start medications. Now, how do we manage persistent hypoglycemia? Management is always investigation and intervention. So, what can cause persistent hypoglycemia? Hyperinsulinism, endocrine disorders, inborn errors of metabolism, and neurohypoglycemia. Now, baseline investigation, we need to have a documented blood sugar from lab. Anyways, whenever we get 3 abnormal readings on any point of care machine, it should be confirmed with lab. Because the blood sugar machines are meant for hyperglycemia. They are meant for diabetics. They are more sensitive for that. They are not that sensitive for hypoglycemia. So, whenever we are getting abnormal low sugars, then we need to confirm. Serum insulin should be sent. Always document the blood sugar when the sample was taken, because that is where it matters. It is not the insulin level, it is the insulin sensitivity, HOMA index. Serum cortisol, serum growth hormone, and ketones. Now, cortisol and growth hormone are stress hormones that will be released with sugar. So, normally in an adult, whenever our sugar goes to around 78, the insulin disappears. When it reaches somewhere around 70 to 72, the growth hormone and cortisol this glucagon acts, and when it reaches 68 and below, the cortisol level goes up. Till the reports come back, we keep on increasing the GIR by 1 to 2 milligram per kilo per minute every step and start counter-regulatory hormones. Now, what can we start? Glucagon. It increases the glycogenolysis and gluconeogenesis. It can be given as a drip, 5 to 10 microgram per kilo per hour, or we can give it as a bolus, 0.1 to 0.3 milligram per kilo per dose. Cost is a limiting factor. It's quite costly drug, and availability in the peripheral places is difficult. Steroids increase gluconeogenesis. Action is not immediate, it will take some time, it takes around 2 to 4 hours. Long-term use is associated with adverse effects of steroids. Injection hydrocortisone 2 to 5 milligram per kilo per dose can be given. Now, treating hyperinsulinemia. This is how the insulin is released. Now, we have these GLUT2 receptors, and there we have the calcium playing through calcium channel blockers playing some important role. Now, this is where we work, inhibitory effect of somatostatin and blocking of calcium for release that releases insulin. Octreotide is a somatostatin analog. It causes membrane hyperpolarization and reduces calcium influx and direct inhibition of exocytosis. It decreases also because it's a common membrane receptor, so it decreases the bile secretion, causes cholestasis, and can cause abdominal distension. 1 to 10 microgram per kilo per dose every 6 to 8 hours. IV or subcutaneous it can be given. It takes around 8 hours for action. Diazoxide, it's a cornerstone in treatment of hyperinsulinism. It causes membrane hyperpolarization by increasing potassium efflux. It works on potassium ATPase and it inhibits insulin secretion. So, this is the treatment for hyperinsulinemia. It is given in 10 to 20 milligrams per kilo per dose in 2 to 3 divided doses. Practically what we do, we start with 5 milligram per kilo per dose, 12 hourly, and if needed go to 8 hourly. It has to be combined with chlorothiazide, 5 to 10 milligram per kilo per day. for better inhibition as well as to reduce the water retention. It has lots of untoward effects. Nausea, vomiting, fluid and sodium retention, hyperuricemia, hypotension, hypertrichosis, and rarely blood discharge. Yes, what relatives are more concerned is always hypertrichosis. Once they come back, these babies are like hairy. They look like almost like monkeys. The only good thing is when you stop diazoxide, it goes off. Nifedipine, calcium channel blocker, it inhibits insulin secretion. Dose is 0.25 to 2.5. Needs blood pressure monitoring. It is poor man's diazoxide. Getting diazoxide is not easy for everyone, but it needs some monitoring. Very few babies need surgical intervention, and the major important thing is going to it. Diagnosing this is far more difficult than treating this, because it's a very selective procedure where you need to find from where the insulin adenoma is there. Beyond hyperinsulinism, endocrine disorders, pituitary insufficiency, cortisol deficiency, congenital glucagon deficiency, congenital epinephrine deficiency. Inborn errors of metabolism, carbohydrate metabolism, galactosemia we all know. Once in a while, almost everybody has seen galactosemia. We had all these discussions, so I won't go in. Hepatic glycogen storage, GSD1 is pretty common. Hepatomegaly, renomegaly, hypoglycemia. Usually they present in infantile age group. Amino acid metabolism, MSUD, propionic acid, MMA, tyrosinemia. Fatty acid metabolism, defects in carnitine metabolism, acyl-CoA dehydrogenase deficiency. If you have a patient with jaundice in neonatal period, indirect jaundice, which keeps on increasing with deranged PTA, PTT and hypoglycemia, tyrosinemia. Neurohypoglycemia is very rare disorder. It's GLUT1 defect, and so glucose transfer to brain is affected. Sugar remains normal, but the brain sugar remains low. And these patients have severe seizure disorders, mental abnormality. Ketogenic diet may help them. Now something different. MISN is new disease, less than 3 years old. Everybody is seeing different manifestations of MISN. What we were troubled with the endocrine manifestations of MISN. Most of us have seen the deaths of MISN because of its cardiogenic element, but what we were troubled a lot was babies with MISN which presented with endocrine manifestations. We are writing on 6 babies, of which 1 baby had only hypoglycemia, but 5 babies had hypoglycemia and hyponatremia, and very severe hyponatremias, going up to 96. 1 baby had 96. Non-responding, very difficult. Outcomes of these severe hyponatremic babies were bad. We lost 3 out of those 6 babies. We are still getting on and off endocrine manifestations, but that are not that bad. But last year it was difficult. We could not find any reference in our academics. We could not find the method how it works. So hope we find after some time. Probably we are the first ones to see, because I talked to so many people, nobody has seen that. Now the most important thing of hypoglycemia, the management of hypoglycemia starts at discharge. In NICU we are so much aware, but ideally, technically if you save a patient of hypoglycemia, then your management starts at time of discharge. You have to push the parents for that. They need a rigorous neurodevelopment follow-up and early intervention. They need neuroimaging to rule out any damage that has happened. They need visual assessment. They can have cortical blindness. That is very important thing. This preterm baby with hypoglycemia will not have any ROP, but he might be cortically blind. And they are the candidates for management of infantile epilepsy. They are one of the worst ones who go in West syndrome. Thank you. As
Thank you,
Kishore
Dr.
sir is taking photographs of birds, I take birds also, but I focus more on butterflies. Thanks.
Thank you, Dr. Amit Tagare. Thank you, Chairpersons Dr. M.S. Kumbare and Dr. Dilip Dilip Kade. Please proceed for felicitation.
No conference can conclude without discussing few sensitive topics and few day-to-day issues that we take for granted as they are. For this last and important session, I invite chairpersons Dr. Sneha Velapurkar and Dr. Deepak Bablade. I also invite speakers Hemant Gangolia to deliver his talk on medico-legal issues.
Excuse me, there is one important announcement.
After the lecture on medical errors in NICU by Dr. Dayanand Nakate, we are going to listen to a few words of wisdom by Honorable Dr. Simin Irani. So I request you all to stay back and give this grab this golden opportunity to listen to Madam Simin Irani.
Hello. Hello. Yes. It's already becoming lunch time, but then नमन करते हुए और आशीर्वाद चाहूँगा इन एब्सेंसिया मैडम डॉक्टर ईरानी जी, जिन्होंने मुझे KMA नियोनेटोलॉजी सिखाया था, तहे दिल से धन्यवाद करना चाहूँगा ऑर्गेनाइजिंग टीम का, जिन्होंने मुझे यहाँ आमंत्रित किया, स्पेसिफिकली डॉक्टर ऋषिकेश सर, डॉक्टर विक्रम डीओ, डॉक्टर दयानंद, डॉक्टर कुंदन. Hearty congratulations to the organizer for excellent organization of the conference, excellent science, excellent venue, and a wonderful evening yesterday. They need a good applause and claps, I think, so we should clap for them. The outline of the talk, 22 minutes, prevention is better than cure, is a very huge topic. And probably, so aim will be to sensitize about basics, present neonatal scenarios, and preventive aspects. And I may request organizers to spare a few minutes to complete my talk if possible. Otherwise, I will stop whenever the bell is there. काल आपण ऐकलं डॉक्टर विक्रम सरांचं लेक्चर होतं, त्यांनी सांगितलं कोर्टाची पायरी शहाण्याने चढू नये, पण आपले शहाणे पेशंट असतात आणि आपल्याच काही लूज कॉमेंट्समुळे आपल्या कोर्टाची पायरी चढावी लागते आणि हे हकीकत आहे. आणि त्याच्यामुळे 43% of the litigation is due to loose comments by our colleagues. And I do not know when it will stop, पण ज्यांना झटका लागतो मेडिकलचा ते तरी कमीत कमी लूज कॉमेंट करण्याचं बंद करतात. आणि असं असताना काही बेसिक गोष्टी आय विल जस्ट रन थ्रू दिस स्लाइड विच एव्हरीवन शुड नो और अदर दे आर नोईंग. Ignorance of the law is not the excuse. There are too many laws. One cannot know everything. So we can just classify two types of laws: statutory law which is passed in the parliament or the state assembly, which example MMC, CPA, and judgment laws, because everything is not covered in the law. So whenever any issue goes to the Supreme Court, High Court, and whatever the judgment come, that is known as judgment laws, and which is the fourth law set as a precedence. Law syllabus doesn't cover all issues, and as well it doesn't provide all solution. The word is justified logical ethical reasoning, and there are a lot of gray areas. Medical issue is part and parcel of our practice. One has to accept it, but one need not get afraid of it also. And please, every patient can be a potent litigant. To be watchful, and whenever there is complication, please save the papers. For how many years, I will come to that. I will not explain this, but only 2 lines on that. Always, court of law sees prudent, reasonable doctor with average skill. And it involves 2 acts, acts of omission and act of commission. What is act of omission doesn't do that act which was necessary while treating the patient is an act of omission, and does the act which should have been done while treating the patient is an act of commission. All evidences, all the whatever the defense is presented, it revolves all around this act of omission, commission, and the documentation. So one should, so NNF can think of making, this is just request from my side, can think of making guidelines, list of acts of gross omissions and commission, as well as stand on options when at one given point of time there are 3 or 4 options of treatment, which one is better, probably that guidelines NF can be proved, which will hold true in the court of law. I will not go into detail, everybody knows this 4 essentials D of the negligence, because I want to cover more the things too. Duty, deficiency directly, only one point, the damage should be a remote one, immediate one, not happening after 1 year or 2 years. And so, everybody should know this IPC section 304A. Many of our fraternity doesn't know this IPC 304A, and this is an act, this is a section which is applied in case of medical negligence, rash death due to rash action. And this is bailable offense, meaning by you get bail outright at the police station, no arrest. And therefore, it is a cognizable offense and non-compatible. But only one point to remember, punishment, if convicted, is 2 years or fine or both. So, many times, court of law, this police station applied 304. What is the difference between 304 and 304A? Everybody should know, because many times, and when the struggle starts, we don't know that the things. So, this is the interpretation. We, in lack of time, will not explain, but just read the last line. 304A is not amounting to murder, and where there is no intention and there is no knowledge by the act occurring dead, therefore it is a bailable offense. What is 304? 304 is there is a intention, there is no intention, but we have knowledge by this act it can cause death. So when there is a knowledge and no intention, then it becomes a non-bailable offense, that is a 304. One should remember only 304A, that is important. Everybody knows what is DPA? Doctor Protection Act. Everybody should know Doctor Protection Act, implemented in March 2010. Each and everyone should have this copy of in their smartphone, because at the time when the FIR is made, police station is also not aware of most of this DPA Act. And I can request each and every clinic, this we have displayed in our clinics and hospital in our Karjat Taluka as well as Raigad, and that really makes the patient aware of the things available. I will not give the detail, it mentions just what is a कायदा, त्याच्यामध्ये 4 सेक्शन काय, कुठली 4 कलम आहेत, आणि त्याच्यामध्ये, आणि ते आम्ही मराठीत लिहिलेलं आहे. But we have displayed with the permission of the police station of the respective area, then only we displayed this. And in short, section 3 deals with the prohibition of this violence, section 4 deals with the punishment, and section 5 deals with this offense which is non-bailable. So there is no bail offered at the police station unless and until judicial first-class magistrate agrees to the argument of the patient, accused to the bail to be given. And section 6 is compensation is always twice the amount of damage. Everybody should remember this and should have the copy of this. What are the legal forums if the prospective doctor as well as patient? Some mishap happens, so what doctors can do? One of the important solutions is always inform police. We are afraid of police. And there is a solution to that. I will just speak on that. Call your colleagues always. Calling influential persons as political persons is a double-edged sword. One can add a word. And last is financial settlement. Most of the doctor resorts to the financial settlement, but there is a Supreme Court of India warning of the ruling that do not give any cash or check to the patient in an out-of-court settlement without proper written consent, to the consent term is not known as. But more often, आपल्याकडे तोडपाणी केलं जातं, पण beware of this is for information, and for patient, it is lots of forums, police station, consumer forum, medical council, National Human Rights Commission, civil courts, as well as some authorities are there, which are Chief Medical Officer, Ministry of Health, Lok Adalat, and etc., etc. The point what I want to make is that in FIR, if FIR done, we don't have any time, so documentation of paper is very important. If the paper are seized that time, we cannot make any things, and so we should learn to document the things. In all other cases, one gets time to reply to the notice, maybe for 15 days to 1 month, maybe extended to 45 days. So in there we need not worry, but in FIR, these are sections which just sections 88, 89, 90, 92 and 93. What are these? One should know these sections. Why? This is related to consent. And when the consent, of course we take the consent. Therefore, in 88, 89, if consent is taken, if do good faith, death occurs, no negligence. But in emergency cases where we don't get the consent, or the emergency situation where one doctor has to take the decision, then 92 and 93 is communication made in good faith and act done in good faith without a consent available. Example, emergency situation. But doctor should document the emergency. Importance of consent in NICU setup. I will just correlate to that. Consent in emergency versus routine consent. Generally, NICU admission, we take the blanket consent. It is a blanket consent. But real-time consent should be taken as per the emergency arises, as what are the process to be done. There should be real-time mentioning the date, time, signatures of both treating doctor as well as the patient, and the reason for it. And in emergency, where one cannot take the consent, the time is not there, because saving the life is important, critical situation, that time, but that this justification should be there for the process what is to be done. So just the emergency to be documented in real time, better to inform post-interventions. So now, 3 issues with intensive care practices. Medical involves medical management, and ethical involves to take right decisions while maintaining patients' interest in all aspects. And legal involves maintaining standard care of practice and providing honest and actual information to parents and taker. So we had a talk yesterday, and these are the major contributing factors for neonatal deaths, but technology is improving. Therefore, neonatal survival is improving, and therefore rising expectations. So sometimes inappropriate intervention may lead to the increase in handicapped survivor. Whether not to do is a question mark. Negligence, misdiagnosis, wrong treatment, death, and lack of consent. These are the situations where medico-legal situation can arise. It's a huge thing to discuss, but I will just go to these things one should be it requires lot of communications, lot of skills, and lot of time to explain the things which are concerned with the perinatal asphyxia, ELB, WABs, care of babies with major malformations, and complications like severe grades of IVH in preterm. Already we had yesterday. So I think so these are the 6 words which are very important, and I think so if we apply this, because of lack of time I will not go, but 3 things are very important. Anticipation. Whatever practice you are doing, we should learn to anticipate, and we had a lot of anticipation yesterday by Dr. Rahul sir. OPD indoor-wise complication, documentation should be justified, formats, computerized versus manual, and communication is always informed, documented communication. One should practice as per the qualification, infrastructure-wise. Display of service is very important. CEA, Clinical Establishment Act, still not implemented in Maharashtra, but it will be soon implemented. So this comes in the display of services. Always follow 4 ethics of principles: respect, do good, do harm, no harm, and equality. And introspection, I think so that's the last important, always put the patients by thinking of our near and dear ones in the patient's shoes. Probably we will make the next less mistakes. And I think so there is no uniform solution, blanket, there is no blanket solution. One has to be tailor-made, individual-wise, setup-wise, hospital policy, as well as NICU policy. Whatever policies has to be displayed, that is important. So was just coming 4 or 5 scenarios, important papers. I think so these are important papers, everybody knows. But the point highlight I want to make, all should be with justification. A keyword is corroboration amongst the paper. If the orders on the indoor paper is by doctor is something, and that should corroborate with the nursing treatment paper, the findings on the indoor paper should corroborate with the findings on the nursing treatment paper, because these all things are seen in the court of law. If that doesn't corroborate, there's a gross negligence. So everything should, discharge paper should be with proper follow-up instructions. Now important paper is OPD paper and signboard. What name we should write? Full name, qualification, what you are having, neonatologist specialization, whether we can write pediatrician, neonatologist, important questions. We don't have time, otherwise it's the interaction and it has almost 10 minutes. Whether we should write pediatrician, neonatologist or child specialist. Because in the field of pediatrics, there is a super specialization existing with a DMA neonatology. So, As a MD pediatrician, we should always write only pediatrician or the child specialist. We should not commit to write pediatrician neonatologist. The reason I will come to that. And whether we should write fellowship. We have more OPD papers and things mentioning fellowship here and fellowship there. Unless until that fellowship is recognized by MCI, पहले अभी NMC हो जाएगा. If they are not recognized by NMC and NMC, it cannot be written on the OPD paper or the case paper. So that should not be written. And then if MD pediatrics practicing NICU setup in the area where the DM is across the road, so one has to take the opinion of DM neonatology. Otherwise has to transfer. In the areas where the MD pediatrics is there and there is no DM neonatology, then he can go ahead with the NICU, but informing the patient that such a facility is available so many kilometers away. If he is interested, he can go. Otherwise, he can proceed with the things. And 24/7, it's I leave up to you. If you write 24/7, you should be available 24/7. Otherwise, it is wrong. Otherwise, write a specific time. And if you are not available, if you have seen the patient in the OPD in the morning, and if you are not available in the night, then you should have the paper, on the paper available number or place in emergency case where the patient should go. Otherwise, that also amounts to negligence. Because when you have seen the patient in the OPD in the morning, duty of care arises there, and you have to continue seeing the patient in case of emergency when they come on the same day. And therefore, this because why I said that physician versus cardiology case is pending. MD medicine claimed as a cardiologist, patient went against that, and that is still very because medicine has itself many DM courses, and same holds true for the pediatrics. And then this only one line because I don't have time to that. Regulation 2.4 ethics gives us chance to choose the patient because it's a treatment contract. But that exists only in the state of non-emergency. In emergency state, because Permanent Katra versus India, Union of India case law states, in emergency patient, every doctor has to see the patient. So, emergency setup in OPD, when we have anaphylaxis or any emergency patient coming, we should have the setup oxygen ambu bag. Already yesterday, I don't know in which talk, it was stated that in office it should be there. Because if any known complication, if any patient gasping brought, if paper doesn't show the resuscitation made, that becomes a gross negligence. In spite of having all this setup, death occurs, that is not a gross negligence. But if you are not having setup and death occurs, in spite of attempted, that will become a gross negligence. So everybody should keep in office practice also these things. And SNC is always, because I think so this is very, very fantastic discharge card. Everyone should, this I can just, and this one more case I will just discuss. History of milestones as a routine pediatrician. This is for general pediatrician. As a routine, we should always write history of milestones. And specifically when it is the NICU QRS this provided. If it is an NICU graduate. Why? Because it's a case of ROP where though the incidents occurred at treating NICU, but other pediatrician paid party, because in the OPD follow-up, he has not written and he has not asked about that and has not informed of the ROP. So he has made this case is still pending with the National Consumer Forum, and therefore, and as a general in OPD, we should write all these details also. I am not advertising any format, but one should find out which format is very good. And I think so NNF can think of stationary formats for where it should be uniform across the state or across the country. That will be very helpful because the uniformity will do the wonders of making the less doctor shopping. And this one, everybody knows just the point. The judgment came on the doctor's day. So this is a 1.38 crore Krishna Kumar versus state of Tamil Nadu. And the case is very long, but to mention this case, this patient went from Tamil Nadu to Bombay, from Bombay to US, and USA he got informed that this was, if it were in laser stages 1 to 3, laser treatment could have helped. And I know, and this is a link to go to this judgment. So the lesson what we learn from that is, follow-up advice is very important in various settings. NICU policy, ROP screening, when, why, how, explained. BERA, and etc. I will not write, not a blanket or follow-up. Many times I have seen the case papers of the NICU, just this tick karte hai, ROP karo, BERA karo, hi karo. But that doesn't hold in court of law, and one case is going where the court of law is rejected because you have not mentioned. तर आपल्याला दोन लाईनी लिहून दिल्या की आम्हाला हे आरोपीबद्दल समजावून सांगितलंय आणि कधी चेकअप करायचं हे जर आपण 2 लाईन मराठीत लिहिलं किंवा लोकल लँग्वेजमध्ये लिहिलं ते आपल्यासाठी भलं राहणार. त्यासाठी असं फक्त टिक करून चालणार नाही. दॅट बिकम्स अ ब्लँकेट कन्सेंट, printed forms, and still the judgment is pending about the printed form. So, and ROP is a case where is there are rising cases of litigations in neonatology. Records, how many years one should keep records? So, clearly MCI or NMC it says 3 years. And when asked, please give me 5 minutes, please, if you don't mind, otherwise I will stop. Refuse to give, one can refuse to give for 72 hours, but one has to apply for it and one has to give. One cannot withhold the records, they have to give. So many suggestions. Any WhatsApp university आहे तर प्रत्येक गोष्टीमध्ये काय काय लिहिलं, कोण म्हणतं 10 वर्ष, कोण म्हणतं 30 वर्ष, कोण 21 वर्ष, etc. etc. What is final and why? And how to destroy? If MCI says or NMC will say 3 years, after 3 years when you destroy the record, 2 local newspaper advertisement, these records will be destroyed. Anyone wants to collect, they can collect. So that record should be preserved. And then, why 21 years and these issues were coming? कोणी म्हणता medical legal cases 30 वर्ष ठेवा, कोणी म्हणतं 21 वर्ष. Because this is the important case from Madhu versus Narendra Kumar, which states that claim application cannot be barred till minor attains majority. So records of such cases forever. So what are those cases? Permanent disabilities, brain disability, mental retardation. And there, because 18 is the child to become major, and 3 is the period of limitation which is in the criminal case, and 2 years in case of consumer forum. So they have the 3 years and 2 years. So 3 plus 18 becomes 21. But what I will say, we have to destroy after 3 years. But wherever if one senses complication, one senses mishap, one senses permanent disability, probably to keep lifelong. That is the thing to be done. Now this EOL decision is very important. I think so. I will just skip over these things. Legal dilemma, ethical dilemma, who takes that? This is an important point. I will just mention this. This is a consensus statement from Indian Academy of Pediatrics. One should read that. And then everybody knows what is DNR, when to do what is DNR. What I want to mention is this. This is a format which is available abroad but not available in India. And these are the things. This DNR protocol dilemma involves ethical principles, mostly article number 21, which provides protection of life. So right to life as well as right to death mentioned. But what important I want to say, I will just skip this, but these are the EOL circumstances where one has to take the decision. Extreme prematurity, congenital anomaly, imminent death, evidence of profound error, and one can read that. But this is resuscitation not intended. This is what I can search. If is there any change from NA, please let me know. Birth weight less than 400, anencephaly trials from 13 and 18, and optimum duration of research after birth without results is 10 minutes. So this is the thing, and these are lethal legal problems which can occur in our NICU when potential legal problems is unnoticed, passive euthanasia, and by accident. Infrastructure for insertion fails, oxygen not available, oxygen the tubes getting disconnected accidentally. So these things are there. हे बंद करू का, चालेल का?
You can continue for 2 minutes.
हाँ ठीक है. हे मला वाटतं हे झालंय. So these are last newspaper leaves 440 grams, but I have to just ask this thing. This was the paper when the Max Hospital incidents occurred and when to resuscitate, not resuscitate. I will not go into detail because of lack of time, but what I want to say is, this is again one-to-one discussion with the things, but then NNF should think of making the guidelines properly and it should be correlated properly. And then this, I will just leave it to you. I will not answer this question because lack of time. If everything is there, working diagnosis is there, and parents refuse to sign such consents, what to do? It's a really dilemma. But lack of time, I will not. And just we have gone this, we had a human milk lecture also. 31 years old engineer, resident of Panvel, gave birth to baby boy, kept in the nursing home, monitoring sugar levels. Newborn was given formula feed. Human milk bank was part of the hospital. And then she went to for this litigation. So mother's consent is important. India has no such legislation. Australia does have. They provide mother consent before giving any milk. This I will skip. How many of you know IMS Act? What is the IMS Act? We don't have time, I will skip, but please read this IMS Act word by word in the true spirit of this law, and because these are the punishments, and when I will just come to one case law where there is then, and Indian Academy of Pediatrics also has sent these things, resolution, and last 2 to 3 minutes, please, 2. Transfer facilitation, ambulance, pickup, transfer notes is very important. One has to learn that. Then surfactant case, just I will enumerate, this decision has not come, but because of good faith, doctor gave the surfactant. And when the surfactant was, just nurse asked the patient to replace that. And when they saw that surfactant, it was expiry date. This case is pending still, we will not what happen. So, drugs also, expiry drugs is very important. One should follow that. And these are important things, please, neonatologist has to have good relations with a pediatrician. I will just come to the directly to the third point. Interesting, whenever call is there and stillbirth occurs, pediatrician sometimes refuses to write the notes. And gynecist also says you write this. So there should be a policy between both obstetrician and gynecologist what to read because one of the cases of, I will not name the city, I will not name the hospital, same thing happened. The neonatologist refused to write a research note in case of stillbirth. And gynecologist said, obstetrician said, you write this way. So that is pending. So newborn, and this one more case. Generally, obstetrician delivers the baby. And after giving BCG and hepatitis B, the child died after 3 hours, and child was buried, but that patient got out, and that report went to the JJ. This is pending still, and is one of the pediatricians. So every time routine, we should write whatever we are doing. He has not written anything. Table deaths, if any pediatric surgeon is there, inform police, document is very important, is declare the death after the arrival of the police. And this is an important slide. Please, any mishap occurs, please discuss the literature for and against and preserve the papers and appropriate documentation. And may I suggest NIF guidelines modification needed as per the levels infrastructure area wise, individual group practice corporates accredited hospital protocol certified, and information leaflet I should be uniform. Maybe information come consent leaflets for HIE, HRN, PT and HMD, Highland memory disease preterm, and this high risk newborn. So one can make this. This I will skip, what not to document because it is not better to speak from the dais. Sometimes this is very important. We should have excellent criminal lawyer, good medical legal expert, and local association rush tip concept. And always, whenever the office bearer changes of the association, we make a visit to local police station for the courtesy
really
meeting.
Sorry. Really running
Insurance,
short of time.
I will not go in detail. Only important 1:1, unqualified staff to be covered, damage to furniture. This I will skip. This I will just skip. This only proper way to write death certificate. 3 things are there always. Immediate, antecedent, underlying complaint. This case is there, but I will not go in the detail. This is where antecedent 3 causes should be written. Pulmonary hemorrhage, I will have not narrated the case, therefore I cannot explain that. And there is a different certificate of cause of perinatal death. I don't know how many of you are aware of this and how do they feel this. We don't have time for that. Handwriting, please improve. This I will not go in the detail, but this one important line is national consumer always state the chances of success or failure in percentage, not in percentage, but fair, normal and good. Finish. आणि हे मी सोडून देतोय सर्व. फक्त I will just leave one slide for a thought process. Because this, please, expert witness, try to give the expert witness for this. And this I will skip. Just I will leave with this slide. Because it is a thought process to see. LSCS baby 3.1 kg developed jaundice 4th day. Baby shifted without mother. Powder milk with bottle. Vomited, aspiration, pneumonia, septicemia, multi-organ failure. And what is the problem? Baby shifted without mother, no consent, and then vomited, aspiration, and it's very difficult to defend this. With that I end. Thank you very much. Extremely sorry to exceed the time, please.
Thank you, Dr. Hemant Gangolia. Let's now have coffee with Dr. Ganesh Kulkarni and Dr. Sagar Kulkarni over some discussion on vaccines.
So now will be a slideless lecture.
Moving mic.
So after seeing so many slides, we will have a slideless
दोन
lecture.
आहेत.
When
अजून एक
Atul
द्या.
called me,
अजून एक.
कि Sagar, will you come
एक
for
दे, एक
coffee with K? I said, yes, 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 I will come. I will come for coffee with K. He said, Sagar, wait, this is not coffee with Karan. This is coffee with Kulkarni only. And there is no Kiara, there is no Ania, there are only 2 Kulkarnis only, and you all have to talk amongst yourself only. So since morning I am carrying this dabba, people are saying, what is this? This is my panel discussion, because there are no slides in it. All the questions which I have gained from you only, from my colleagues, I have put it into this, and we are going to discuss this with you. You can ask us any question anytime. You can interrupt us when we are having this discussion. You just raise the hand, then we'll take question and answer session also. So welcome Ganesh sir.
Yes, good afternoon, Sagar.
Let us have some coffee. Though lunch is waiting, offer them some coffee.
Is this our new startup?
Startup? Yeah, why not?
Coffee with
We'll have this
Kulkarnis?
startups. Yes, sure.
I think we have mistimed it because people are waiting for their lunch. And we thought that we might probably, every conference gets delayed for the scientific session goes on delaying. And we thought that we would reach almost 4 p.m. to deliver this particular coffee with Kulkarnis. But unfortunately, all the neonatologists are very damn on time. They have finished their talks within their time limits. And so we have, in fact, preponed kind of our talk to lunch area now, lunch times. So instead of coffee with Kulkarnis, coffee with toast and khari, rather it would be roti and rasa. We wait for some more time to go for lunch. And I think I must thank organizers and the scientific committee for one reason is that to make this particular topic relevant in a neonatology section. Because even I was thinking, what would they really want to listen? They only have 3 vaccines in first 1 month of time they have to be given. One is BCG, hepatitis B and OPV. And we as a vaccinologist, what are going to speak on these 3 vaccines for 30 minutes? But the thing is, I must congratulate all you neonatologists there. I have seen you working very hard. You make these tiny survive with your empty efforts. So our job as a vaccinologist is to safeguard these lives for another 100 years. And that's the reason why vaccinology is so important, even for neonatologists as such. So Sagar, should we proceed?
Yeah.
The format is going to be like, we would be picking up a question which actually have come from you, and one of us would ask a question to the other and he would try to answer. If he fails, the other one would answer. If not, you would answer. So let us begin.
So Ganesh sir, there is this 35 weeks, 1.9 kg baby, and the baby is about to be discharged from NICU. And the grandmother is suggesting to postpone the vaccination till the baby gains weight or reaches at least 2.5 kg. So what is your opinion? Should we postpone?
So the question is 35 weeks preterm, 1.5 kg newborn. The grandmother is very right because that's a concept or a myth in population, in a community that these are very tiny babies, premature babies, and vaccination should not be given because the concept is every one of us, we know that there is some kind of immune immaturity with these preterms and probably vaccines wouldn't work. It wouldn't generate that much of immune response. And that's the reason not even the grandmother, most of the pediatricians think that preterms should not be given vaccines, they should be delayed to some other time. But that's not actuality. The actuality is, in fact, a child is born, however preterm is, 35 weeks, 30 weeks, 3 vaccines are important to be given soon after the birth. One is BCG, other is hepatitis B, and third is OPV. When it comes to BCG, we know that the BCG has to be given soon after birth. Actually, it has to be given within first 7 to 14 days. That becomes the most relevant time. And it has to be given because we know that it works through T cell. Even then, the maternal antibodies are there. They won't interfere with this particular vaccine. The other vaccine is OPV. The 0-dose OPV has to be given despite all this IPV which has come up in a big way. The reason of giving OPV soon after birth, despite the immune immaturity, is basically it primes. It may not give you an immune response, but it primes it very well, and it sort of prevents VAPP afterwards when we give OPV, because it is OPV given when the maternal antibodies are actually there. So they prevent VAP. So that's the reason why OPV has to be given. And the third is hepatitis B. Even then, No, there was a concept before that below 2 kgs hepatitis B was not to be given soon after birth because it does not produce that much of immune response. But that concept has also gone now. We are supposed to give hepatitis B vaccine soon after birth, within 24 hours. That is called as timely birth dose. And it has to be given. It would generate immune response. And the best thing that is, it will prevent vertical transmission. So that's the reason why, even if your grandmother or a pediatrician says that it has to be delayed, despite immune immaturity, the vaccine has to be given.
Right. So basically, the vaccine-induced B cells, they are equal in preterms, they are equal in terms. The T cell immunity is good in preterms, is good in full terms also, and there is no reason that you should postpone the vaccination just by saying that a baby is preterm or a baby is having some such weight which is less. True.
Yes,
so that will be take-home message. Okay.
In fact, there were a lot of changes which are happening in between. Last time when we knew about BCG, it was 34 weeks and above BCG was to be given. Then the recommendations changed. They said that no, 30 weeks and above you should give. Now, Sagar, what is the latest one?
So right, there are studies now that the safety of BCG has been proved above 31 weeks also. So you can give BCG at any gestational age above that and at any weight also. Just remember, BCG is to be given in a clinically stable baby, that's all. No weight criteria, no gestation criteria. So that is the take-home message.
So when we talk that there is an immune immaturity, what kind of immune immaturity these preterms have?
So there might be some waning of antibody, that is okay. And there was one study by Mahanecon et al. She had selected 94 term and 92 preterm babies, and they sought out. But the antibody response to every antigen, including the pertussis, was optimal in both preterms and terms. Only thing, there was some minor immunogenicity decrease which was noted in hepatitis B and anti-PRP antibodies for Haemophilus influenzae, but that was also not significant. After taking 3 doses, the immunogenicity in a preterm and a term baby are almost equivalent, and when you take the boosters, it is totally equivalent. So that is the basic risk.
That's absolutely right, Sagar. Another thing that I want to add is, see, on one side we say that preterms are immune immaturity, but on the other side, that makes them more susceptible for vaccine preventable diseases. So the take home is, even if they are little immature, they are more susceptible. That's the reason why vaccination becomes more important for them.
See, I know many pediatricians who say that, why don't you vaccinate at 2 months, 4 months, 6 months, instead of giving 6 weeks, 10 weeks, 14 weeks. Because there were some studies, some Western countries were following like that. Remember, in our country, we are thinking of 3 factors. One is epidemiological factor, disease. Second is programmatic convenience. And our aim for a very higher GMT titers. In our country, we don't go behind GMT titers. What we are worried about is our epidemiology. What we are worried about is rigorous immunization. Because sir has already said, that child is susceptible for diseases in very early age, in early infancy. The death rate is more in that rate, and we want protection in that age. So there is no point in postponing vaccination for that purpose. True, correct? But the grandmother said, see, I am telling you not to postpone vaccination. You gave BCG to my stable preterm baby, but now after 3 months the baby has not developed a scar. So you have not listened to me. I am a grandmother. तुमको क्या समझता है? All grandmothers say the same thing, isn't it? तुम्हाला काय कळतंय म्हणून. So now what to do?
That's also a big catch, because these are the things which make us. So these are the things which probably I'm not.
Yeah, Lord. It is working. It is working. Take that.
Hello. Yes. So these are the things which, kind of create confusion in our mind. But we need to understand, see, BCG scar is just a surrogate marker of vaccination. Having scar does not guarantee you an immune response. Neither absence of scar would tell you that the child has got immune response. So scar is just a mark of given BCG. That's one thing. Second thing is, when we talk about scars, routinely, when you give a BCG vaccine, 6 to 12 weeks later, you get a scar, right? But there are babies who do not get that scar, even if they develop an immune response. The prevalence of scar in preterms is, the failure of prevalence of scar in preterms is as high as 55%. And in terms, it is almost to 20%. So that in fact, sometimes, I feel BCG, if many of you must have experienced that. giving BCG in front of granny, it makes me jitter. I do it from this side and the vaccine goes from the other side.
BCG giving is an art.
It's
Even
an
many pediatricians don't know how to give BCG. I know there are some pediatricians who refer for BCG to government setup and tell them come back for next vaccines. So this is a very
or smartly I tell my sister, you give it here. Or then I said, the granny, you please wait outside, I'll give this BCG. So there are things, but that's keeping that aside. If scar has not come, how long to wait? So the scar failure by definition is, even after 90 days of vaccination, if there is no scar, then it is said to be a failed BCG or the scar failure. And then thereafter, Sagar mak kai karaycha? Should we give it again?
Repeat it.
Should we repeat?
So after 6 months, you can repeat if you want. Government does not repeat it, but if the parents are apprehensive, they want a scar, you can repeat. Now, there was one study in which they took 92 neonates who were given BCG, but there was no scar mark, and they did the LMIT, leukocyte migration inhibition test. And in that LMIT, they found out that 90% had developed immunity, though there was no scar marks. So that is actually what is the scientific evidence, that don't worry about scar. Scar just means that it is just the uptake of the BCG.
It is just a scar. Yes.
So next question, we'll take. So these questions are arranged randomly, so we are taking it. Okay.
So now this is about the other vaccine is hepatitis B, a very important vaccine for neonatologists per se. Sagar, this is a 35 weeks late preterm, 1.9 kg baby delivered by LSCS. Mother is HPSAG negative. Should I give birth dose of hepatitis B in this vaccine? See, this is Sagar, so many friends of mine, they ask, HPSAG negative, my mother, we know that. Why do you are rushing for this hepatitis B vaccine?
So basically, can you guarantee the quality of the RDT which you are doing? That is the first question. We know that most of the deliveries are taking place in village, rural areas. Home deliveries are taking place. Some DMLT, CMLT person is carrying out the lab work. And it is said that the RDT which we are using, the sensitivity and specificity is only 90% and 99% respectively. And the sensitivity drops down to 72% in HIV cases. So even you can't believe on the H-based antigen test which is done by RDT in a village or rural setup. What is needed is an enzyme link study or a chemiluminescence study which is not available. So that is why I say instead of relying on that H-based antigen test, it will be better if you do universal hepatitis B immunization. So coming to the preterm low birth weight baby, what is the recent WHO position paper that not vaccinating a preterm, not vaccinating a low birth weight, out of fear of adverse events or out of fear that there might be wastage of vaccine, these are all false contraindications in the mindset of us, the healthcare workers. So what, as a faculty, we used to teach that please don't give hepatitis B below the weight of 2 kg. Now that is out.
Yes.
Now you are supposed to give hepatitis B vaccine to all babies, irrespective of their weight, irrespective of the gestation. Don't worry about what effect, what immunogenicity it is going to carry out. In a preterm, just don't count the dose. In term, you can count the dose.
Absolutely right, Sagar. Perhaps India is a hub for chronic hepatitis B infections. And we all know that what hepatitis B in a long term does. The complications are so dreaded that we do not want to lose our kids into their adulthood. So that's absolutely worrisome. That is the reason why WHO has made it universal vaccination against hepatitis B soon after birth. Now, soon after birth means how soon?
See, if you want that birth dose of hepatitis B to be effective, you have to give within 24 hours. If not possible, at least within 72 hours, but never later than 7 days. Now, government definition of what is a timely birth dose, so we have to report it to the government, how many vaccinations we did. So, any dose which are given within the first 24 hours will be a timely birth dose. Anything which is given beyond 24 hours will be a late birth dose. So, that is a government definition, but as I said, maximally you should try to give within 72 hours so that it will be effective. So even if the mother is H-based antigen positive, if you are not given hepatitis B immunoglobulin, still it will be 70 to 75% effective against preventing the transmission.
And perhaps the intention of giving a timely birth dose and a late birth dose, there are two different ways to think about it. One is timely birth dose, that means the birth dose, the hepatitis B vaccine given within 24 hours has a maximum effect in curtailing the vertical transmission. Whereas the late birth dose, probably when you miss that particular golden time of 24 hours and you still want to give that particular vaccine to that child, is perhaps to terminate the horizontal transmission. Because see, we always thought that it is a vertical way of transmission, but more than that, there is horizontal way of transmission, which is equally important. And just to stop that horizontal way of transmission, late birth, or whatever the day the child comes thereafter, you are supposed to give that vaccine.
True. So, as sir has already said, 4 types of transmission: vertical, parenteral, sexual, horizontal. So, the universal birth dose is going to take care of only the vertical transmission. But the horizontal transmission which occurs between families, for that you have to give a late birth dose. Now, what WHO says? That, let us say, I'll give you an example, a 30-day baby has come to you. He has not taken a birth dose of BCG, not taken a birth dose of hepatitis B. Should we give or not? Yes, you should give it. What WHO says, that the late birth dose also should be given till the time of the first dose of the primary series. So even if a baby comes at 25 days, 30 days, 35 days, whatever, give that hepatitis B dose, as such you are not going to count it.
So up to 6 weeks probably you would be giving, but to logically, if the child is coming few days before the 6th week's dose, you can
fine, 1 or 2 days here doesn't matter.
Now there is a twist. The mother is HbSAg positive, and this child is 32 weeks and 1.6 kg delivered, born to a HbSAg positive mother. But simultaneously this newborn is sick also. Now these neonatologists are very scared. They say, don't give vaccine, my child is already sick.
No, so this comes under emergency vaccination. So even if the baby is admitted in NICU, you are supposed to give the hepatitis B immunoglobulin dose and also the hepatitis B vaccine dose, even if the baby is sick. Now, some one day here and there, suppose the baby is hemodynamically unstable on ionotropes, you might wait for some hours or one day, but you follow the 72 hours principle and you give HBIG and hepatitis B vaccine, even if the baby is admitted in NICU, even if the baby is having septicemia or RDS or anything. That is the rule.
Absolutely, Sagar.
Yeah. So coming to the next question, Ganesh sir, government is using this 2+1 schedule of pneumococcal vaccine. So saving 1 dose, saving money, we are using 3+1 schedule. So why not, I should also start this 2+1 schedule. Why we should stick to 3+1 schedule?
Pneumococcal vaccine is important, we know that, because under 5 mortality, the second most important disease that, taking a role in our under 5 mortality is pneumococcal disease. Invasive pneumococcal disease per se, because that is very common at earlier age, in infancy as such. Now, scheduling about this particular vaccine, there are different schedules which have come up. One is 2P+1, that means 2 primary and 1 booster given at 9 months of age. Second is 3P+0, that means you're giving only 3 primary and not giving a booster at all. And the third is 3P+1, that is 3 primary and 1 booster given 16 to 18 months. Now, we private pediatricians, the ACVIP guidelines followers, give it 3P+1, right? 3 primary and 1 booster. But WHO has now started giving it for our government setups as 2P+1. Now, why is this? See, as Sagar has rightly said, that there are a lot of things when a scheduling is formed. There is programmatic feasibility, cost of the vaccine, the mass vaccination. So, government has to think over a lot of things. Now, 2P+1, which is actually a very good scheduling, which saves some cost, because you save 1 dose, so you're saving cost. The problem with 2P+1 is, it has a primary vaccination for 2 dosages and 1 booster at 9 months. This does not really go well for 6B and 23F serotypes.
Correct.
And which is actually very, this is a prevalence is much higher during first 6 months of life. So that's the reason why 2P+1 is not to be advocated in private practice. So we would be giving 3P+1. Moreover, lower number of doses, the OPA titers are better. If you want to correlate of protection, if you want to check, probably 3P+1 is the gold standard. One more thing, more the number of pneumococcal vaccine dosages, probably the mucosal clearance is much better. So that's why you probably stop the transmission of the disease. So probably you go along with 3P+1.
And the seroprotection against 1, 4 and 5 serotypes. Yes. The OPA titer is better with 3+1 schedule. So in office practice, stick to the 3+1 schedule. But the issue is, the child has taken 2+1 in government. The child comes to you at 18 months. Your routine habit is to give a 18 months PCV booster.
For money or for the dose? It is the pediatricians always thinking, now one of my Prevena would go. It's not that way. Because that 2P+1 is, the booster dose is actually given at 9 months. So even if he comes to you at 16 or 18 months, he has already received his booster. So So there's no point in giving another booster to this particular child.
Very true. So the germinal center reaction, what we were aiming to keep a gap of 4 months between the primary series and the booster, we are already completed it. So the 9 months vaccine has already worked as a booster. So giving one more booster, there is no logic behind that.
Now, another wonderful thing, because these neonatologists are very, keen to observe this. They are so good in their labor rooms. They actually not, birth aspects is not seen at right now. The prevalence of birth aspects is almost not seen. And hats off to all of you. You all guys are doing fantastic job. But still, there is a case of birth asphyxia with HIE who was brought for 6 weeks vaccination. Will you offer acellular pertussis based vaccines or WP based vaccines?
So this confusion is always there, WP versus acellular. And even if the case is a case of birth asphyxia or HIE, you can give WP based vaccine. It is not contraindicated in birth asphyxia, number one. Number two, we agree that if the parents are not convinced, they want a less reactogenic vaccine, you might tell them about acellular pertussis vaccine, you might do one-to-one discussion, and if they want acellular only, you can offer them, that is okay. But WP vaccine is not contraindicated in birth asphyxia, you can give it straight.
It was earlier being said that non-progressive neurological disorder, those things. But now you can give one of them, no problems. But after one-on-one talk, as he rightly said, if the parents are ready, acellular would definitely have an edge over the WP. Now, this child was given WP vaccines as per standard expert advice. No, you said it and they gave it at 6 weeks of age. But the child had hypotonic, hyporesponsive episode. Now, again the same catch. They said, you said and I have given it. The baby was again brought for his second dose. Now, he wants to listen to you. What are you going to do?
So basically, again, you have to convince him scientifically. These hypotonic, hyporesponsive episodes, unexplained fever, insistent cry, and these contraindications are mainly for the first dose of WP. In fact, these decreased on the second and third dose. We have to explain it to them that yes, the child might have had this hypotensive, hyporesponsive episode, but that episode is not going to probably occur in the second dose, and you can still safely give him WP vaccine.
Right.
But again, the same catch. You can explain them acellular pertussis vaccine, do a one-to-one discussion. There is definitely a study called as impact study which says that the acellular pertussis vaccines, the chances of hypotensive, hyporesponsive episodes and febrile seizures are 70% less in acellular pertussis vaccine. So do a one-to-one discussion. You can give the vaccine to that baby. No issue
Yes,
about
absolutely.
that.
And all these things what he has mentioned just now, they were contraindications before. Now recent guidelines have shifted them to precautions. They are not contraindications, they are precautions. That means if such things have happened, you would be more precautious. You would be more, taking care of these kids. Still you would be giving WP, it doesn't matter.
We all have seen this discussion many times. Is preterm baby a high risk baby? Should we label a preterm baby as a high risk baby?
See, that's what, the neonatologists say that preterm babies are precious babies. The
So
parents
someone
also
was
say
saying in
precious
afternoon,
babies.
you have
Someone
to
would
stop
say,
using this precious term.
So they have so much of, they are possessive about their preterms. They say that it's a precious baby. Someone say, no, it is a high risk baby. But in vaccinology, the definition of high risk is different than actually what high risk in preterm is. They definitely are high risk, no two doubts, but vaccinology per se, they are not high risk. They are in fact immune immature. They need more care. They need more to be, we need to be more cautious. But when we call high risk in vaccinology, it's a different segment altogether. So I would not call them high risk. I would just call them a special group or a
might be a special
care
group or priority group, you might call them, because if you label them as high risk, we'll have to give them PPSU 23, we'll have to give them meningococcal vaccine 2 doses.
Yes.
The principle changes,
Principle
isn't
changes.
it? Yes, true, very true.
This doctor by mistake did some miscalculations. Of his first pentavalent vaccine was given on day 36th of life. Instead of 6 weeks, he gave it on 36th day. Now, what is to be done?
So basically what we are dealing with is a grace period. So we know that between any two same antigen, we have to keep a gap of 4 weeks. But that is for the second dose, third dose, or between third dose, fourth dose, something like that. But there is something called as grace period for the first dose in a primary series also. So we know that we are vaccinating the baby at 42 weeks. But if you give vaccine for any purpose, either on purpose or by mistake. 4 days prior to that, that will be considered as a valid dose. But before 4 days, if you give that, the first dose of the primary series, it will be counted as invalid and you will have to repeat the vaccine when the child attains the recommended minimal age. So you said what day was?
Come below 36th day.
36.
That comes
So,
much before than the 45th day.
so after 38th day, it will be valid. 36th day invalid, you will have to repeat it. Very true.
No, if you want to repeat it, when do we repeat it?
There are two thoughts now. One is the CDC USA guidelines and there are experts from our country. Our government of India guidelines are that you have to repeat it when the child achieves the recommended minimum age. So irrespective of the gap. So if the gap is 7 days, we'll have to repeat it. Now CDC says that, okay, you can wait for 1 month and give it. There will be no harm. Just complete the whole series. That is what CDC says. Now there was this pregnant woman, 14 weeks, and she had a road traffic accident. Obstetrician saw her. Obstetrician gave her Tdap vaccine for TT. But when the mother came at 28th week, she was now confused that she wanted to give Tdap, but now she has already given it Tdap. Should I give it Tdap for neonatal pertussis purpose or?
Wound care.
Wound care.
Probably. No, this is.
How much more time we have?
5 minutes.
5 minutes.
Finish. Actually, this is again a different situation here. Normally, for every pregnant woman, we would give Tdap between 27th to 36th week of gestation. You know? But here, this vaccine was given for wound care. So, the catch is, when we are vaccinating a pregnant woman for either for wound care or some pertussis outbreak or something like that, you can give it during any time in the pregnancy period. But once we have given a Tdap, now there are also two different theories. One would say that, no, you repeat one more Tdap because that Tdap is going to give a protection to the newborn thereafter. But the consensus by CDC is that if you have given one Tdap anytime during the pregnancy, you do not repeat it.
Fair enough. Now this mother had chickenpox rash 2 days prior to delivery. So now only 5 minutes are remaining. Let us give one line answers.
Yes,
okay.
sure.
So chickenpox rash 2 days prior to delivery. Recommendations for the newborn?
You have to give HBIG and hepatitis B complete series.
Varicella zoster, immunoglobulin and acyclovir for the
because
baby.
5 days before and 2 days after the delivery, if the mother has got chickenpox, the child do not have any kind of antibodies and the viral load is much higher transplacentally transferred. That's the reason why we need to call it high risk baby.
Okay, fair enough. Now the mother had LSCS and the mother had chickenpox 2 weeks after delivery. The baby is full term, 3.5 kg. Still you want to give immunoglobulin vaccine?
No, because this is a full term child and this does not fall in that 5 days and 2 days interval period. So this child will not require anything.
So once the child has crossed a 12-day period, there is no need for hepatitis B, immunoglobulin or acyclovir. Don't do anything. The baby is not at any increased risk for complications from chickenpox.
Okay, so this is after delivery of 3rd day the baby was brought home with all family members waiting at home for arrival. Out of excitement, pet dog bit this baby. Small amount of blood was also noticed. Now pet dog was vaccinated. Now this is a very tiny baby. Now Sagar, don't tell me to vaccinate this child again.
But by rule, you will have to give immunoglobulin also because there was bleeding. So it became a category 3 wound and you will have to give rabies vaccine also to a newborn baby also. So a newborn is not a contraindication for rabies vaccine, remember. Babies born to HIV positive mother. What will we do about BCG and OPV at birth?
Again a Pandora's box, there are a lot of things. But one line answer would be, if BCG, symptomatic child, don't give it. Asymptomatic child, you give it. OPV, do not give it. And if at all you would be able to give IPV instead of OPV, you can give IPV.
Okay, fair enough. There is this preterm baby, 800 gram baby. But the baby was admitted for 6 weeks. 6 weeks has already crossed. Now the baby is going to be still there in ward for even more 4 weeks. So, do you think we should vaccinate or we'll wait for the baby to get discharged?
No, this depends upon the clinical stability of the newborn. The dictum is a preterm or a term baby who's clinically stable should receive vaccines as per the schedule at its actual or chronological date.
True. So, even if the baby is admitted, the baby is in a special care unit or baby is in there with a mother in a room, you can vaccinate the baby. But if there are many patients, some sick, some immunosuppressed, then you don't give rotavirus and OPV. But you can still give the hexavalent vaccine to that baby also who is admitted in your SNCU or in the special room. Don't postpone the vaccination, you give the vaccine.
Right. So now I think we would wind up, Sagar, because we would give them 2 more minutes from our side, gift to them. Before I finish and we finish.
We'll take last 2 questions.
Yeah, that's what I am coming to you now. Now tell me, Sagar, in pharmacology wise, we say that, in medicine we say that fixed drugs, multiple drug combinations are not good, right?
Yeah.
But in case of vaccinology, monovalent vaccines or combination vaccines?
Always combination vaccines. There are
Why?
so many
Here
ways.
you say that drug combinations are not good. Here you say that
There are
combination
so
vaccines
many advantages, less number of doses, less number of injections, less load on cold chain, less need for storage, better
great.
compliance, so combination.
Second, do you want to reconstitute and give the vaccine, or you want a ready-to-use vaccine?
Ready to use, will be better.
That's
Last
again
minute,
better.
please.
So are there any vaccines of combination that you know?
See, for the primary series, we have all these beautiful vaccines which we have. There is this pentavalent vaccine, we have WP based hexavalent vaccine, we have acellular based hexavalent vaccines, we have vaccines like Pentaxim, which is a quadrivalent vaccine, we have vaccine for 5 years like Tetraxim, it is a combination of DTAP plus IPV. So, lot many combinations are available, it is a basket and you can choose from this basket, so they are very useful in our private practice.
So the hallmark is Tetraxim, Hexaxim, Pentaxim. Now these all vaccines are ready to use vaccines, that's one thing. They follow the QSPs. QSPs is quicker, safer, precise. This was for my sponsors. Thank you so much.
Any
For
questions from your
sponsoring
side?
this particular thing and making this topic relevant for a neonatologist.
Any questions from any of us? We will love if someone will ask a question. Then
Thank you, Dr. Ganesh Kulkarni and Dr. Sagar Kulkarni.
Thank you very much. Thank you.
For the final session, I invite Dr. Dayanand Nakate on medical errors in NICU.
Before this last lecture, there is one important announcement. We are going to listen few words of wisdom by Honorable Dr. Simin Irani. So I request you all to stay back and grab this golden opportunity to listen to Madam Simin Irani.
Good afternoon, everyone. Though I am the last batsman to finish this session of our Mahanecon 2023, so I am very much thankful for giving this opportunity to talk on medical errors in NICU. Sorry, the heading. So, error. What is error? To err is a human. So, an error is a deviation from accuracy or correctness as a mistake. So, the error can be defined as a failure of planned action to be completed as intended, whatever the intention was there. It is the error of execution, or it can be a wrong plan or error of planning. So, there are two components in an error. So, in this talk, I am going to have errors in modern medicine, classification of medical errors, then burden of this error, what is the exact problem of medical errors, then how to quantify the risk factors, then is there any grading or is there any classification for medical errors. So, what are various specific types of medical errors, then how to minimize, and in short, a take-home message. So, coming to the errors in NICU, what are the various medication errors? It is a failure in the treatment process that leads or has the potential to lead to the harm to the patient. So this can be in two parts. One is adverse drug reactions, and it can be an adverse event. Just like event can be in the form of multiple signs and symptoms, or it can be a syndromic. So it is an event. And if this particular reaction is there, adverse reaction, particular reaction in the form of some urticaria, some itching, some chills, rigors, so that can be a particular reaction. But if it comes to for example, if you want to take this as an event, the Stevens-Johnson syndrome is secondary to the penicillins or some sulfa drugs like that. So this can be event on syndrome. So these are the two different examples. So there are various components or various parts of the adverse drug reaction. One is adverse events that are not reactions to a medicine particularly. So this can be a coincidence that the patient may have complaints. Then adverse drug reactions are not from the errors itself. They may not be. Then they can, but these adverse drug reactions can be from the medicational errors. Medicational errors that cause the events that are not adverse drug reactions, and medication errors that don't cause adverse events. So there are these 4 to 5 components in adverse drug reaction. So how to classify? So if you want to classify the errors, this can be divided into one definitely directly there is a mistake, and there are these mistakes, and there is skill-based errors. So mistakes can be in the two parts: error in the planning action, that is knowledge-based errors, rule-based errors. Then again rule-based error can be in two ways, that is good rules are there, they have been defined, that is just like the protocols are there, but they are not been applied. And there are not at all protocols, and they are not been followed. So this is rule-based. Thirdly, action-based errors are there. They're just because of just slippages, or this because of the technical errors. The person who is implementing is not technically sound to conduct that action. And sometimes even though perfectionist is there, even though trained person is there, and he just skips the things because of some memory loss or because of the just lapses. So these are commonly things. So knowledge-based error, for example, giving penicillin without having the proper history that the patient is allergic to penicillin. Then rule-based, as I mentioned, that is giving injection, diclofenac or some IM injection to the child on the lateral aspect of the biceps, instead of preferably choice of the injection will be at the thigh region. So action-based, the picking of the bottle instead of just like sometimes we have an emergency trays. Some, for example, vitamin K injection and Celasics, they look like same. So this can be a grave mistake. Then memory basis, the patient was sensitive to penicillin, and this thing was also known, but accidentally it was given. So this is just skippage. So the other dimension of the medical error, this is one part, this is for the action part. The other part is again the writing the prescription, then transcription, dispensing the medicines, administration of the drug, and monitoring. There are 5 components. And this can be again because of the deficit in the knowledge itself, or it became the typical mistake itself. So the resulting error may be one of the range of types, that is wrong drug, wrong dose, wrong frequency, wrong patient, wrong route, etc. So this is again based on the knowledge, but the person is not able to conduct that properly. So rate of error or the extent of the harm which resulted may be, as it can be measured as a pre-medicational error, or it can be adverse drug event. So the medical errors can occur as a choosing the medicine. It can be irrational combination, inappropriate or ineffective choice, or under prescription or over prescription, or overdosing or underdosing. The writing the prescription, as you know, it is blamed that most of the medical practitioners don't have a good handwriting, so the errors can happen. So prescription errors because of the writing itself. Then manufacturing of the formulations, maybe wrong strength, maybe adulterations, or it can be a irrational combination itself. Then dispensing, suppose there are some corporate hospitals and there are some units where the dispensing is done from the pharmacy unit, and then there is a wrong drug combination or wrong formulation like that. So, and when it comes to the patient itself, then administration or taking the drugs itself. So coming to these various types of error, how much it is the burden? Definitely, I am going to say that nobody will say that I have not done a mistake. So there are mistakes, but there is definitely a lack in documentation of these errors, and even Indian data is very much poor in documentation of these medical errors. So there are various studies from the UK that 36,200 medications orders were given, and out of to the tune of 2%, that is 1.5% were because of the wrong dose. And that too, out of that, 0.4% were potentially serious or dangerous. And in the other study, there are 40,000 medical errors in 173 hospitals that were the trust hospitals. That to 15% were having in the range of slight harm, and 5% were moderate to severe harm. And another study from the USA states that 3 billion prescriptions, out of that 3 billion, 50% would contain the errors. And that too, out of that, 0.1% were the clinically important. Another report from 2000 reports from UK Medical Defense Organization say that 20% of the litigations, that medico-legal issues that have arisen because of the medical errors, and that are mainly because of the prescription and dispensing errors, repeat prescription without proper checking, failure to monitor the progress, the failure to warn about the adverse reactions. And now, how do we quantify these errors or magnification? So, if you want to classify, that error can do no harm, but it has done, impact is prevented. Then the other part is no harm, but the impact has been not prevented. Any patient safety incident that ran to the completion, but no harm occurred, due to the receiving care. Then low harm, then moderate harm, severe harm, and to the tune of death. So this can be classified as a 1, 2, 3, 4, 5 like that, but the maximum risk is the up to death, that can be the severe form. Another classification from this, there is national grading of the medical errors is there. They have been decided that there are significant, minor, moderate and major catastrophic events. So they have given different scores. And then depending upon the likelihood of recurrence, whereas if the recurrence is almost certain, they have given 5, 10, 15, 20 and 25. And if the recurrence is likely, then the score is 4, possible is then score is 3, unlikely is 2 and very rare is 1. So depending upon this chart, you can grade as a low risk, high risk. So if the score is in between 1 to 3, the event or circumstance have occurred which have been the capacity to cause an error, but it has not harmed the patient. So another is the low risk with the score of 4 to 6. An error has occurred that reached the patient and required monitoring to confirm that it resulted in no harm to the patient or required intervention to preclude the harm. An error occurred that may have contributed to the resulted temporary harm to the patient and required intervention. So coming to the third part, that is moderate risk, the score is in between 8 to 15. An error has occurred that may have contributed to the result in the temporary harm to the patient and required prolonged hospitalization or delay in the hospitalization, and that error that may have contributed to the result to the permanent patient harm. And in the high risk, the score is 16 to 25, and definitely the error has occurred that may have contributed or resulted in the patient's death. So there are these various classifications, and they are from the National Coordinating Council from the India. So coming to the various types of errors, there are various very less studies from the Indian data. So these types of errors can be as a prescription errors, administration errors and the transcription errors. And they are in the tune of around 1 to 30% and maximum up to 40% also. So this chart shows various types of errors, and this is a different study from. So again, the prescription errors I have mentioned, there's wrong doses, underdoses, overdoses. These are the components of prescription errors. Then administration, that is monitoring the omission, then wrong time of administration, then underdosing, overdosing, then again wrong route. These are the various components of administration, and for the transcription it is the wrong frequency or the wrong doses. So this is another study from Indore where errors related to the medications with a tune of 68%, and misuse of the medication in that form of incorrect medication, then incorrect route, then incorrect dose, and that percentage was around 3 to 45% for the incorrect doses. That is a tune of very high percentage. So what are the various factors that are responsible for prescribing the errors? So one is insufficient knowledge of the medicine that is being prescribed, so then accuracy of the doses, then and basically not knowing the patient's history or particularly for the allergies. Another important that I mentioned is illegible handwriting, history including the wrong medications being taken, then confusion in the name of medications, or patient itself. Actually, suppose we are supposed to give to the patient just like bed number 7, 8, 9, 10 like that, and if you are prescribing for according to the beds and without the patient's name and all that, so then these errors can happen if the medicine from bed 3 has been given to the bed 5 or like that. So calculation mistakes, definitely these medical errors of calculations are mainly in the NICUs as well as PICUs from the junior doctors or the residents on duty. So they have to be monitored and they have to be meticulously checked in repeatedly. So again, nowadays use of inappropriate, unclear abbreviations. Everyone is using short forms for particular words or things. So then these abbreviations should be standardized or they should be followed. If they are there standardized, then and then you should follow. Otherwise, you just get the clear-cut information from that. Then most of times when we are out of the town or when we are not in the ICU, sometimes we order on the phone and some medications may get wrong pronunciation and all that. So insufficient training is one of the reasons why these medical errors can occur. Then lack of awareness of the errors. Sometimes the person does the mistake and he is not aware that he has done the mistake. So this is awareness lacking. Then most important, as we are having much workload in our setups, and most of times work environment and workload is very important. As we know that all the residents are working for more than 18 hours, 19 hours in a 24 hours a day. So this can be a most common reason why most of the medical errors can be done because of this work environment. And next important is the poor communication with the healthcare providers. And the last, not the least, is the look alike and sound alike, that is LASA errors. So this is an example for LASA errors. Amaniphylline instead of amitriptyline, then amoxicillin instead of ampicillin, just like cyclosporine or cycloserine, then bisacodyl and bisopropanol, then Zantac and Zyrtec. So see, these are few examples for the LASA errors. So we have to be very careful what kind of drug you want to prescribe and what has been exactly given, and you have to have a recheck list always. So there is one synonym that is the IEDO. So there are 9 questions before writing the prescription. One is indication. Is there any indication for that particular drug? Secondly, whether that drug is going to be effective or not. Thirdly, whether it is particular to that particular disease, or suppose this is given to the patient if the patient is having previous illness and that is going to cause the illness or additional burden to that because of that drug. Thirdly, whether the patient is on similar drug, already the patient is taking and you are repeating the dose of the same. And most important is the drug interaction. Drug to drug interaction is very important. Again, dosage is very important. Not only the dose milligram per kg, but the frequency, the route and the formulation. It has to be very, very carefully mentioned in the prescription form. Then giving to the orders. Again, orders has to be given in the written format always, or the papers instead of verbal orders. Then, and if you are trying to give, sometimes there is chance that you need to give verbal orders, then try to check or recheck that whether that has been properly conducted or supervised or not. Then basically most of times what happens, some medications are given. Recently we had an example, the patient was given zinc supplementation for 3 to 5 days period, and the patient continued 3 to 5 bottles of the, so similarly this thing happened because of patient's understanding can be different. So duration of therapy is very important. Then economics is the drug, cost effectivity is again very important. So coming to the how to reduce this burden or the medical errors during the prescription form. So preferably nowadays these computers and laptops, and this has reduced the legitimacy of the handwriting. Still that is again a preferred choice that you should have this electronic media using. Then clear and effective communication should be there. Using generic names for this particular antibiotics or the drugs preferably will be better. Then avoid abbreviations, verbal orders, unclear instructions. Achieved balanced prescription by using mnemonics. Then realize the equipment, then medical delivery, then ensure the correct calculation of the proper drug doses. Most important is that keep the hospital environment quiet and safe to avoid the further errors. Have a qualified professionals with adequate level of training and education. But a prescriber should have a provide patient with information related to the medications. Then transcription errors, incomplete prescription, insufficient information, and clinical decision error. These are the 3 types of transcription errors. Dispensing errors, then again I mentioned is LASA drugs, poor handwriting, then lack of experience, training the knowledge that has to be improved. Systems using such as labeling the computer programs, again. So many things that can contribute for the administration errors, that is lack of knowledge that again mentioned, then complexity of the equipments. So how to minimize this? So as I mentioned, this again to minimize, then that is again based on the whether they are helpful, whether they are strong recommendations, whether they improve this. So electronic prescriptions have been studied and they have definitely given the positive impact, and that has been, there is a strong recommendation as far as transcription is concerned. Then adverse reactions also, they have a positive impact, and then there is a strong recommendation. But for education, then clinical decision making and structured order forms, there is a promising evidence as far as positive impact of the outcome of the measure or the as far as medical error concerned. But there is less evidence or there is less recommendation as far as patient history taking, pharmacist support, and standardized pediatric formulations. So these are the various recommendations based on the effectiveness to reduce the medical errors. So in short, at least 6 major changes are required to begin the journey to culture of the safety. That is, errors are not individual failures, but they are the results of the system failure. Hence, move from one punitive environment to the just culture. No more secrecy, move toward transparency. Care should not be doctor-centered, but it should be patient-centered.
Last 2 minutes, sir.
Yes, last minute. Move our models of care, that is from reliance on independent individual performance to the interdependent, collaborative and interprofessional teamwork. That definitely helps and that reduces the risks. And lastly, if someone says I have not done any medical error in practice, then probably he has not worked at all. Thank you.
Thank you, Dr. Dayanand Nakate. Thank you, Chairpersons, Dr. Deepa, Dr. Sneha. Thank you, Quizmaster, Dr. Ashutosh Yajurvedi. Please proceed for felicitation. We now invite Dr. Rishikesh Thakre for further proceedings.
So, a very good afternoon to you all. As we come towards the end, I am sure all of you would be excited in knowing the awards for the free paper and poster. And to present these awards, may I invite Dr. Pratibha Patil onto the dais, Dr. Vikram Hirekerur, and Dr. Anita Hari Balakrishnan. For poster presentation, Ashish, the first prize for the poster presentation, so for the best poster, first prize of rupees 5,000 to Dr. Shweta Chowde. Second prize to Dr. Karthik Kolkure, that is of rupees 3,000. Third prize to Dr. Shweta of rupees 2,000. We have two special prizes, and may I request Dr. Pratibha to hand over. Dr. Ruhi, prize for rupees 1,000. Dr. Kevin, prize for rupees 1,000 for the best poster. And lastly, the judges thought that there is a need to give the best prize for the best innovation, and we have it for Dr. Aryan Patil. Heartiest congratulations. So now we come to the last part of the prize distribution, and that is for the best paper. So we have the best paper that was judged by two judges. The third prize goes to Dr. Siddharth Shailesh Patil of 2,000 rupees. Madam Anita to hand over the prize. The second best paper award to Dr. Priyanka, 3,000 rupees. And the best paper receiving the first prize is by Dr. Ashutosh Pai for 5,000 rupees. Heartiest congratulations to one and all. So thank you very much. Before we end, may I invite Dr. Sandeep to take over the proceedings as we finish the agenda for the conference.
Thank you, Rishikesh. We are very much lucky, I mean to say, that Dr. Irani madam is there with us for the entire conference, and we now from Solapur Academy of Pediatrics wish to felicitate her. For that, I request all Solapur Academy working committee member and reception committee member, please come on the stage. Meanwhile, I declare the quiz winners. Please collect the prizes from the reception committee. Dr. Swapnil Giri, Dr. Sukanya, Dr. Sahil Mehta, Dr. N.D. Birazdar, Dr. Snehal Rathod, Dr. Shreya Patil, Dr. Jyoti Patil, Dr. Deepika Mashalkar Bhosle, Dr. Nachiket Inamdar, Dr. Aishwarya Madane, Dr. Karthik, Dr. Shambhi Vattal, Surbhi Vattal, Dr. Gurav.
Now I request Dr. Vaidya sir to present a memento to Madam Irani ma'am. Mic. Now I request Madam to give us few words of wisdom.
To all of you, I am indeed very thankful and grateful to all of you, all Solapur members, administration, all of you who've been present here. I think within a short time of 6 months, I don't think, at least to my thing, I have never had such a short time having such a conference, so well prepared. And believe me, everyone had a feast of time. I mean, all the workshops which were taken, all the presentations which were done, it was an eye-opener to all of us, how you go from basic to a very high level. And I worked with, in Dr. Khasliwal's unit also. And I'm sure sir will understand how important it is to see the basic form. Unless and until, as Sandeep has said, if we don't pay attention to a newborn as soon as it is cried, please remember they are born with all 5 senses. They are more intelligent than you and I are, because even without talking, they can tell you how well they are or how sick they are, how they need your help. They can talk in the form of speech. They can talk in the form of smell. They love the mother smell, the horrible smell which we don't like, but they like the amniotic smell, and that's how they latch to the mother's breast. I hope and pray that all of you will continue with breastfeeding. You know all the advantages of it. And please remember, the baby grows not only with feeding. The baby loves the touch and the bond between the mother parents. And that is what we are now inculcating, the phenomena of mother and baby, or the family-centered care of newborn and follow-up of these babies. We have found to an extent of nearly stunting and wasting happening in the first 6 months of a baby's life. And I would request all of you, please try and see in your follow-up whether these babies are basically low-birthed, because you're all the time blaming them. I do not think a preterm baby will do so bad. If it was stable at birth, they grow beautifully, as good as a normal newborn baby does. A baby is born with a brain of practically 25% of yours and my brain. It is only how you stimulate them and how you take care and nurture them that they go well, and many of our doctors and even my teacher, Dr. Purandare, they were all low birth weight babies preterm, and they were geniuses, you know of Newton also. So please don't underestimate them, but it is for us to understand why they become, we blame the mother all the time, but I think we should blame us. The thing should fall on us because we don't nurture the mother when she's pregnant. She has mental stress. See, there are many factors which leads to low birth weight or preterm delivery. And all of us are working with newborn, and I'm 100% sure if you really look into that depth, take history and take the early part of it, follow them up, we'll come to know exactly what is happening. Thank you very much. And I really, from bottom of my heart, thank all of you. I have been associated with Solapur long time. I did my internship in this institute, not this institute, but I know Dr. Mehta was there, Dr. Karkhanis was there, and that time Dr. Vaishampayan's college was established, long way back. But Keur is there, Keur is my student, but let me tell you, it is not that a student is to be known by the teacher. It is, I would say that today, I mean, all of you are my teachers. And we learned from you all. We learned a lot. I learned a lot from whatever presentation was done. And I vow for it. If I have any problem, I ask Sandeep or I ask Rishikesh or Kishore. And they've always been very helpful to me. So I think each and every one of us should learn that there is a time we learn from our students. And so we should see that we inculcate that in them. Thank you ever so much.
Thank you, madam, for your word of wisdom. Thank you very much. We are ending this our conference here. Before that, I want to say a few words. I think this conference was very successful. So I would like to thank all my team as an organizing chairperson. I thank our senior advisory member, Dr. Kasliwal sir, Dr. P.T. Kulkarni sir, Sathe sir, Savaskar sir, Yajurvedi sir. I like to thank Tridev, Dr. Vikram, Dr. Sandeep and Dayanand. They have done a wonderful job. So big round of applause for them. Then Dr. Kundan Chopade as a president, with his good communicative skills, and he has done worked very hard for last 3 months. I thank Dr. Sunil Vaidya sir, president of our conference, for guiding us at each and every moment. I would like to thank a most important person who has done a difficult job, that is Dr. Nitin Rathi. He has managed the finance, reception, everything, along with Atul Zawar. And our 3 musketeers, Joint Secretary Keur, then Vinayak Ravankar and Mahesh Arkal. They have managed all the workshops also, and also they have managed other committees also in last 3 days. Then heart of the conference is a scientific session. And Dr. Vikram, then Samir, Rajeshri, Manisha, Anna, they have taken a very good care of our heart. So thank you very much. They have done an excellent job. Thank you for the scientific committee. Also Dr. Pratibha madam and Dr. Sachin Bandichode for managing the paper and poster session and workshop, Dr. Sudarshan Chakre and Sandeep Kade and Ashutosh Edurudi. They have done a fantastic job. Even for the printing, they have done taken a lot of efforts to do printing. And Monish has managed the hall and also the paper. He has worked for the poster presentation. If I'm missing someone, please tell me. And the last day's banquet was wonderful. All the credit goes to Anna Sahib. So kudos. Thank you very much. Thank you. And not to forget our PG students, they are the master of ceremony. They have done a wonderful job for last 2 days. Thank you very much.
3 cheers for state NNF.
Hip hip! Hooray! Hip hip! Hooray! Hip hip! Hooray! 3 cheers for Atul sir and Solapur IIP. Hip hip! Hooray! Hip hip! Hooray! Hip hip! Hooray! Thank you very much.
I now declare the conference is ended. We had a very nice time. We enjoyed all the faculties' talks, and it was a wonderful 2.5 days. So please proceed for the lunch. Thank you.